Good morning, everyone. It gives me immense pleasure to welcome you all to the fifth edition of ENTrain Workshop, which is going to be 2 days scientific fiesta on 26th and 27th. And to start off with, we have a really privilege and pleasure to have to giving us a message is none other than our beloved President of AOA, Dr. Bharti Madam. Though Dr. Bharti Madam does not require any introduction, but as a formality, I'll be doing so, but it's my privilege to do so. Dr. Bharti, current president of Association of Otolaryngology of India, senior professor and former head of Department of ENT, Head and Neck Services, JSS Medical College, which is attached to JSS Academy at Mysore. She has been awarded the prestigious BC Roy Award and has received Best Teacher Awards, and she has also honored with the Lifetime Achievement Award. And Madam is instrumental in developing first-time mobile app for testing hearing disability, which is called as JSS Shravan app. So it's our pleasure to have Madam's message. So over to Madam for her message, sir.
Dr. Krishna.
Welcome to you all on this cool Saturday morning for the 5th ENT workshop, which is being held at Bangalore and virtually presented throughout India. This ENTrain workshop is a brainchild of Dr. Deepak Haldipur, who started this program 5 years back along with Micro Knowledge Academy, and is executed and coordinated by Dr. Vishwas. Dr. Deepak Haldipur, you all know, is the director of Trustwell Hospital and a well-known otologist, rhinologist, and head and neck surgeon. He wanted all the young consultants and the postgraduates to learn the basics of ENT surgeries, and also the other senior consultants wanted to update their knowledge. So this ENTrain was started 5 years back, and this year, as usual, we have 2 days of workshop. The first day is the live surgery and the second day is the panel discussion. And throughout these 2 days, we have the topics covered are from the basic to the advanced, which will help all the ENT surgeons in their day-to-day practice, starting from otology, ear discharge, atocoantral type, or going to stapedectomy, which will be showcased by none other than Dr. Vijendra sir. And then we have Dr. Sanjay Agarwal, who is known for his endaural tympanoplasties. And then Dr. Deepak Haldipur will be showing endoscopic dacrocystorhinostomy, and followed by Dr. Vishwas, who will showcase the surgery of pediatric septoplasty. The second day, we have the discussions on various common topics like headache, facial pains, OSA, and what not to do and what to do in otological problem. With this brief note, I welcome you all to this 5th ENTrain workshop. Have a good 2 days academic feast. Thank you.
Thank you very much, Bharti Madam. It was really wonderful and pleasure for us to have your talk and setting the tone for the entire program. May I now request Mr. Durga Prasad, Vice President of Microlab Limited, to give his welcome note.
Yeah, thank you, Dr. Angela. Dear doctors, happy morning to all of you. At the outset, we at MicroEros would like to thank our mentor, Dr. Deepak Haldipur, Dr. Vishwas, Dr. Vijendra, Dr. Sanjay Agarwal. These eminent personalities will be on action today for the live surgery workshop. ENTrain is an live surgery academic initiative, workshop initiative by Micro Heroes. And this is entering the 5th year successfully with all your support and patronage. The choice of surgeries are always done with the involvement of all the doctors' feedback and presented to you today and tomorrow. As Bharati Madam mentioned, it is going to be a real feast for the entire ENT fraternity. We are going live in pan-India medical colleges, more than 25 centers, and 2,000 registrations are already done, which in detail Dr. Manjula will take it up. And it is a pleasure to invite you all for this 2 days academic feast. And I would like to make a small announcement that since all medical colleges are there, active medical colleges, which is going to have interactions and Q&A sessions, we will have a reward for those PG students. And this is an educational initiative by Micro. So we are working in ENT fraternity continuously for last 5 years, and we would like to make a mark more with such scientific academic initiatives. So I welcome you all for this 5th ENTrain program. Thank you. And Dr. Manjula, over to you. You're on mute.
Thank you very much, Mr. Durga Prasad, for a really refreshing word of welcome to all the delegates. Now, very briefly, I will be talking about Micro Knowledge Academy, which is doing this initiative. Which is a part of an initiative of Microlabs. We all know Microlab is a multifaceted healthcare organization with a state-of-art manufacturing facility, as well as it has an excellent R&D center, which is at par with international standard. And Microlab is the fastest growing transnational healthcare organization, and Microlab is present in more than 50 countries across of the world, including US, and several other European countries as well. So coming on to the Micro Knowledge Academy is an independent, non-commercial academy which is supporting educational and academic activities to address the unmet needs in therapy management. So Micro Knowledge Academy is committed to conceive, build and sustain programs and make scientific initiatives which are aimed at providing evidence-based update to healthcare professionals. We've been doing several activities under the aegis of Micro Academy. We have Fever Foundation dedicated for fever and infectious diseases. HFI is Hypertension Foundation of India for the hypertension and other cardiovascular diseases. And ADF is our academics in diabetic forum for a diabetologist. And PRIDE is for endocrinologist program. Regain is for the program for nephrologists. And we have an exclusive e-library for doctor, which has a lot of information, one-stop solution for the slides, guidelines, various curated content. All of you can access that e-library. It is a free access to all the doctors. A simple registration is required. Apart from that, nothing is there. Then we can maintain Hypertension Registry of India in association with Hypertension Society of India. So we are planning to start Dyslipidemia Society as registry, as well as glaucoma registry as well. Coming on to another important event, which is ENTrain, which I will be telling little in my next slide. Before I go to ENTrain, just want to say Micro Knowledge Academy also brings out a lot of books under Micro Knowledge Academy. So for all of you, the ENT surgeon, most of you, almost of you will receive the book called Current Concept of Otolaryngology. In case you have not received this book, you can go to the stall on the platform where you can download this book, and we are planning the next edition of the book after this conference is over. So by beginning of the next year, we should be getting the second edition of this book. So coming on to the ENTrain Workshop, it's another flagship program of Micro Knowledge Academy. It's ENTrain Workshop is an academic platform for clinicians to witness the live ENT surgery and interact with the leading expert. It provides an insight into surgical approaches and current challenges in ENT practice, which can be of substantial help for in day-to-day practice. Especially we want the youngster, especially postgraduate students and the young ENT surgeons to help from this activity. That's why we have an expert who will be giving you all the content and the surgical methodology, so that you will be having a extremely an important session today and tomorrow for your learning process. And ENTrain Workshop is conducted by renowned faculty across India at this point of time. This is, I must thank Dr. Deepak Haldipur sir, who has been instrumental in starting this activity as well as guiding us, mentoring us to conduct this activity. Hence, we have with the fifth edition, as well as Dr. Vijendra sir and Dr. Vishwas sir, whom we will be troubling. We are troubling almost every day basis when this has started. So thanks to all three of them helping us, and also Dr. Sanjay Agarwal sir, who has been supporting us in this activity. Now, just briefly about ENTrain. The first ENTrain we held in 2017, where we had 180 delegates across India. It was done in Bangalore. In 2018, we had 230 delegates, and we also had delegates coming from the Nepal. It was also held in Bangalore. ENTrain, the third version we had in 2019, we had more than 300 delegates. It was in association with Karnataka chapter of AVI. We got 3 credit hours for KMC. We had 6 live surgery, unique session on truth and secrets of private practice. In 2020, we have went to the virtual mode because of the COVID scenario. We had more than 1,500 delegates, 6 live surgery and panel discussion, instrumental session. This year, fifth edition, we are having is today and tomorrow, which is November 26th and 27th. The highlights of ENTrain fifth edition is we have 5 live surgeries from renowned surgeon, and we have 3 very, very important practical topics on panel discussion. We have also have certificate program instructional sessions, and this session is also accredited by Karnataka Medical Council. Just to give overview of the technological overview, we have state-of-art 3D platform technology, which all of you have seen when you enter this. And we have a camera view from OT using Vitam, Karlstad, Spice camera, endoscopy camera, microscopy camera, as well as external cameras. And live streaming done across several countries, not only across India. We have delegates joined from the international arena through their professional and social media handles as well. And I want to tell you also, happy to say that we have more than 2,000 registrations so far, and we are also live streaming in 26 satellite centers in medical college across India, where more than 600,000 doctors will be physically sitting, including important PGs who will be participating. As Mr. Durga Prasad announced, so we are having some reward for those postgraduate students who are asking some interesting and the unique question. Our a panel of experts will decide who has to be. So ask more questions to win the reward. So this is the platform. Just very briefly to the virtual platform. So when you enter the platform, you can enter into the live surgery auditorium. You can see right in the center. Then in the below you have audit. You can directly go to the auditorium, download a book, instructional session, and you have the brochure area where you can download the agenda. This is some of the features of 3D platform. And then when you enter into the download or the instructional session, you will be taking to this area where you can download the ENT book. If you have not received so far, please download it here. Current concept of otolaryngology volume 1. We will be coming out with the volume 2 as well. And you have 3 certificate programs here: an instructional session, swallowing assistant by Dr. Manju E. Isaac, and anaphylaxis by Dr. Gayatri Pandit, and position maneuver in vertigo for Dr. Srinivas DR. And this has already available, and you can go at your leisure and then attend the instructional session and get a certificate. So here you need to click to download the book. So this is the workshop line for today. So we have 5 surgeries today. Endoscopic DCR by Dr. Deepak Haldipur will be the first session. That is followed by we have Dr. Sanjay Agarwal performing the surgery on endoral tympanoplasty. Then followed by we have Dr. Vishwas sir doing pediatric septoplasty. Then Dr. Vijendra sir from his OT, which will be Dr. Deepak Haldipur sir and Sanjay Agarwal. It will be live stream from Nagpur, and Dr. Pediatric septoplasty from Trustwell Hospital, and Dr. Vijendra's ENT clinic. Dr. Vijendra sir would be conducting 2 surgery as tapidectomy and extensive aticolestoma with lateral semicircular canal and vestibular fissure. These are the surgeries which are lined up for you for the entire day. Tomorrow we have 3 panel discussion, tips and pearls of otology. Starting tomorrow session is starting at 10 o'clock, which is moderated by Dr. Jay Prakash Reddy. Then head and facial pain from 11 to 12 o'clock by Dr. Vipyan Mukherjee will be moderating the session. Then third is sleep and snoring disorder, moderated by Dr. Seema Sheikh, which starts from 12 to 1 o'clock. So, which I told about the retarded and the certificate course as well. So, it's been a really pleasure to hosting it. I'm sure you will enjoy this scientific fiesta. Once again, welcome to all. Enjoy all the scientific event which is going to be available for you today and tomorrow. Thank you very much. So now can we start the first session, first live surgery session? So we have pleasure and privilege to have Dr. Madhusudan Rao sir with us for this session. The session will be the endoscopic DCR. Can I have Dr. Madhusudan Rao? Sir, Dr. Madhusudan Rao is a well-known across the world, not only India. He's been known for various activities. One is surgery, other is his philanthropic work. Sir is a senior consultant ENT and head and neck surgery. He has a ENT super specialty hospital, Madhumani Nursing Home at Nandyal, Andhra Pradesh. He has contributed to numerous books, including book on chronic sinusitis, and he has conducted live surgery workshop every year, very popular live surgery workshop every year with pan-India delegates. And he is a founder member of a very unique cultural organization called Kalaradana. He has got very good interest in theatre art. He has performed at Nandi Natyotsavam in 2003, and he is running a Madhumani Charitable Trust since 1991. He is doing an exemplary work in various service activity to the society for health, education, sports, culture, graveyard, as well as personality development program. It's our pleasure and privilege to have sir with us, Dr. Madhusudan Rao. Welcome to the program. I now hand over the session to you to moderate the first live surgery program. Over to you, sir. Dr. Madhusudan Rao? Yeah.
Hello.
Yes, sir.
Able to home.
Yes, sir. We can hear you now, but in between it's going.
Visible as well as audible.
Yeah, sir. Your audio little problem is there. Maybe you are visible, but audio maybe internet issue.
My side,
yes.
Maybe there's a lag in sir's video.
Manjula, good morning. Am I able to?
Yes, sir. Good morning. It's going. Internet must be an issue there, sir. Network issue. It's your voice is coming and going off.
My side, internet, I mean, signal strength is perfectly all right.
Okay. Dinesh Paul's team, is there an issue?
Yeah, now we can hear you, sir, clearly. You can
Yeah.
start.
I just introduce my good friend, Dr. Deepak Haldipur, which is on the screen now. It's really a pleasure for me because my first meeting with Deepak Haldipur is a car collision in Chitradurga about 22 or 23 years back when we were attending, and accidentally I have caused damage to his car. Suddenly, who is this person? Then I met with Deepak Haldipur, and since then I can proudly say for the past 15 years he is coming as a faculty surgeon to serve my free ENT camps pan-India in Nandyal, a small place in Andhra Pradesh. Deepak, you are a senior ENT consultant, Director for Trust Well Hospital, Bangalore, a multi-speciality, wonderful service hospital. And more important is, he is our past president of ENT Association of India. His areas of interest are skull-base, endoscopic, microscopic, and endoscopic lacrimal surgery and thyroid. Written various articles on otology, endoscopic surgery, published many articles in most prestigious journals. Chief faculty in live surgical demonstration at various centers across India. Innumerable lectures in wide-ranging topics in otolaryngology, head and neck surgery, in various conferences and workshops. And Deepak Haldipur, I am very confident he will give you a surgical feast regarding dacrocystorhinostomy today. Over to you, Manjula.
Thank you very much, sir. It was really wonderful of you to introduce your close friend and set the ball rolling. Is OT?
Yeah.
Hello.
Yes, sir. Over to
Good
OT.
morning, everybody.
Hmm.
Can you hear me, madam?
Yes, sir. We can hear you,
Yeah.
sir.
Madam, I will be welcome to you all from our Nagpur OT, Dr. Nandu Kolwadkar ENT Hospital, and we'll be performing our first case. I will be giving a brief history of the patient. CT scan will be read by Dr. Deepak Haldipurkar, and this is a 33-year female housewife. She has no other complaints except running of nose and stuffy nose of nose gradually increasing since last 1 year. No other complaints. On clinical examination, there is a huge mass in the left nasal cavity occupying the whole of the nasal cavity. And throat examination, there is a mass protruding in the oropharynx. It's more on the left side. Rest all are normal. The DNA picture are not available because the patient came to me evening in the OT. CT scan, a large lobulated mass in maxillary sinus extension in the nasal cavity, protruding in nasopharynx with widening of the ostium and DNS on the right side. For further CT scan reading, I will be handing over the mic to Dr. Deepak. So please stay online. Thank you.
Mic on. Hello.
Yes, sir. Good morning,
Yes, sir.
sir.
Morning, sir.
Can you hear me?
Yes, sir. We can hear you, sir.
Baga Expo.
Hello. Yeah, good morning, everybody.
Morning, sir.
As usual, we are into the 5th ENTrain workshop. And we were, trying to work out the details. And then originally we had planned.
So your voice is slightly feeble.
Yeah, let me see. Audio.
Voice is slightly, I think.
Audio.
Kindly adjust search mic.
Yeah, mic.
Gajanan.
Yeah, I'll do that. Mic adjust karna na, mic ka. Can you hear me now?
Yes, sir. We
Hello.
can hear you, sir. Slightly can position towards your ear.
Yeah, I don't know. I think the audio people have to do it. अरे आवाज weak बोल रहे हैं ना रे? हाँ. Sponge करो. Now you can hear me?
Yes, sir. Slightly better.
Slightly better is not a good thing. Tell me when it is normal, otherwise we'll tell the audio visual guys.
We can hear you, sir.
Huh?
We can hear you now. Manjula madam, is it okay?
Now you can
Dr.
hear?
Madhusudan Rao, sir. Okay, na, sir? Madhusudan Rao, sir.
I am able to hear.
Yeah.
Yes, sir.
No problem. I am also.
Madam, Manjula madam, basically the problem is
I am able to hear.
Yes, sir.
No problem.
I don't have a booming voice like Madhu.
No. Deepak Saab, namaste.
See, never make the mistake of comparing me to Madhu. And, he's like, Prabhas. So, we can't compare ourselves to him. Are you getting the endoscopic picture also?
Yes, sir.
Yes, sir.
Yeah. I'm just packing the nose right now. Let's go towards the CT scan. There's a small story. In fact, surgical demonstration is all about storytelling. So, Actually, Madhu, we were supposed to do this program on the 19th and 20th of this month.
Okay.
Then we suddenly realized that Dr. Morwani sir's 75th birthday,
Oh,
the program was on 19th and 20th. And, as we all know, in this part of in fact, the entire country,
okay.
Morwani sir is a highly respected senior ENT consultant, a good friend of Dr. Madhavaya. So,
Okay.
in respect to him, we suddenly decided to shift the program by 1 week. The following I was supposed to demonstrate from Bangalore. I had to shift to Nagpur because I also had an invite to give a keynote talk in the HNS Academy by my dear friend Nandu Kolwadkar. But Nandu was so magnanimous that suddenly when I requested him that can I demonstrate from your OT, he said no problem. And we had 3 cases. The only problem was we couldn't get a DCR case. So we had this case where, mild AFRS, but mainly an antroconal polyp. We had one more inverted papilloma. And we had one ethmoidal polyposis. Out of which Satish Jain yesterday in the academy showed the inverted papilloma. My endoscopic guru has taught me so much. So I think I'll straight away go into reading the CT scan. Madhu, I'm quite audible, no? There is no problem?
No problem. For me, I am able to clearly hear your voice.
Yes,
No,
yes. Then if you hear, I will take it as the whole world is hearing.
Yes, sir.
Salam, sir.
Let's go to the CT scan. See, again, this as the doctor introduced, there is no disc. And the only thing that's available here is a film. But then usually in most of the operation theaters across India, this is what we get. In fact, I love to demonstrate to a common ENT surgeon in a small place with minimal setup. If you can notice here, there are some axial views. In this, I would like to highlight. See, I'll touch upon the basic points which we look at whenever we go anywhere. You can see the frontals here. There's the interfrontal septal cell here. And both the frontal sinuses are pneumatized well. You can also see the supraorbital cell. This is the axial view. And in the axial view, after the good amount of steroids that have been given, most of the edema and other sinuses has disappeared and we are left with a huge polyp involving the maxillary sinus with minimal mucosal thickening in other sinuses. Anyway, we never look at the pathology. In fact, as a surgeon, you would always like to look at the anatomy. So let us go to the coronal views. Now, when you see the direct coronal view, which is a surgeon's view, you can see that the left frontal is bigger than the right. There could be an interfrontal cell or a partition in the center. Now, as we go behind, you can see a high deviation of the septum to the right side. And the next cut from the beak, you can see the frontal beak here. And from that, the next 5 mm cut, the beak has disappeared. You can also notice that between this cut and this cut, the maxillary sinus has appeared. You can see a small glimpse of maxillary sinus here, which means what cell we are seeing here is the supraorbital cell. This is the frontal sinus. The moment the beak disappears, and you can see a supraorbital cell here on the left as well as right, fairly well pneumatized. As we go behind, we see the coning of the orbit or the appearance of a nipple, what is known as Kennedy's nipple, which is named after Sir David Kennedy. Now, this is the globe. You can see the medial rectus here, the superior rectus here, and the superior oblique muscle. The confluence of the superior oblique with the medial rectus, you can see the anterior ethmoid artery coming here. And it is not exactly running on the skull base. It is a little at a lower level, probably on a mesentery. The films are really, the cuts are very far off, but it's okay. As I keep telling this, This is what an average ENT surgeon is going to get, unless you get a disc, which you can put on radiant DICOM viewer and get 0.5 millimeter cuts and in a dynamic picture. So as we go behind, you see the W of the skull base gradually is becoming a shallow W. And now you can suddenly see a thick bone here, which means we have moved from the anterior ethmoid to the posterior ethmoid. So here we are in the posterior ethmoids. The cells are a lot bigger. You can see the two superior turbinates. You can see the orbits have become smaller and the maxillary sinuses start becoming oval in shape. And you can see the disease here, which is widening the meatus here. So from the posterior ethmoid, you then move to the sphenoid. When do you know that you have moved to the sphenoid? When the septum starts bifurcating and when you see the borders of the choana, you can see both the sphenoids roughly equal in size. Of course, the left one is a little smaller and right one is a little bigger. So for me, at the end of the day, when I look at a routine scan, whenever I do FES, whether it is antroconal polyp, whether it is AFRS, the salient features I see, first, number one, you need to be sure whether both the frontal sinuses are present. Many times you can find one of the frontal sinuses is agenetic or aplastic. Then you are trying to search for a sinus which is non-existent. You're likely to cause a CSF leak. The second point I always see is how is the higher part of the septum, which I showed here in this cut, to see which side is a deviation, which side do we need to operate. Fortunately for me, here I'm operating on the left side. The third thing that I see is whether the lamina papricia is intact. It is. The fourth thing I see is the anterior ethmoid artery. Is it running on the skull base or hanging on a mesentery? Here it appears that it is running below skull base, which means we might have a well-developed supraorbital cell. The next thing I see is the septum. The septum in the middle part and the lower part is deviated away from the side in which I am likely to operate. And then I go for the posterior ethmoid. It's very important for the beginners to know the cut of transition between the anterior ethmoid to posterior ethmoid. As I keep harping the 5 salient points there, the skull base becomes thicker. Instead of being a W, it becomes a gentle flat U. And you can see the spacious ethmoidal cells. The middle turbinate curls and attaches itself to the lateral wall. The orbits become smaller. The maxillary sinus becomes ovoid in shape. And from there, the transition from posterior ethmoid to the sphenoid, I always like to look if there's any onodi cell. And if there's no onodi cell, and I also want to look at the pneumatization of the sphenoid. So this is my summary. And one important thing, occasionally, rarely, I don't advocate this, occasionally it so happens a patient coming from outstation or wherever, you suddenly realize the patient has not got a CT scan. In some rare situations, you find that you've already induced the patient and you don't have a CT scan. You can at least ask for a regular PNS X-ray. Make sure the pneumatization of the sphenoid and the frontal, if both are pneumatized, you can still go ahead and do a safe FES. But you have to assume very clearly that in the sphenoid there's a onodi. You have to assume that the carotid is dehiscent. You have to assume that the optic nerve is dehiscent and go ahead and operate. Then you can be doing it safely. Though today to do a FES, quality FES, CT scan is absolutely mandatory. With this small reading of the CT PNS, I would like to go ahead with today's case. And I'm really sorry we couldn't give you the DCR which we were supposed to give you, but these were organizational issues. We had to. I'm extremely grateful to Dr. Nandu Kolwadkar because he could pitch in the last minute because of our 1 week postponement. And that is what great friendships are made of, you know, where I could just request him. And here I am doing my own program from Nagpur, from Nandu Kolwadkar's OT. You got the picture? Are you getting the endoscopic picture?
Yes, sir.
Hello?
Yes, sir. Yes, sir. It's
Yes.
coming.
Yes. Madhu? Who are the moderators for this?
Yes, I am the moderator and I have read and followed your CT scan.
Arey, PJ Chandigarh wala, what you will follow my CT scan?
No, 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 no.
Your CT scan.
No, no, your simple words without any ultra modern facilities. If you
Yes.
come across a case, even if you don't have a CT scan,
Section.
how to go ahead? Such a description very rare.
Debrider
And
ka section.
I think it's a wonderful, basic, fundamental first surgery which
Yeah.
can any person has to do. And see the debrider, the marvelous
Shift kar lo.
equipment,
Shift kar.
just like what you use in the kitchen. I always compare it with the coconut drooling small bits of coconut for your chutney. The same way the polyp is being made in small bits. I think this is a straight 4 mm tri-cut micro debrider blade. See how the surgeon is making use of his maneuverability, exposing the cutting surface towards the pathology and not touching the mucosal surface, which is having a guard, so that the posterior or back part of the tri-cut blade is half open with a vibrating or oscillating blade. Posterior part is a protector, guard like Bahubali, so that the mucosal surface should not be damaged. You all know the mucosal sparing effect is the key mark of functional endoscopic sinus surgery. The trauma to the mucosa should be as less as possible, so that post-operative healing with wonderful mucosalization will be there. And I think handover, I can, sir, surgeon, sir, you can speak. Is audio connected to the operating surgeon, Deepak?
Yes.
Yeah.
No, the master was describing, so I just kept quiet. The whole endeavor, as you said, is to keep the debrider, using it in such a way that I
Yes.
don't touch the, mucosal surface as much as possible.
Yes.
Because if I don't touch the normal healthy mucosa, then the bleeding is going to be less.
Very less. Yes.
Yeah.
Don't be in hurry. What Deepak always prefers, take your time. Go
Yeah.
by millimeter.
So here again, you see the gate. You can make the debrider rest on the inferior turbinate and then keep on debriding,
I think now the separation will come between the
Yes.
choanal hanging part and the antral part.
Yes.
Super. Very nice separation of the pedicle, constricted pedicle between the choanal and maxillary antral polyp, so
Yes.
that he move the choanal part.
Yes.
मंदी का तो जो भी नहीं
Straight grasper. Yeah. Sponge. Sometimes the posterior part can be really, really big. Debrider.
Chest.
Yeah.
Yeah, now the total separation, I think,
Yes.
happens, he suddenly falls down.
Yes. Now let me just take a look from the other side about how big the polyp is actually. Sponge.
So you want to see oropharyngeal exam.
Yes, yes, yes. From the other nostril, I would like to just take a look. You know about where it is or whatever. Yes. In the meanwhile, Dr. Sanjay Agarwal is getting ready with this case of endoral tympanoplasty. Madhu, whenever we conduct a course, we actually first send a, form to the delegates to ask them what would they like to see.
Okay.
And we found that there was a lot of demand for this endoral tympanoplasty.
Endoral tympanoplasty, yes.
Yes. SMR elevator. Now at this point, I would like to see whether I can out fracture the posterior end or the shoulder of the inferior turbinate for better visualization of the
7.5.
yeah.
No, it is 7.5.
Pressing forceps. Let us just take a look at the other nostril. You can see the spur there. SMR elevator. Yeah, the polyp is here.
లోపల నుంచి మేము కూర్చున్నాం ఆ కూర్చోడం వల్ల గరుకు
SMR elevator.
లోపల పోవడం లేదు కాబట్టి ఎటువంటి పరిస్థితి కొద్దిగా పక్కు పేరుకుపోయింది రాత్రి ఫస్ట్
Hello.
హలో
Some disturbance, we are hearing some other.
No, sorry.
Okay. Madhu,
Yes.
you can see the same polyp on this side.
Yeah, that's almost occupying.
Yeah. It's a bigger coronal component.
Yeah, nasopharyngeal total
Yes.
obstruction.
Yes.
What I am interested is, can you remove nasally through the anterior?
Yeah. I think we can debride it, make it really smaller,
Okay.
and then probably take it out. Bipolar idea. Yes. Dressing forceps.
ఒక తీసుకురండి ఒక సిరంజ్ ఒక నార్మల్ సెలైన్ ఒక చిన్న ప్రతి చిన్నదానికి అసలు ఎవరికి రాకుండా ఉంటున్నారు అందరు
Debrider. Talk. Oh. Acha. Mara is enough.
Deepak, you want to debulk it?
Yeah.
For getting some negotiation to the constricted nasopharynx.
Yeah, because I don't think it will deliver otherwise, sir. Otherwise, I have to take it out from the mouth.
Okay.
So, let us see.
Yes. Okay.
How much ever I can debride without damaging the adjacent structures. I'll try to do that.
I mean, you always do like this, or rather push down into the oral cavity, put a tongue
No,
depressor or
that can
something.
also be done. That can also be done.
Okay.
It will save you time.
Yes, yes. But I think you want to show how such a big antrocranial
See, when you're
delivered
a high volume surgeon like
to the
Madhusudan Rao,
Wow.
then you need to save on your time.
Yeah,
Because in the morning you have a huge caseload to do. If you are like Deepak Haldipur, the occasional operator,
See,
then
I'm no way compared to Dr. Deepak Haldipur in the volume of work and the meticulous surgical skills.
no, sir. See, as long as you remain within the substance of the polyp, I think the whole trick is that, isn't it?
Yes, yes.
I should be grateful to Dr. Devendra Mahore, who sent this case in the last minute. But then whatever it is, I have no regrets because Morwani sir is such a great senior surgeon that when they were celebrating his 75th birthday, it would not be correct on our part to be doing the workshop simultaneously on the same dates. No? State grasper. So the other advantage of this thing is that you can take out the polyp for histopathology as well. Yeah,
We
Madhu
need
was
a
right.
bigger forceps to catch bulk of the polyp mass.
Yes, sir. Yes, sir. No, the corneal component appears to be really, really big.
Really big, really big.
Yeah, I
Almost.
just said the more sensible approach would have been.
No. Delegates or participants will have the ability or way to see how a dual manipulation through how you can debulk and make it less in size and pull it, or otherwise how you can remove
Yes,
transoral.
yes, sir.
Jelly. Jelly.
Straight grasper.
Can a 45 or 90 bent grasping forceps will catch hold of more?
Yeah. The whole idea is that we need to reduce it just a little bit more.
Yes.
We are almost there, like,
Yes.
yeah. And again,
Two jellies.
I can see the anesthetist pack. Straight grasper or 45 degrees. 45 degrees sweet ko. Yes. So the whole part came out. If you notice, Madhu,
Sir.
if we don't do any touching of the mucosa,
Okay.
look at how the field looks now.
Even it looks like a mini fest. Somebody has removed bulla ethmoidalis.
Yes, yes, yes.
And there is some adhesive band there.
Ball probe. Yes.
Is it a revision or it's a virgin case?
Sir?
Is it a revision or a virgin case?
It's a virgin case, sir.
Okay, okay, right. Now you are expanding infundibulotomy.
Yes, yes, yes.
In the natural process of coming out by itself, it causes pressure expansion.
Yes.
So naturally, the middle meatal antrostomy opening will be widened than natural.
Yes. Now I am changing over to the 40 rad
Okay.
section.
So you want to expand or remove the uncinate up to the anterior border of lacrimal crest. That is the maximum antero-posterior.
Yes.
Middle meatal antrostomy dimensions are anteriorly the lacrimal duct crest, posteriorly the posterior wall of macularis sinus, lower shoulder of inferior turbinate, and top almost sinus.
0 degree hakama first. $30 scope ಮತ್ತೆ 70 degree ಎಲ್ರಿ ಇಟ್ಕೋ. They are just about cleaning up the 40 degree blade which was blocked. So little limited dissection I have done with the 0 degree. I will try to take an angular view. Ball probe. Manu. Ball probe. So it is better that we go flush up to bone punch. The posterior wall, if you can make it flush, you know, the antrostomy goes flush up to the posterior wall, nothing like it. And second, as I keep on telling in my demonstrations, I like to always expose the maxillary sinus up to its maximum limits, you know. So that way your instrumentation within the sinus becomes easier. And this is a very safe instrument. Operator? Yes. What if a degree?
You are still with 0 degrees?
Yes, Z with 0 only, even now.
Yes, yes.
Again, this is another point I tell the beginners.
Yes.
It is better they, you know, stick to 0 as much as possible.
Okay.
And then in critical areas, go for an angled scope.
Right.
because that way the distortion of anatomy doesn't happen.
Very good concept.
Grasper, the landmarks, yeah, straight grasper.
But the
And
only thing is in AC polyp, you should know the attachment from where the maxillary sinus, upper zygomatic features floor. For that, I think you have to show to the delegates with 70 degrees.
Yes.
Inner pedicle attachment,
Yes.
polyp arising surface. Okay.
Sponge. So right now with 0, whatever I can widen, I have done it. Now 40-degree blade ready na? This is correct. I'm widening the antrostomy to the maximum without trying to damage the nasolacrimal duct. Ball probe. Now we will probably go for a 70-degree Madhu, and we will try to visualize whatever we can.
Yes.
45-degree forceps. I am still with 0 degree debrider, 40-degree blade. Blade ಮತ್ತೆ ಬ್ಲಾಕ್ ಆಗಿದೆ ನೋಡ. Straight grasper. Straight Blakes sleeve. Wash. Wash. Straight needle ಕೊಡು first. Straight needle. I'm just giving a little bit of an irrigation. I'll also try to wash the sinus. ಈಗ ಕರುಡ ಸೀದಾಕ್ಬಿಟ್ಟು ವಾಶ್ ಕೊಡು. Simple wash ಕೊಡು. Yes.
If anybody wants to use a curved debrider blade and they want to use only one curved blade because of economy in my hospital, which you will either 60 or 40.
If you are using single, you can use 60.
Yes, this work can also be done with 60.
Maneuverability, only thing is 60, you must learn how to maneuver, especially when you're working on the lateral wall.
100%.
Otherwise, on the roof, yes, 60 works wonderfully well.
Yes.
In this direction, 60 works wonderfully well, you know.
Right.
There is no problem with this. Let me debride a little bit more. Wash. Ready? Yes. The reducing of the recurrence, one thing is we need to go to the root of the polyp. And once you remove the root, if it is possible, if you can cauterize the lymphatics around it.
Everybody is interested how you are going to make a negative or a neutralizing non-polypogenic mucosa from the attachment.
Yes.
The pedicle from which mucosa it is arising.
Debrider.
Even if you leave, even after 90% removal, and that 2% of pedicle can cause recurrence.
एंट्रोकल पॉलिप है. साइनस में अभी भी है 70 डाल के 70 डिग्री डाल के देखता हूँ. मनो ಎಲ್ಲ ಸೆಕ್ಷನ್ ಆನ್ ಮಾಡ್ಸ. So I'm trying to get the widest possible opening. See, this is how much you can do maximum.
Yes.
With 0.
I think you have done 99, not only 99, can consider as 100% of the maximum available space of a middle meatal antrostomy.
Yes.
The posterior bony boundary, how nicely it is seen.
Yes.
The posterior maxillary surface with a small, and anterior the lacrimal crest. And superiorly, you will have the axilla where it becomes,
Yes.
and down turbinate shoulder.
Yes, sir. Now I have a wide axis. Let me see. Sponge. -70° scope it go.
So you are using a small cubical Merocell cut pieces.
Yes. And you are the inventor of the Indian Mirocell.
Yeah. I use
Which you would use, no?
for
Which
all.
you use in your free camps,
Yes.
which you do year after year at Nandyala.
Yes.
70° scope. 60° blade ಹಾಕು ಆಮೇಲೆ 120 ಇದ್ರೆ 128. I think, Madhu, that seems to be the attachment there. If we can see, curved section haku. So what we can do is the trick shown to us by Dr. Sethi.
Sir.
You remember?
Yes.
You go like this in your antral wash area, where you do the antral wash. You can go like that, maybe even a little posterior.
Okay.
So that you have an access for your debrider blade to go there and take away this attachment. Probably, maybe I may have to sacrifice the inferior turbinate a little bit in this case, because the attachment seems to be really anterior, bipolar.
So you want to debride the posterior part of inferior turbinate?
Yes. Probably turbinectomy scissor it go.
Okay.
Yes. 0° kodu. The other thing one can also do for this is the pre-lacrimal approach. That also.
Pre-lacrimal approach to know the attachment of maxillary sinus?
No, basically so that you get a good view.
Okay.
Bipolar.
And in this juncture, I would like to give a small my concept.
Yes.
Within a 70 degrees and 120-degree angle debrider,
Yes.
majority of the inner surface of the maxillary sinus can be seen.
Yes.
Usually be manipulatable. The way the 120 degrees goes onto the roof of.
But I have a feeling.
Sir.
That in this case, the attachment is more towards the anterolateral wall, Madhu.
Oh, anterolateral wall, nothing to be.
Yes, it is difficult. Yeah.
Yes. Now see the small bit of inferior turbinate he has removed,
yes.
which exposes
yeah.
anterior inferior surface.
And second thing is, if I stay below the inferior turbinate,
Yes,
I won't be damaging the nasolacrimal duct as well.
100%.
Because
100%.
Ashner's wall is much above
Yes.
ball probe.
This step at this juncture is to be nurtured by all the participants who are seeing. See now
Yes.
how still he is using a ball probe and removing that small pedicle of bone of the antero-inferior surface of the maxillary sinus.
Yes, sir.
The 2 millimeters of removal increases a wider scope of visibility of the inner anterolateral surface. You will see the tamasha after using a 70 degree.
Yes. 60 beta 40. So as long as I stay below the attachment of the inferior turbinate and don't go into the roof, my Ashner's valve is safe, So,
yes.
And again, this can be easily done by any average ENT surgeon
Okay.
in his average setup,
Yes.
with a regular set of instruments, SMR elevator.
Our workshop is coined like that, entire basics, ENT, IER, so that all these sort of procedures will be demonstrated.
Yes.
Yes, see that small inferior, from the shoulder of inferior turbinate, that bone is going to the floor of the palate, hard palate. That projection of bone.
Yes.
What a wonderful demonstration. Very nice.
And see, I am moving my nasolacrimal area and I don't find any movement there. Debrider.
Okay.
Which means I think we have an adequate exposure now. Yes. Straight grasper. Sanjay Saab is ready. Yes. Bipolar. Just the stump of the bipolar. You can cauterize. See this end of the inferior turbinate.
Yes.
Cauterize this.
Cauterize with bipolar.
Yes.
For as a preventive measure of post-operative reactionary bleeding.
Yes, yes, hemorrhage, So
yes.
Now dressing forceps.
What is the blood pressure, Deepak?
What is the
blood pressure?
76 by 43.
Wow. If something for 76 by 43.
See the attachment, Madhu, with 0 what I'm able to see now.
Yes.
With 0, I'm able to see this attachment. Now I'll go with a 70.
Yes.
See, that is the attachment. A small ribbon goes kodama, Wash. Curved needle hako. And this antroconal polyp, despite the best of the efforts, is notorious for its recurrence.
Yes.
No? Yeah.
Yes.
Wash.
The crux of this surgery is removal of polypogenic mucosal surface from the attachment. That is the key point for the success.
Yes. Straight suction. Okay. संजय साहब वॉश करो साहब, वॉश करो ना, इंजेक्शन हाँ दे दो, दे दो, देख ओके, लेट हिम, ही कैन नो. अच्छा पैक, यस, और 15 मिनट में रिबन को हस्कोड़ो. ಮೊನೊಪೊಲರ್ ಇದೆಯಾ ನಮ್ಮ ತರ, ನಮ್ದು ಇದೆಯಲ್ಲ ಆ ತರದ್ದು. ಓಕೆ, 70-degree scope. So probably we'll go for the final assault.
Yes.
And let me use the 40 rad blade initially and then the 60. My dearest friend Sanjay Agarwal is ready with his case. He wants to demonstrate the local infiltration.
Now the overhead camera is there. Just show a shot of pulse oximeter. Okay, nice. Just go ahead. Thank you. No problem.
Yeah.
Sanjay wants to show the local infiltration.
Yes. Sanjay, you can show it with that camera, no? दिखा दो ना तब तक. Yeah. Oh, straight grasp.
Want to show the infiltration points, or at this stage is it necessary?
Yes. No, I think anyway, one thing I know about Sanjay, he is one fast real-time surgeon. Once he starts,
Yes.
he will polish it off within no time.
Yes.
All debrider, please.
See, that must be about 4 to 5 millimeters of real pedicle of the antral mucosa. This is at the posterior surface of the maxillary sinus towards the floor.
Yes. 120 ಇದೆಯಾ? Huh? No, 120 ಇರ್ಬೇಕು ನೋಡು, ಎಲ್ಲ ಇರುತ್ತೆ. There is a small bit there. Now 120 blade है क्या नंदू? Okay, गूंज दिया. $120 ब्लेड है क्या, देखो यार. डिब्राइडर कोड. Huh?
The 120
yesterday during demo, 120 is broken, Madhu.
During demo. How come? I mean, the angled force on the shoulder of the 120 bend has broken?
Yes. Our master Satish Jain used it yesterday. It is broken. He's my teacher. I cannot blame him.
In what case? What is the case of usage of 120
he was demonstrating for the academy yesterday. The academy event was there. Bipolar cautery idella. Inverted papilloma revision he was demonstrating.
Okay.
Anyway, let us see. We'll do the Indian jugaad. Yes. Now, that is the last bit of the attachment. Guj koda.
Yes.
Section. Good. Yes. Ah. 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 ಜ್ವರ ಬಡಿಬೇಕನ್ಸುತ್ತೆ ಒಂದು ನಿಮಿಷ. Okay. Very good.
You made a imprint of the cutting borders.
Yes.
Then you are removing. What's the
Yes.
osteotome or boost and what the size of this?
Yes.
Is the tip has a U-shaped bend or?
Yes. This is not a U-shaped bend, it's a straight gouge only.
Yeah, it's a straight gouge. What all else can be used? You can use a skull-based drill also.
Yeah, you can use the drill actually, that
Yes.
Medtronic drill. Gouge. 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 Yes. 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 Suction. Again, these things appear crude. If you have a Medtronic drill, you can, but then how many of the average surgeons across the country can afford a Medtronic drill, isn't it?
It's a, I mean, highly economically
Straight grasper.
priced equipment.
Yes. What pedigree forceps? ಇದು ಮೊನೋಪೋಲಾರ್ ಬೆಂಡ್ ಮಾಡಿ ಇಟ್ಕೊಂಡಿದ್ಯಾ? ಅದು ಆಗಲ್ವಾ? ಡಿಬ್ರೈಡರ್? T next to 16 ಇಟ್ಕೋ. ಕರ್ವ್ಡ್ ಮೊನೋಪೋಲಾರ್ ಸೆಕ್ಷನ್ ಕಾಟ್ರಿ ಇದೆಯಾ ನೋಡು. $60 ಬ್ಲೇಡ್ ಕೊಡಿ ಈಗ. I'm really missing my 120 blade, Madhu.
Wow.
It would have been child's play for me.
Yes, yes, yes.
With that, you know.
Yes. We are also fans of 120 blade. My son Manideep has a very special maneuverable technique of using 120 blade.
Yes.
Introduction and how it can be used with maximum visibility and surface malleability.
Yes. ಇದು DNC ಕ್ಯೂರೇಟ್ ತರ ಇದೆಯಾ? ಜೆ ಕ್ಯೂರೇಟ್ ಉಪಯೋಗ ಆಗಲ್ಲ ರಾಜ. There is, I think, still a small bit maybe, but this looks like a normal.
Bony curved bend must be the posterior
I'm
maxillary.
almost able to see the anterior wall now.
Yes, yes, yes.
But maybe, you know, gooch kodu.
Can any cobbler wand can
Drill
be
ಇದೆಯಾ ಅವ್ರ ಹತ್ರ ನೋಡು?
calculate?
Metronic drill boss?
Not only drill, to use the wonderful surface
Drill,
cutting,
drill.
the cobbler wand. The cautery mode of cobbler wand touching the
नहीं है?
poly.
Sure. Cortical elevator kodu.
Deepak,
Yes, boss.
now I would like to ask one or two questions and your way of dealing. Suppose the pedicle is the
Ear surgery का drill है क्या? वही दे दो. कुछ शीत कवर कुछ है तो एक थोड़ा सा. Yes, Madhu, your question. Sorry. I'm
Yeah,
just
no
taking the
problem.
instrument.
If this pedicle is arising from the lowest part of canine fossa
Yes.
and lowest part of medial wall of maxillary sinus and canine fossa junction and highly pneumatized zygomatic recess, these 3 points
I can go with
far away.
the canine fossa approach in that case, no?
Okay,
I
okay,
can put
yes,
the
yes.
debrider in the canine fossa, which is what I'm going to do now. Having done all the hard work here, I just
Yes.
don't want to miss out on the last part. So
Yes.
let's see. I don't have access to Medtronic drill, but would switch ka hai? Ready? I'm using a contra-angle ear drill, Madhu.
Yes, yes, I'm able to see the beauty of that maximum utilization of available resources.
Yes.
So contra angle ear. If overhead camera is there, can somebody show the drill handpiece how you are holding? It will be of lot of
Yes.
use.
Yes. Wash. The wash kudu. Yeah, almost I think our exposure is complete. I really enjoyed this demo. Initially, I was a little bored, this was antroconal polyp. But now I realize wash, suction. Yeah. Yeah. Debrider. 40-degree haku first. Because this is notorious for its recurrence.
Yes.
Yeah. That is the problem. Yes. Yes. This is 70-degree I'm seeing now. Now you give me the idapa. Ade kodu. 40-degree kodu first, ಆಮೇಲೆ 60-degree kodu. Yes, Madhu, now I could clean up the whole thing.
Wonderful.
Yes.
My small addition
Yes.
at this stage is the various modalities
Third section.
to nullify the effect of polygenic mucosa. Number one, as he has used the debrider and totally debride the mucosa.
Yes.
Number two, you have to use a cautery.
Action block agide.
Make it
I
a
would have loved to use a curved cautery. Curved cautery,
that's what I am just thinking of. showing the curved cautery. Sometimes unipolar ball probe cauteries are there.
I don't have a
40
curved
millimeters
cautery.
cautery probe tip will be there.
Yes.
And so that surface gets, but
No, I've
it's not
ensured that it is completely denuded.
yes,
I don't
denuded.
have access to the curved cautery here. But
Okay,
still,
okay.
to be honest, I must confess that I'm
Yes.
very happy with the exposure now. I can see the bare bone. I can see the dental
Yes.
root also there on the top.
100% there is no chance of recurrence, but for discussion for the delegates.
No, it is correct. I
putting
would have
for-
loved to finish it off with that, this thing. But anyway, the great Indian Jugaad with available instruments, I've been able to reach most of the areas now. See, because
Yes.
of the exposure, I'm able to go down to the bare bone.
4 to
completely.
5
The remaining
millimeters all
margin
around the
yeah,
4 to 5 millimeters all around the pedicle is now totally
Yes.
denuded and bony surface is exposed.
yes. You can see very, very clearly the attachment has been removed in toto. Sanjay Saab, please go ahead. I'm quite happy with this, Madhu, actually. I
Yes,
can
yes,
feel
I
the
am
bone
very happy.
completely. Of course, if I had a curved cautery monopolar, which is
Yes.
my favorite instrument back in Bangalore, where, but see, all said and done, Nandu has been so kind. And again, special thanks to Dr. Devendra Mohare for providing
Okay.
places for this demo. And of course, thanks to Micro ENTrain, yes. Yes, Shailesh Kothalkar. Yes.
It's 100% perfect management of
Yes, sir.
integral. The
Yes, sir.
beauty of your surgical maneuver, Deepak, the
Yes.
anterior wall of the bone
Yes.
of maxillary sinus
And
MMA.
remember, this is one thing that I want the beginners to realize. They should stay below the attachment of the inferior turbinate.
Yes.
Keep the anterior part of the inferior turbinate as a landmark because the Hashner's valve opens
Yes.
at the roof of the inferior meatus. So if you can notice, when I put a pressure on the NLD, nothing is moving here.
Okay.
I can show it with a 70-degree scope. The only complication in this surgery usually is damage to the nasolacrimal duct. So, wash. I mean, it was really, I enjoyed doing this case because, again, as I keep on harping, for an average surgeon, you realize today all that you require is a ear drill, a gouge and hammer, and
Yes.
with a 0-degree scope and a 70-degree scope, with blades of 40 and 60, even if RAD 120 is not available, you can still do a reasonably safe job.
The beauty of your surgical maneuver, Deepak Haldipur,
Yes.
all the instruments you have used is available even with the beginner.
Yeah.
All the instruments you have used are available with a beginner, Deepak. That is more
Yes.
important.
Yes.
You can use a EVAC 70 slightly bent cautery. You can use a
Yes. Wash
unipolar cautery. You can use a curved bipolar cautery. You can use something. All these are may
We are
not be
saying
available.
hello to the anesthetist pack, which means
Yes.
the coina is completely open. In all
What
likelihood, these
name
patients
can
will
we extend our appreciation of her hypotensive anesthesia, his or her?
Yes. Even now the BP is 76/37.
Wow. So overhead camera can just project on the pulse oximeter.
Curved section of wash code. Sanjay sir, get ready. I think take a picture. ये monitor के ऊपर लगाओ जरा 1 second. Wash.
Wow. It's visible. See the beauty of hypotensive anesthesia in FES. Very nice. Very nice.
So that is why even if I gouged the bones also, the bleeding was bare
Yes.
minimum. One final look, Madhu, before I sign off.
Yes.
Thank you. 70
Yeah,
degree.
yeah, yeah, yeah.
Yeah. 0 degree and 70 degree final pack ready, madam.
Yes.
And this is the final look.
Yes.
I could have done it with a canine fossa approach, or as you said, I could have gone through the middle meatal antrostomy, but I would have struggled to get this kind of a visualization. And this also
No,
ensures
I am able to.
Bernoulli's principle and Poiseuille's law don't apply anymore because the antrum it cannot be more wider than this. So I don't expect
Yes.
any kind of block or
Maximum 100 or 200%
Yes.
available
And
space.
these are the most
Floor of the
difficult
canine fossa
antroconal
is deep.
pulse where they have this attachment to the anterior wall and the anterior part
Yes.
of the lateral wall. Thank you, Madhu.
Wonderful.
I'm just
Right.
showing the final
See-
pack, what I put.
Yes.
With the
Yes.
0 degree, a single pack. We cut the pack always, the Mirocell pack into half the width. We don't use the full width. And we just put this here. And yeah, saline, dressing forceps. And again, come next July, we are there at Nandyal.
Sir, yes, sir. We are all in the arrangement. This time maximum we have done 122 cases
Yes.
for our free camp, sir, as Swachh Bharat or 75th of independence. And this service, thanks for remembering our work.
And Madhu is one of the few fellows to think of death when he is alive. And he has made a very nice crematorium in Nandyala.
Thank you, sir.
Selfish fellow that he is, even in our post-death, he wants to stay in a nice AC place.
Yes, 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 yes. 100%. I'm making my own graveyard, useful
Yes.
for others also.
Yes, yes, yes.
Its name is Swargadhamam.
Yes.
You don't put the Mirocell into the antrum?
No, 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 no. See, the antrum per se is not bleeding. I want it to be
Yes.
covering this area. And I'll put two more
Okay.
pieces of Mirocell anterior to that here,
Now this I'm interested. I thought you'll just leave like that.
No, no, I won't leave it like that. What I'll do is I'll bring the thread out, of course.
Yes.
See, the only disadvantage of this loose piece of Mirocell, they can slip
Yes.
into the coina. So once
Yes.
you have this, technique of keeping one in the coina, the long one, with the thread, which is attached to the nasal skin, then see, this will not
Okay.
slip. And
Yes.
these will sit nicely there, covering all our raw areas. Thank you, Madhu. It's always a pleasure interacting with you. And I'm also happy.
Thank you, sir.
So, another common case, the uncommon
Yes.
way of doing it, on that particular day when you are spoiled with the luxury of your instruments, right?
Yeah.
Yes. Thank you very much. Over to Dr.
I thank
Agarwal.
the micro people for making me as a chairperson, because I have a long, wonderful relation with micro company. And I thank you very much, Deepak. Wonderful demonstration, meticulous. I can
Thank
say
you.
by RBC to RBC.
Thank you.
Not even like.
Thank you so
Thank you. Thank you, Deepak sir. Thank you, Madhusudan sir. It was really wonderful session we started off with. Over to Dr. Krishna and Dr. Sanjay Agarwal sir's OT. Over to you.
अच्छा हुआ ना? Came out well. Actually, curved section, ये curved रहता तो. Yes.
Yeah, thank you, ma'am. And we have a next surgery lined up, which is endoral tympanoplasty by Dr. Sanjay Agarwal, sir. And to chair this session, we have none other than Dr. Professor T.M. Nagaraja. He is a senior consultant in otolaryngology, head and neck surgeon. He is a professor and head Department of ENT from Rajarajeshwari Medical College, Bangalore. He has delivered innumerable lectures at various forums in otolaryngology, head and neck surgery in various conferences and workshops. He has several publications to his credit, both national and international journals, and also has chaired various sessions at national and international forums. Nagaraja sir, welcome, and over to you, sir, for moderation of the event.
Dr. Nagraj, sir, can you hear us, sir? OT, yeah.
Hello.
Hello? Yeah,
Yeah.
please go ahead. Go ahead, sir.
Yeah. Do you see the external camera picture?
Yes, sir. Dr. Krishna, can you please stop sharing? Yeah.
Hello.
Yes.
Uh,
Dr. Nagraj, sir, over to you, sir. Yes, sir.
Yes.
Good morning, Dr. Nagaraj.
Sir, good morning.
We are
Hello.
taking this case with yes edition.
Good morning, sir. Good morning, Sanjay Agarwal,
Nagaraj.
sir. How are you?
So I am infiltrating. We are doing this endoral tympanoplasty under local anesthesia.
Yeah, please go ahead. Go ahead.
Can you see the picture?
Yes, sir.
Yes,
Dr.
sir.
Krishna, please stop the slide, please. Please stop sharing. Yes. Dr. Nagraj, sir, over to you, sir.
Yeah, thank you. Thank you very much. Good morning, sir. How are you?
और ये कैमरा लगा दो इस पे माइक्रोस्कोप पे अटैच किया है क्या मैं ले सकता हूँ इसका पिक्चर है क्या नहीं कोई बात नहीं दिस पिक्चर इज गोइंग ना Hello,
Sir, we can hear,
Nagra?
sir. We can hear you and see the pictures.
Okay, okay.
Right, sir.
Okay. Single space.
I'll be using the tragal cartilage. So infiltrating here also.
One more.
And lastly at the incisura terminalis. Here we will take the endoral incision. So approximately 2.5 to 3 ml we have used. Xylocaine 2% added with adrenaline. Now I'll scrub and then we start.
How much adrenaline you are using, sir?
Sir, I use for 10 ml, 0.4 ml of adrenaline. 10 ml 2% xylocaine with 0.4 ml adrenaline.
Can you come once again? Call it.
कुछ अड़ रहा है उठ नहीं पा रहा
It's not moving.
मैं स्क्रब करूँ ना
Start. College Wi-Fi आपको मिलेगी किसान को कैंसिल मत that yes should I leave it and join again? Huh?
ವಾಯ್ಸ್ ಕ್ಲಾರಿಟಿ ಬರ್ತಿಲ್ಲ ವಿಡಿಯೋ ಆಫ್ ಮಾಡ್ಕೊಂಡು
ನಂದು ವಿಡಿಯೋ ಆಫ್ ಮಾಡ್ಕೊಂಡು
ವಿಡಿಯೋ ಮಾಡಿ ಆಮೇಲೆ ಕೇಳ್ತೀನಿ
ಓಕೆ ಆಡಿಯೋ ಏನಿಲ್ಲ ಅಲ್ಲ ಇಲ್ಲಿ ಆಡಿಯೋ ಏನಿಲ್ಲ Oh, they are not talking. He has gone for washing. After infiltration.
I was able to hear your voice. That's the audio.
Okay, okay. Mute, mute.
बस एक ऐसा लगा। अच्छा लो, फुल शीट है तो अच्छा है। इसको ऑन किया क्या? माइक्रोस्कोपिक पिक्चर। ये बॉयल्स इधर आ जाए और ट्रॉली इधर आ जाए, ऐसा हो सकता है? सिद्धू, हाँ ये बॉयल्स थोड़ा इसको उधर हटा लो अभी। जितना जा सकता है और जाएगा, और ट्रॉली हमारे पास है। ठीक, दोनों इसमें सलाइन ले लो, वॉश कर, सिरिंज चालू किया क्या? एक बेटा एयर इस पे कलम देना। ये चालू नहीं है। टॉप लाइट बंद करा दो। एक मिनट, अभी रुकना। अभी डालिए प्लीज।
Sanjay sir.
जी सर।
Hello. Can you tell us about the patient? What is it safe type of perforation? Details about the patient?
Patient detail?
Patient details. What's the diagnosis?
ये पेशेंट का बोलोगे क्या? केस के बारे में बता दिया। Can you see the perforation?
Yes, sir. Yes. Yeah,
The large central perforation.
We are able to see.
With a airborne gap of around 40 decibel. Okay.
Yes.
We have infiltrated already, and now we are going to start with the incision.
This is under general anesthesia, no, sir?
It is under local anesthesia with sedation.
What type of sedation, sir, you have given?
What
Is it
sedation?
methadone or pentazocine hydrochloride or
Between Finargan and
hydrochloride?
Dexmed. Hospice. Hospice then. Tooth fossa. Endoral. It is always better to clean the canal before giving the incision. So all the debris and everything are being taken care.
That is saline wash you give, sir? Saline wash.
Saline wash we have done, and I am just rubbing with this. You will pull like
It's
this.
beaten in.
Yes, sir. So we are ready with the incision now. This is blade number 10. I usually prefer. For the vertical incision. And then I take a 15 number blade for this horizontal incision, joining the two and now bringing it up to make the flap. This is because it is bone deep.
So
Now
the
with
vertical
this
incision is
Lester's
around 12
elevator,
o'clock now, sir.
we elevate this skin. See.
Yeah.
So this is about the incision. Give me the
vertical and the horizontal incision.
Yes, and joining here and taking it up. Okay?
Yeah, yeah.
Retractor. Asteroid retractor. बड़ा वाला यही है हाँ और एक और लाओ नहीं एक और ले आओ दो निकाले थे ना हमने so now this 2x2 oh, it's not opening नहीं दूसरा देना So these two retractors we are applying at right angle to each other. Can you flush, dear? Yes. ऊपर से डाल दीजिए.
It's a request for the audience. Somebody has unmuted and there is echoing.
Hello.
There is echo. Hello, Dr. Sanjay
I cannot
Saab.
hear you.
Please
पूरा ऊपर से.
mute it. Somebody has unmuted in the audience. Please mute it. There is a double voice. Please mute it.
I could not get you. ये थोड़ा बातचीत मुझे सुना ही नहीं आ रहा दोस्त.
Sanjay Saab, are you able to hear now?
Now I can hear.
Yeah,
Please
yeah,
tell
yeah.
me now.
Yeah, I was requesting one of the audience to mute because they were muted and there was double sound.
Okay,
Yeah.
okay. So now it is clear?
Yes, sir. It's very clear.
So we have applied the retractor.
Yeah.
And now I think the perforation is well in focus.
Yes, sir. Visible. It's almost subtotal perforation if I
It's
am right.
large total.
Yeah.
Subtotal.
Yeah.
It will become subtotal when we will freshen the margins.
Yes, yes.
Right?
Yeah, yeah.
There is a slight tympanosclerosis I can see here.
Yeah, anteriorly, the anterior limb.
मुझे वो देना सिकल. आप comfortable है? So we will now freshen up the margins.
Yeah. So you are using the sickle knife to.
Yeah, I'm using the sickle knife.
Yeah.
You can use, some people use the hook.
Yeah. Even smooth curled pick, a few people
Yeah,
use.
yeah, pick.
Yeah.
Pick works very well.
Yeah.
The idea is to remove all around.
Yeah. Freshening the edges so that there is no epithelium on the free
Yeah,
border.
yeah.
Yeah.
Scissor the knife. Then we can take a circular knife.
Yeah.
And just scratch the under surface. This is the portion of tympanous sclerosis.
Yeah.
I'll be removing this one.
Yeah.
Yeah?
Yeah.
Visible now.
Visible.
This simple. Yeah, this tympanous sclerosis.
Yeah.
Important to remove this.
Tympanosclerotic patch, the
Yeah,
anterior rim. Yeah.
Yes, yes. Otherwise, the middle ear mucosa and everything are quite healthy.
And the ear has remained dry for nearly 6 months, sir, or more than 6 months. It is remaining dry.
Yeah, that I have to ask. I have seen the patient for the first time on the table. So I'm happy with this removal. Okay?
Yes, sir.
Dr. Nagraj?
Yes, sir. Visible. Nice. Nice removal.
It is in well focus. So now we proceed with the canal incisions. 15 number records. So all around we have denuded.
The
And now it
epithelium.
is looking like a subtotal are large.
Yeah.
So for this canal, we take an incision around 7 o'clock. Can you appreciate?
Yes, sir. Visible.
I'm taking with 15
7
number
o'clock
blade.
incision.
And then with flag knife, we will further. And one here. So
on the anterior wall.
Yeah, yeah. And we free this here also. So that flap, this flag knife.
So the anterior incision joins the 12 o'clock incision which you had put earlier.
Yeah.
Yeah.
So these two incisions.
Now you are using
Bone deep.
canal knife to elevate that flap.
Yeah, yeah. And both the incisions are bone deep.
Yes.
We once again deepen it.
Yes.
Circular knife.
So now you are elevating the posterior bony meatal wall.
Yeah, yeah. Exactly.
Up to the level of the annulus.
Yeah, yeah.
Yeah.
Give me seeker. You can see the chorda.
Yes, sir. A white thread-like thing rising from the posterior bone unilateral wall. Yes, sir. Visible. Yes, sir. Very clearly visible.
We will denude the malleus handle.
Yes. Yeah.
Can you appreciate we have denuded it?
Yeah. So it's otherwise called skeletonizing. Skeletonizing the handle of malleus. What you did.
So we have completed with this.
Yeah. Elevation of flap.
Yeah. Now we will check for the
Oscular continuity.
ossicular. So the chain is mobile. Can you appreciate?
Yeah.
I will show again.
Yeah.
You see the movement of?
Yeah. Can you go for a little higher magnification, sir, if you don't mind?
I can. Yeah, is it in focus now?
Yeah, clearly visible.
I'll again move the malleus handle.
Yeah.
And the chain is perfectly mobile.
Okay.
Right?
Yeah.
This is a round window. Okay, this is chorda.
Yeah.
And this chain is mobile.
Yeah.
This is our flap which I am putting back. So what is my plan is for reconstruction? I will use temporalis fascia plus slices of tragal cartilage. Okay?
Yes.
So next we will harvest the temporalis fascia. Gel foam bada piece de do. By the time we will keep gel foam pieces
to control whatever little bleeding is there.
बहुत बड़ा है चलेगा हो गया ओके इधर दिखाना दोस्त sorry for the sound. Another patient is being induced.
Intubated.
Yeah. राइट एंगल दिया था ना मैंने तेको वो लगेगा ऑटरी लगाओ यार एक है ब्लीडर
So for harvesting the temporalis fascia, you are using the same endoral incision?
Yeah, there are Nagraj.
Yes, sir.
This endoral approach.
Yeah. Extending little bit so that you can...
Sometimes our colleagues, they just worry about how to take the fascia. And if you can see by the external camera, how easily we can harvest.
Yeah. Easily approachable, and the same incision is extended little bit.
You see, with that small incision,
any going post-oral region.
I think again somebody has switched on the audio.
Yeah.
The patient is not okay now. Just leave the
audio चालू है फोकस कर पा रहा है क्या सिद्धू आप बताना बेटा कुछ भी यदि ऐसे ऊपर उठा लेना बेटा नीचे करता हूँ मैं दिखाता हूँ अभी उसको बनाऊंगा so we have obtained the temporalis fascia hello
Sir, we can hear, sir. Please go ahead, sir. We can clearly hear you, sir. Please go ahead, sir. Yeah. Dr. Nagraj, sir, I think his internet some issue will be back. Dr. Manjula here, sir.
पटरी करना पड़ेगा ना बस
Request audience to mute.
नहीं आ रहा
Some of you have unmuted and it is echoing.
ये चलो वो ले लेते हैं ट्रेगल कार्टिलेज हेलो
Yes, sir. Yes, sir.
now I am taking the tragal cartilage you have the microscopic picture
Yes, sir. Outside picture we have. What we are seeing is
please give the
now,
microscopic picture देखो माइक्रोस्कोपिक हुआ क्या बेटा ये पकड़ो ओके actually I am operating from the other table so I do not see the monitor monitor is not in my view so
Yes,
please
sir.
tell me whatever is required
Yeah. If there is some inconvenience, I will let you know.
yeah
So you take an incision on the free border of the tragus.
yes
right?
yes boss थोड़ा उठा के रखता हूँ बेटा गॉस पीस है क्या गीला नहीं है कोई बात नहीं so we will obtain a piece of tragal cartilage
Tragal cartilage.
we will mark first the incisions
Yes.
size we need for this perforation
Yeah.
okay
Yeah.
I hope it is visible
Yeah, clearly visible, sir.
side knife
It's around approximately 5 into 5 millimeters, sir. The
Yeah.
size of the cartilage.
It's
Yeah.
smaller, just maybe 4 by 4.
4 by 4. Okay.
And now what I do is,
Yeah.
I do have all the latest slicer and everything,
I see.
but usually I take this 10 number blade I initially used
Hmm.
and would like to
slice it.
slice this.
Take-
Okay.
Yeah.
So some pieces I will obtain, which will be used.
Hmm.
इधर एक्सटर्नल कैमरा से दिखा दो बेटा कटोरी, या इधर एक लाइट दे देंगे थोड़ा सा, टॉप लाइट. मैं इसको कर लेता हूँ, चलो कोई बात नहीं. नागराज, just I'll show you. I have obtained this slicer.
Yeah. Yeah.
Just I'll freshen up my fascia. ये बड़ी कटोरी दे सकते हैं क्या? ये बड़ी दे दो यार, ये बहुत छोटा है. दे दो, मुझे दे दो. थोड़ा सलाइन डाल दो बेटा. डाल दो. दिख रहा है ना? गुड. I am removing the excess tissue from my fascia.
You are thinning out the fascia.
And if you can see, I have obtained 2 to 3 pieces from this tragal cartilage, which we all will use. Okay? So give me tooth forceps, retractor. We can go to the microscopic picture. ऐसा लगा दो बेटा. Section. माइक्रोस्कोप का पिक्चर जाता है. टॉप लाइट बंद कर सकते हैं दोस्त. So this gel foam I will remove now.
Yeah.
I'll go to one higher magnification. इस सिकल दे दीजिए. At this point, it is recommended to take the smallest possible suction tip.
Yeah. Maybe,
Okay?
maybe around 21 or 22 size.
Yeah. We reflect back our flap.
Yes.
So this is the handle we have denuded.
Yes, sir.
Ossicular mobility we have already checked.
Yes, sir.
So what I'll do is, I will put this. दे दो. थोड़ा पास में नहीं है ना ये. This is one piece I am using. बेटा इस पे रख दो. इस पे रख दो. ये चाहिए मुझे. मैं ऐसे ले लेता हूँ. यहाँ ले लो. मुझे अभी दिखेगा नहीं.
Picture is somehow frozen. It's not moving.
नहीं दिखता. हाँ, चलो हटा लो. इसको वहीं डाल दो. आप यहीं डाल दो. डाल दीजिए. And this is the largest of the three pieces, which we will try to put below the malleus handle. Can you appreciate now? Hello?
Yeah, yes,
Nagaraj,
sir.
this was one piece I
Yes,
have
sir,
kept
yes.
before. Another piece
Yeah.
and big piece. So forming, like forming a foundation. Okay?
Yeah.
So this is like
So-
double layer tympanoplasty.
Okay.
And we are using this method since more than now 25 years. And we are very happy with the results. Now I'll take the temporalis fascia.
So these pieces of cartilage act as reinforcing the graft.
Yeah.
They give good support and reinforce the
Yes, yes.
facial graft.
मुझसे चलता नहीं है. ये लेता हूँ, शायद वो नहीं चल रहा है. We are putting back our temporally tympanomeatal flap.
Yeah.
Our graft has come here, which will be tucked all around over the cartilage base.
Yes.
Agreed?
So underneath the cartilage base is there. So it gives support for the temporalis fascia.
You see now.
Yeah.
Can you give me this something like? ये क्या है? This is also good. So just to ensure that it has gone in, so it should.
So you are using circular knife to tuck in the anterior.
No, I was just checking.
The graft. Yeah.
Now I am tucking. You see?
Yes. Yes. Yes.
I was checking for the space and how much it is in.
Yeah.
And subsequently I have tucked it. Okay. So this has
Yes.
gone inside over the
Yes,
cartilage
sir.
from all around.
Yes.
We'll just check
Mm.
once more the position
Yes.
of the cartilage.
Mm.
This is our graft,
Yes.
and this cartilage you can see
Yeah.
is well in place. Okay.
Yes.
So we are very happy with
Not
this.
displaced. It is well in place.
Yeah. Please come again.
Mm. Yes, sir. So the cartilage piece secures the temporalis fascia, and you
Correct.
are
Correct.
tucked in on
So the bigger piece
beneath the
is
and
kept under the malleus
yeah.
handle. Okay. And we see this ballooning effect, if you see,
Mm. Yes.
indication of a good
Yeah.
pulsation function. As soon as we got the seal, we can see a ballooning effect.
Yeah.
Give me the gel foam, small pieces.
Yes.
So I think we are happy with our reconstruction. If there are any questions, Dr. Nagraj, otherwise I am putting now
Yes,
the
sir. Yes, sir.
small piece, beta. This is very big. Small pieces of gel foam which will overlap our graft and the remainder of the meatal skin, so that by surface tension it will hold the graft. Okay.
Okay. Okay. Okay.
थोड़ा कुछ गीला करके दो ना यार किसी में, क्या कर रहे हो? ये तो ऐसे दोगे तो सारा ग्राफ्ट ही बाहर आ जाएगा. लाइन में कर लो, किसी में भी कर लो. Yeah, this gel foam should be soaked maybe in the antibiotic solution. If nothing is there, it may be in the saline.
Okay.
So I think it is visible that partly I am keeping it over the graft and partly over the skin, canal skin.
Yes, sir. Visible. Yeah. Yeah. Gel foam is
So the
placed
initial
over the skin.
3-4 small pieces to cover from all around the boundaries.
Yes, sir.
So the main advantage of this our endo and oral tympanoplasty is you will see how fast we will close this. Number one, we can use both the hands.
Yes.
Vision as compared to permeatal. Of course, post-oral approach gives also a very good exposure, but this is fast and less traumatic to the patient. And hardly we will apply 2-3 stitches.
Yes. Scar problem is not there.
Yeah,
The time
it is hardly visible.
Yeah.
After a few months, we have to ask the patient which year we have operated, like that.
Yes. Yeah. Yeah.
बड़ा बड़ा दे दो, थोड़ा बड़ा दे दीजिए, 5-6 दे दो. So till the bone, we will fill this gel foam to cover all our flap.
Yeah.
And then subsequently will reflect back the canal skin which we have lifted.
Yeah.
दे दो बेटा.
So the canal skin acts as a vascular strip which supplies blood to
Just
the
I'll show. Just
facial graft.
रुक जाओ बेटा. I'll just show in a minute.
Yeah.
So we are removing this our retractors.
Yes.
There are dissectors, है ना मेरा, plasters. So this is important to reflect this back. Okay.
Yeah. That acts as a source of blood supply to the graft.
Yeah, yeah. This is reflected back. And now what is left is to apply few stitches. इसको आधा कट कर दो बेटा, यहाँ से कट कर दो. Tooth forceps. So this is our tragal incision.
Yes, sir.
I am purposely doing it under microscope, so you can appreciate well. So this is one stitch.
Yeah, what's the material you are using, sir? Is it
Yeah, I am using a 30 silk. छोड़ दो बेटा.
silk? Okay. 30 silk. So to summarize, you have taken under local anesthesia this patient.
Yeah, yeah.
And the tympanomeatal flaps are raised. And with the endaural incision, you have taken the
this was our
facial
incision.
graft. Yeah.
Can you see now?
Yes, sir. So temporally
your voice is breaking.
Being harvested with the endaural.
कुछ प्रॉब्लम है बात. ये मुझे काटो बेटा, एक और लगाते हैं. Hello.
Yes, sir. Yes, sir. You are audible.
Yeah. Can you see now?
Yeah,
These
yeah.
stitches we have given here.
Yeah.
One at
Clearly
the
visible.
tragal area.
Yeah.
And this completes our surgery.
Yeah. So wonderful demonstration, sir. It's a very nice operative procedure.
सारा दे दीजिए, बड़ा पीस दीजिए.
So the method of taking the fascia graft through the endaural incision, we were witnessing with the same incision, we took the facial graft.
Yeah, yeah.
And
we have taken the
flaps
tragal
were raised
for additional support
in order
and
to protect
like
the graft.
reconstruction.
Yeah. Yeah.
Okay.
Yeah, cartilage was harvested from the tragus and cut into small pieces. They act as support for the temporalis
Yes,
fascia
yes.
graft.
Yes,
Yeah.
yes.
Very
Now
nice
the-
demonstration, sir.
Thank you very much. Now our
Very nice
dear friend Dr.
demonstration.
Deepak.
Complete hemostasis was maintained with the use of gel foam. So I
Okay.
request any audience who have got any doubts, please.
Our next case is being done by Dr. Deepak.
Yeah.
It's a mastoid operation. He will demonstrate now.
Yeah, yeah.
So what?
Excellent demonstration, sir. Jai Saab. Endaural tympanoplasty. Tips. You
Dr.
demonstrated
Nagraj?
very clear, sir. Yes, sir. Am I audible?
Yeah, yeah. Is everything okay?
Yeah, very nice demonstration, sir. Very good.
So
Complete
this is
hemostasis
done
was
under local
maintained.
anesthesia.
Yeah, wonderful, sir.
Closure is fast.
Yeah.
And we get adequate exposure. Plus we
Yes.
can use both our hands.
Yes.
So I find this a very useful technique. Thank you very
Yeah,
much.
yeah, yeah. So wonderful, sir.
Thank you.
Wonderful, sir. Thank you very much, sir. Thank you, Shailesh and team from Microlabs for giving me the opportunity to moderate the session. It was a wonderful demonstration of endaural tympanoplasty by Dr. Sanjay. It was a nice demonstration. Thank you very much.
Hello? Hello? Hello?
Yes, sir.
Yes,
Go ahead, sir.
boss. Dr. Deepak.
Yes, sir. How are you, sir?
Dr. Deepak.
It is really nice of you that you could make time.
Good morning. Good morning, boss.
Yes, yes.
Good
There's
morning.
a child with a chronic ear, which I am starting now. External camera, please. 15 knife. Nagraj,
Hello. Good morning,
are you
Deepak.
getting the external picture?
Sir, not yet.
AdSense.
Yes, sir, we're getting the picture now.
Yeah, touch. Touch. Can somebody discuss about this case? Yeah, yeah. Please tell now. Keep the mic for yourself and tell about the case details. Innೊಂದು 15 blade ಬೇರೆ ತಗೊಳ್ಳೋ ಒಂದು ನೋಡೋಣ. एक नया लेना 15 blade. Touch करो यार. ये भी touch करो. हाँ 15. Yeah. 3-pin retractor ಕೂಡ. L-shaped retractor. Yes, 15 knife, please. The new blade. Hello.
Yes, sir.
Yeah, who is there on the other side?
Sir, Dr. Nagaraj idare and this Krishna here, sir.
Oh, very good. Yeah. Are you getting the external picture?
Sir, we are seeing the case. Yeah, now we got it, sir. We are getting it.
Yeah.
Yes.
Oh, case detail, I think. He's describing the case details. Let him describe. That's correct.
Right.
He will not disturb that. ಹಿಡ್ಕೊ ಇದು. रेगुलर सीजर दिया तो बस बस एडसेंस हाँ थोड़ा ऐसे उठा हाँ ಇದು ಕೂಡ ऐसे उठा हाँ सीजर ಕೂಡ हेलो हेलो
Sir. Yes, sir.
Are you getting the picture of me taking
Yes,
the
sir.
ground?
Yes, sir. We're getting it right, sir.
Yeah. This I was supposed to do it offline. Me and Dr. Nandu Kolwadkar, we had spoken about it, but Sanjay the Maverick that he finished the case.
Had a right.
No.
Right.
And it is so nicely he demonstrated actually.
Right, sir. It was
See,
a
I've
pleasure
taken the
watching
graft.
case.
I've taken the graft. If you go in the right plane again, it is a bloodless field.
Correct, sir.
Yeah. to save on time, I didn't put my canal incisions first. Microscope, 15 knife. So I'm just trying to palpate for the post-oral groove. How old is the child? 10 years.
10 years.
So I need not worry about a non-developed mastoid process or anything like that. That is less than 2 years. Gauze. Yeah, 15 knife. Yes. Cautery kodu. AdSense. Touch. Light touch. Touch. Yes. Yes, cautery. Nagraj.
Nagraj, sir, it just got muted. I'll just check the one.
Okay. AdSense. Touch. 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 Yes. Sharp mastoid elevator. Usually I start with the canal incisions. One is because in this case I was told that there is an oral polyp. And second, because Sanjay Agarwal was demonstrating on the other side, I didn't have access to the microscope, which I got now, I think. So, yeah, either ऐसा रखेंगे. हाँ. और नजदीक करना है. मुझे लगता है. Lampert speculum. You're getting the microscopic picture?
Yes, sir. Bartide, sir. Visible.
Alligator forceps. This is the fine focus, or no? What is this? ये fine focus है. Brightness, हाँ. बस ना? ओ ये. अच्छा ये. ओके. ठीक है बॉस. अच्छा. There is alligator forceps. Oh, there's a polyp there. Okay. Double 15 suction, please.
Deepak?
Yeah.
Hello.
Yes, boss.
Oh, Nagana speaking.
Yes.
Really nice to watch your earlier surgery. It was so nice.
No, boss.
This is external, this one mastectomy you are doing, no?
No, this is one, this one which Nandu wanted me to just demonstrate offline. 18 section, because Sanjay finished very fast. But we will, I'll reduce the brightness. Brightness is too much. Section Bere Kodu. Nagana, this is a 10-year-old boy. Seems to have an oral
Yes,
polyp.
boss.
See this? You are a master of this. You do it regularly in Rajashuri. I know.
No, boss, you tell me. This is recorded live demonstration from Nagpur.
No, this is live demonstration from Nagpur. See this?
Okay. Because Sanjay finished fast.
Yes. It was almost Sanjay's case was like he was doing a recording. He did so fast.
Yeah.
Right.
Cotton. You can see this, no? You can see the polyp.
Yeah.
Yes, sir. Visible.
I'll try to put a cotton and compress the polyp so that I get space to put in the canal incisions. One more cotton. Your student, Dr. Vishwas Vijay Dev, cotton, he is going to demonstrate next, Nagraj. Hello.
So in the meantime, you want to demonstrate this oral polyp.
Yes.
Right, sir. Right.
Yes. Alligator forceps. It's a 10-year-old child. One more cotton. Or maybe give me the. There is some space for me to put the canal incisions. Okay. Section ಸ್ವಲ್ಪ weak ಇದೆ ಕಣ. Section थोड़ा strong करायची. 15 knife.
Deepak, can you debulk the oral polyp and then put incision? It is easier. That's what I felt.
Yeah, but generally, see, I don't know where it is attached. So it is better if I can put the incision, double-end knife, or circular knife. Section strong nahi hai. See? Section weak hai, boss. Alligator forceps kodu. It is a little bit of a struggle, Dr. Nagraj, but I think once, one of the schools is, yes, you can debulk the polyp, double-end knife. But somehow, unless I know the origin of the polyp, I would be very nervous to pluck it, Nagraj. What do you say?
Meant was debulking with a little
Side knife.
clean cut, not pulling it.
Yeah. Section. What I feel, and the side knife. This anyway looks like a mucosal polyp. Circular knife.
Any biopsy was done earlier, boss, for this case? Biopsy?
No. So I've just lifted one corner of the usual coroner's flap, which was again taught to us by Dr. Madevaya. Lampert speculum. Craft agla madu. double end knife. Now I am going to extend the same incision superiorly here, like this. 15 knife. And then put the vertical limb of my incision at 11 o'clock or the 12 o'clock position. Side knife. External camera, please. Circular knife. With that, you are getting the picture, I think.
Yes, sir.
Yeah, I have elevated the coroner's flap completely towards us now. SMR elevator on the ribbon gauze piece it go. Okay. $15 knife. So just releasing the incision from its attachment, suction. Yes. Yes. 15 knife. We put one release incision here. Can you see that?
Yes, sir.
Yeah. Who is on the other side? Who is there?
So Nagaraj sir is there and myself, Krishna.
Your name?
So Dr. Krishna, microdog, sir.
Okay.
And Dr. Manjula Madam also is there.
Who is there?
Dr. Manjula.
Okay. 15 knife.
And Dr. Reddy, Vishnu Sarup Reddy sir has just joined.
Oh, ho.
And I think again there is some network issue there. He's relogging again.
Yeah.
Boss, is it done under GA, no?
Under GA, SMR elevator, yes.
Yeah.
I do all my cases under GA, Dr. Nagaraj.
Yes, boss.
Yes. And of course, a 10-year-old child, retractor, 3-pin. There is no way how I could have done it under
local labs.
At all, impossible. So let me see, I'll try to put in a ribbon gauze later. I have to dry the graph. But see, Nagaraj, now I am getting a little better exposure, I feel.
Yes, yes.
Look at the
Definitely
poly.
after releasing incision, I think you are getting a good view of the polyp also now.
Yes.
Yeah.
Probably,
Nice.
I think, yes. I'll zoom.
What's the BP, boss, at this time, at this hour? BP?
नहीं लोअर किया तो पिक्चर और छोटा हो जाएगा ना नहीं ना वो लोग अच्छा ओके ओके alligator forceps.
Your anesthetist is so good, boss. They have given hypotensive so well. Hardly any bleeding seen.
Yes.
What's the heart rate and pulse rate and this one BP, boss? Just to know. curiosity, out of curiosity.
Yeah. Heart rate कितना है? Cotton. Looks like a mucosal polyp, Dr. Nagaraj.
Yeah, yeah.
Cotton.
Yeah.
ಸ್ವಲ್ಪ ದೊಡ್ಡ cotton. I think that is a perforation that I can see now. Through the polyp, actually, I can see the perforation. Maybe I'll decongest that area for a while.
Yeah.
Till ready, yeah. One more cotton. It appears my cotton is now sitting in the perforation. Okay.
Is it central perforation or marginal?
Looks like a central perforation. Looks like. As of now, little difficult to say very early, but
what's the amount of deafness the child had got?
Nearly 50 dB.
So
one more cotton.
What was the ossicular status, boss? If CT was taken earlier?
That I have to check out from somebody here, the local people. Can somebody say whether the CT was taken? Cautery soft little nodo. Force लिया cautery कौन सा इसमें है बेटा? Force में है या fulguration में है?
When you are reporting, yesterday you reported.
Okay. Force is good, yeah. Even 3 pin idea. 2 pin idea. External camera, please. Ribbon guards, 2 pin. 2 pin. 3 pin.
One more slip.
Yes, can you focus on this? Nagaraj.
Yes, boss.
As you do, I am just spreading the graft on the bowl.
As you do, sir.
As you do, boss. As you do, sir. You are a master in the post-oral tympanoplasty, but Sanjay, I think, demonstrated wonderfully today, isn't it?
Yeah. It was very nice.
Just couple of incisions. He does at lightning speed. He's exactly my opposite. There was this story of what you call tortoise and the rabbit.
Rabbit.
Yes.
I am also tortoise.
Yeah. No, Sanjay is always like that, but endoral especially I have seen, in the end you just put 2 incisions and there are some patients who are finicky about post-oral.
Yes.
See, in the OPD they ask us, sir, are you going to cut from here to here?
Yes.
They show with their finger for those patients, and he has learnt it from his teacher or master, Dr. Pusalkar, and he does it equally well.
Yes, I should follow him here afterwards for at least some cases. Dry spectral perforation, I should follow.
No, I do at times. I do when a dry perforation I have or a regular perforation I have, where Now the current concept is not to open the mastoid unnecessarily unless you feel there's a disease or in a cholesteatoma and there is a way of establishing the auditus patency.
What's your plan for this, your case, sir? This
Here,
case.
no, let me see if it is a cholesteatoma. If it is not, then I will do the mastoid right now. Definitely I'll do the mastoid because there is an oral polyp and I feel the mucosa, oral mucosa will also completely, it has the same,
Polypoid type, little polypoid variety.
Foot switch, please.
So these are all the cases where you have to open up the mastoid, which is one of the good indications for mastoidectomy.
Yes, Dappa mota bar renyavadilva, idana biggest. See, I'm doing the conventional mastoid now. The first cut parallel to the linea temporalis.
So God sent opportunity for me to moderate your surgery, boss.
What do you mean? No. Excellent. External camera picture is coming there.
Yes.
So this is the second cut along parallel to the external artery canal, posterior surface, and the first cut. I am deepening it.
Your mask is coming in the way. Yes. Somebody pulled it. Nice.
Yes, Sanjay Agarwal is right behind me. And this is our triangle of attack, joining the two incisions. Looks like there could be a cholesterol granuloma in this case. Looks like there is a cholesterol granuloma in this case.
Did you see yellow color fluid coming out already, or?
Your voice is not very clear, Nagana. There's a little bit of internet lag, I think. See, there definitely is a cholesterol granuloma in this. See, there are people who do from the first step under the microscope, which is also a good idea. You can do in a lower magnification. But I have this old habit of doing the first half without the microscope.
So cortex of the mastoid cortex can be drilled macroscopically. That's what you meant.
Yes. It gives me an overall picture, better picture in terms of the landmarks. I am shortly going to change to microscope. Very shortly.
Do you feel there is any difference between mastoid cortex of children and adults?
In the children, especially in cellular mastoid, the bones are very soft and very easy to basically handle. Already I see something there in the, probably, I may be seeing a cholesteatoma, I do not know. I'll move to the microscope. My friend Sanjay is now prompting me from behind. Yes. Okay, let me see. Suction. definitely there is this cholesteatoma, Nagana,
Yes, yes, boss.
and such a young
Yes, boss.
child with a cholesteatoma.
Yes. Reflects on poor eustachian tube function, boss, if I am right.
Yes. Let me just see whether it is a smooth curve pick. Give me a smaller section, please. Drill. Give me the drill. Let us make this party wall really thin. And let us see whether it is thick mucosa. Because if it is thick mucosa, then I don't need to do canal wall down.
Yes.
Otherwise, I'll go ahead and do a canal wall down because the carcinoma is so aggressive at this young age itself.
Yes.
You know, within 10 years, it has reached this level.
Is it appearing glistening epithelium, boss? Glistening?
ತೆಳ್ಳಗೆ ಆಯ್ತು ಕಣ ಇದು. That is what I need to decide because
That is close to fossa infidis, if I am right.
yes.
Yeah.
I want to make this bone
As thin as possible.
yeah, so that I get a good view of the mastoid anatomy. And again, you know, with the burr, always make movements like a paint brush. Okay.
From medial to lateral, that is inside out.
Yes.
Yeah. The angle between the posterior bony meatal wall and the tegmen
Yes.
towards zygoma.
Yes.
Yes, boss.
Smooth cut pick. Let me spread it and see. Definitely, it's a cholesteatoma.
It's a glistening
No doubt at
epithelium.
all. Yes. Give me
Yeah.
the cotton.
So if it is cholesteatoma, you prefer now canal wall down, or still you would like to retain the
No. I would like to do a canal wall down in this child because it is such a aggressive disease. At 10 years itself, this child has got a cholesteatoma.
Yes.
I think
Yes.
if being conservative, I will only be risking a 15 knife. What is this? Initially, I thought it was a bad chronic disease with polypoid mucosa, but now I realize
Not worth retaining posterior bony meatal wall.
No. 11. Okay. We have easily 1 hour. Yes. No, actually, Nandu said, now he has put my lecture third. Abhi bathroom. Yes, we will exactly wind up at 15 knife. Side knife, micro scissors. Alligator scissors से करो. दे भेजा मैं. भेज दिया उनको इसमें डालने को. Micro scissors. Yeah, we have the crocodile scissors. Oh. Yes. Now side knife. I will go for canal wall down.
Canal wall down.
Yes, boss. This is the posterior buttress, okay, which lies on the facial nerve vertical segment.
Yeah.
So that you would call it as a facial ridge, where
Yes.
I am now running the burr.
Yeah, yeah. And also for the benefit of postgraduates, your movement of burr tip is
Yes.
along the line of the vertical facial nerve.
Yes, yes, yes. You see,
Along
should
the
be
line
doing
of the
like this. It
vertical
should not
nerve.
be done like this. It should be going like
Across,
this.
not across, not
Yes,
across,
yes,
no,
yes,
along the line of the
yes.
vertical facial nerve.
And the
So
most
our
important,
postgraduates are
yeah. In fact, sometimes I feel today's postgraduates know much better than me and you. Bhagana. No?
yes, that's true.
Diamond burr
That's true.
looks like a
That's true.
sclerotic mastoid, not
Yeah.
many hair cells. Diamond burr. See, what I want the postgraduates to appreciate is this landmark, the lateral semicircular canal.
Yes.
This
boss.
one. So as long as I
Yes,
remain above it, the facial nerve is about
Yeah.
1.25 millimeters anterior and medial to the lateral canal. So I'm just using the diamond burr to just
Yes.
reduce the oozing a little bit, because you have to keep in mind it's a
Yeah.
10-year-old child. His blood volume will be low. So may
Yeah.
not be a great idea to allow him to bleed.
Yes.
Yes. Now,
So for the benefit of postgraduates, this lateral semicircular canal is a good landmark, is it not?
yes, it's a very good landmark.
No lagging.
Alligator forceps, suction block nodal.
Lateral.
So there are a few questions coming in from the delegates.
Yeah, please ask.
Yes, sir. Sir, Dr. Lakshmi Satish Madam is asking, any CT scan was done for this child?
Yes, it is done. It
Okay,
was
and,
done.
and Dr. A.R. Mondal from...
Now, whatever little doubt I had about the cholesteatoma, can you see the color now? 1 minute, I'll show you. Upper section. Yeah, what is the other question?
Yes, the Dr. A.R. Mondal from Calcutta.
Yes.
Will the cartilage not affect the reduction of the middle ear space and reduce vibration of the drum?
Which one?
Will the cartilage...
The answer, this has to be answered by Sanjay Agarwal. I think the question was for Sanjay Agarwal. Can somebody transfer the mic to Sanjay Agarwal? He can use a hand mic, you know, you use the hand mic. No? Saline? Saline? Smooth cut pick. Yeah, I can feel the incus here. Can you see?
Yes, sir. Right.
So this is my fossa incudis. Cotton. कॉटन अरे हैंड माइक फॉर संजय अग्रवाल हाँ कोई सवाल पूछा ना बस उसका आंसर देना
Hello,
Yes, sir.
I'm Dr. Sanjay Agrawal. About the question of
drill
putting the cartilage, you asked somebody, no?
Yes, sir. Dr. A.R. Mondal from Calcutta is asking this question. Will the cartilage not affect the reduction of the middle ear space and
No, not
reduce
at
the
all.
vibration of the drum?
Not at all, because these are thin slices we used and rather long-term follow-ups, more than 25 years. We are having very good results.
Okay.
So there's one more question. This is a question from Dr. Kalam from Mangalore. Will placing tragal cartilage as a foundation reduce middle ear space as well as increase rigidity of graft, reducing conduction?
No, I just answered. Not at all. Rather, it gives a very stable assembly and double-layered closure of the perforation.
Okay, sir. Thank you, sir.
In many cases, we have also use Palisades cartilage tympanoplasty. If anybody have heard about that. So this is a known technique and it's no problem. Thin slices we use, very thin. Tragal cartilage itself is very thin and then we make slices of it.
Yes, sir. In continuation with the same answer, this is Dr. Sudarshan Reddy from Hyderabad. Doctor is asking a question. What are the advantages of sliced cartilage pieces in the middle ear?
All circular knife.
Yeah, this is the technique. It varies from the person to person.
Regular circular.
In my hands, what I learned from my teachers, this sliced cartilage gives a good stability. Yeah. Somebody puts gel foam, somebody puts other thing. So we use this tragal cartilage because it is readily available. And as I said, very thin slices we use. Okay?
Yes, sir. Thank you, sir. Sir, there is again Dr. Sudarshan Reddy is asking, sir, for the benefit of my PGs who are listening to the lecture here, what would be the 3 take-home points of the procedure which you have performed?
It's another method, like we have post-oral tympanoplasty, endomeatal tympanoplasty. Nowadays, this endoscopic tympanoplasty and oral tympanoplasty is like one of the procedure. It depends how you are trained. And I do all, even my mastoids by this endoral route. So this is the choice of the surgeon. Okay? How you are trained and how you take these. The advantages, it is fast. You can close fast. You can get the temporal fascia. There only you can get tragal cartilage, cotton, right?
Yes, sir.
Cotton. Can you see the attic cholesteatoma here? Yeah, cotton. Yes. Yes. Now I am reasonably sure that this is a case of attic cholesteatoma, and I'm also reasonably sure with my palpation that the incus is not attached to the stay piece. So now I can confidently move ahead with my removal of the bridge. Nagraj is there. Nagarna,
Yes, boss.
you can
Are you able to hear me? Am I audible?
Yeah. Can you see this article here?
Yeah.
This ossicle. Cotton.
Is it malleus handle?
Yes. It is the malleus. In these cases, commonly you will see that the chorda tensor fold would be blocked. This is a disease caused by the chorda tensor fold. Yeah. Now I'm, feeling reasonably confident. If the polyp was there, I can pluck it out also because I've got a good exposure. I realize that lateral semestral canal is not dehiscent. Only facial nerve, I don't know, that I will know shortly. Drill kodama. Diamond barbada, regular cutting barcode. Now that I have all my landmarks in view, I think it should be reasonably fast now for me to remove the remaining portion of the, yes, yes.
Deepak, sir, there are a couple of questions coming in from Nepal.
Yes.
This is a question from Dr. Bijay from Kathmandu.
Yes.
Dr. Bijay is asking, is it okay to remove the inferior turbinate in pursuit of clearance of mucosal attachments?
Yes. Inferior turbinate, is it?
Yes, sir.
This is for our previous case, I think.
Yes,
Yeah.
previous case. Is Dr. Bijay is referring to the previous
Why
case?
not? Why not? Why not? Definitely you can. There is no doubt at all.
Sir, and Dr. Navneet Jain from Indore
Okay.
is telling, sir, my question is, in all my nasal cases,
Yes.
I mostly do inferior turbinate cutting, so patient never complain of nasal block. Because in nose, whatever you do, patient always complain of blocked nose and never satisfied with the airway. Your
Yes.
thoughts and suggestions. That's
See,
what
honestly, I used to believe in the same thing, but of late I realized the trick is in the middle meatus. So I concentrate more on making the middle meatus more open. Me and Navneet and Sanjay, we come from an era where we were very concerned about the floor, you know, this thing at the septal floor. So we would remove those spur and still wonder why the patient was having the nasal block. Smooth curved peak.
Okay.
So this is the destroyed incus, you can see. Can you see this? See, the
Yes, sir.
long process is destroyed. Yes,
Right.
only the body is there. Hold this. And that
Yes,
leaves only a small portion of my yes. I've got a good cleavage here with the cholestatoma. Yes, here I can see the mucosa, remaining mucosa there. So what I'll do is I'll just keep a cotton here for protection and go ahead and take away this last portion of the bridge here. I think it's pretty clear, no?
Yes, sir.
See, this is the facial nerve here. Luckily, it's not dehiscent. So I've got almost all structures in my view, except that I don't know about the stapy superstructure. So that I will see once I remove the ball probe. Vidya. See, invariably, this is a disease because of the block here. The chorda tensor fold, where I'm moving my probe now. I'll keep a cotton there to decongest. What's the time, Sanjay boss?
11:20, sir.
I have exactly 40 minutes to go. I will finish it. Yes. Drill. So basically, the whole idea is you should know good anatomy to do these steps fast. You know, if you are scared of facial nerve all the time, then but as I told, fossa incudis is a very good landmark. That is the malleus, and you can see the squamous epithelium going on the top of the malleus. Now I have taken off the bridge, as our Nagana was saying. See, my facial nerve is at that level. So I know for sure by removing the bone here, I'm not going to damage my facial nerve. At the same time, this is the posterior buttress, which I am reducing, which will give me a good plane to elevate If you notice, most of my bone work is over now.
Right, sir.
This is a very shallow mastoid. See, this is the SAPI superstructure. Can you see this? Here,
Yes, sir.
mostly only the foot plate is there.
Only the foot plate,
Only
right?
the foot
Visible.
plate seems to be there. See this? It is fractured. Alligator scissors. So I'll be cutting the tendon here. I'll keep a cotton to protect my foot plate area. Malleus nipper idea nodu. It clean madu. Yeah. ಇದು Malleus nipper. That seems to be the foot plate area. You can see the colcitoma bit in the sinus tympani. The side knife. Polypoid mucosa,
Yes, sir.
just polypoid mucosa. This is the polyp which was kind of coming through the suction blocked. I think most of the disease in the sinus tympani mid-ear is gone. I need to do a little fine dissection underneath the malleus. This is all polypoid mucosa. I don't see any colcitoma here. Let me try to preserve this. There is a bit of colcitoma here though. Cotton. One more cotton. This seems to be the promontory area. Yes. Yes. I am dead sure that there is no colcitoma further antero-inferiorly. Let me just look at this one small area here. One ನಿಮಿಷ. Double end knife ಅಥವಾ side knife ಕೊಡು. This is the annulus, the tympanic annulus, which I am elevating in the hypotympanum. I think I have got almost all of my landmarks, feeling now reasonably confident. One more cotton, ಸ್ವಲ್ಪ ದೊಡ್ಡದೇ ಕೊಡು ಪರವಾಗಿಲ್ಲ. And this polypoid mucosa will lose a little right now, but another 4 or 5 minutes it will settle down. ಚಿಕ್ಕ ಡೈಮಂಡ್ ಬರಿದ್ಯಾ ನೋಡು. Yes. One thing I'm very happy is that I decided to do a canal wall down on this child. That is the cholecystoma in the facial recess area. Nagana.
Hello.
See this? I removed the.
Yeah, you are close to facial sinus tympanic area now.
See, this is the facial nerve. Can you see this? This is the facial nerve.
Yeah.
Ball probe.
Yeah.
Ball probe or the button.
Is it there? Is it there?
Let me palpate. No, luckily no. And this is the foot plate, Nagana. This is the foot plate. I can feel the foot plate.
Yes,
here.
boss.
And this is the stapedius tendon.
Suprastructure.
So you can see the pyramid here. Superstructure is not there.
Yes.
It was destroyed. You can see the remnant of the stapedius tendon there.
Yeah.
See this?
This white one is stapedial tendon.
Yes.
Left section
Cotton. Only the foot plate is there. Covered by a layer of polypoid mucosa. This is the facial nerve. And see, Nagana, the facial nerve isn't here.
Isn't, sir?
Can you see
yes,
this?
Yes,
here?
yes.
Can you see? Can you appreciate that?
Yeah.
Can you see the? Can you see the foot plate there?
Yeah.
Blue color. Can you see the foot plate?
Yes, sir.
Yes, boss.
Yes, sir.
Here, yes. I have removed the disease completely in this area. Cotton. Okay. Malleus snipper. I think yes. Alligator forceps. I want to retain this mucosa because anyway, that is not diseased. It was only polypoid. Ball probe. That is the tensor tympani tendon area, Nagana.
Yes, boss.
I'm doing a bit of cotton ball dissection there.
Yeah.
Okay, see
So
that?
processes cochlear reform this area.
Yes, correct. And this is the tendon. Usually the problem will be here. So I think first I'll remove the head of the malleus, which gives rise to better ventilation. I'll keep the handle of the malleus as it is. Yes. Malleus snipper. Yes. I could nibble the malleus. Smooth cut pick. Or give me the ball probe. Yes, the malleus head came off. That leaves this area. Can you see this?
Anterior attic region.
Yes, anterior epitympanic recess, or as you said, anterior attic. See, the tensor fold here was also blocked. Now, if we cut the tensor tympani tendon, the ventilation pathway will get completely elevated. Alligator scissors. Yes. This whole thing is open now. Cotton. Now I am really happy, Nagana, because see now, now I am taking away the polyp. If you can notice, after making sure cotton. Okay, hold this. Yes, that is the drum remnant. Okay, one more cotton, big one. I am almost done. I'll do the canal wall down a little more. Then take away disease in the anterior attic. Take a small piece of cartilage from the floor. One more cotton. I'm happy the child has a mobile footplate. Yes, drill. Diamond on the cutting barcode. So even small one also chalega. Double side knife. Yes. That is the eustachian tube area. Okay. That is the eustachian tubal area. Ball probe. Yes, the eustachian tube area is quite open. I'll push in a cotton there. Okay.
Hi, Dr. Deepak.
Yes.
Good morning, Dr. Prakash Munka here.
Hello.
Yeah. Actually, I saw your first case and then I joined just now because I had a surgery in between. Can you orient what has been done till now?
Yeah,
because many people must have joined late. So
yeah.
for them,
I'm basically working near the anterior attic space now.
right.
To basically, remove the last part of the cholesteatoma.
Yeah.
I will leave a ledge of bone there just for the convenience of grafting.
Mm-hmm.
But generally, this is the area where you can leave residual cholesteatoma. One area is the sinus tympani,
Yeah.
which I addressed already, and there is no cholesteatoma there. Now,
Excellent, Uchana. Excellent.
yes.
You well explained the importance of ventilation, which is very important.
Yes.
So,
Yes, thanks to Moaz Tarabishi and Daniel Marchioni and Olivio City, we have understood with the endoscopic pictures.
yeah.
Irrigator forceps. Wall probe. Yeah, there seems to be a cholesterol granuloma here.
Yeah.
See in this. See, can you appreciate the color there?
Yes, yes.
Can you see the color?
Yeah, yeah.
Now see. Now the mucosa is normal here.
Yes. Now we can appreciate that.
This is the cog of Shihi. This is the cog of
Yeah.
Shihi's cog. And this was the fold which was blocking the ventilation from the eustachian tube.
Yeah.
This area, it was blocking. Now it is opened up. Cotton, please. And this is the eustachian tubal area. ಸ್ವಲ್ಪ ದೊಡ್ಡ cotton ಕೊಡು. We can even take away the cog and cotton. That's the edge of the old TM. Yes. Okay. Small side knife you give. Side knife kudu. So this is the area where I would like to place my graft. So I need to have a good clear view of the canal bone here, which I am getting now. One the small cotton ball kodu. That will be where my graft is going to sit. On the small cutting burrow itko cotton. I'll take out the cog so that I can open up the anterior-epitympanic space a little and also remove a little bit of the inferior canal wall bone so that I can see this a little better. That's about it. My bone work is over. We'll shape the cartilage now. Sorry, in my excitement, I hold the suction very tight. So after some time, I start getting a little crampy and yeah. Drill. ಇದಲ್ಲಮ್ಮ ಇದು ಏನ್ ಕೊಟ್ಟಿದೆ ಇದು ಸ್ಮಾಲ್ ಕಟಿಂಗ್ ಸ್ವಲ್ಪ ದೊಡ್ಡ ಕಟಿಂಗ್ ಕೊಡು ವಾಟ್ಸ್ ದ ಟೈಮ್ ಓ ವೆರಿ ಗುಡ್
11:40 sir.
Fantastic. We have 20 minutes here. Saline. Yes, hold this. Double-edged knife. Side knife kodu. Okay. Okay, 1 minute. Cotton. Circular knife. Yes. Now the elevation is really nice and good. Okay. Cotton. One more cotton. Yes. Okay, no saline, just give me the drill. And keep the small drill ready. Saline. Can you see the bony annulus now? Hello? Drill. Small cutting baritala aditko next.
Hello.
Yes.
Could you explain the procedure what you are doing, boss?
Now actually I'm doing a canal plasty. If you notice, Nagana, in many of these people, the canal wall will be prominent inferiorly, antero-inferiorly, and posto-inferiorly.
Yes.
For me to place the graft as well as to make sure that I've removed the disease completely, I need to have a good visualization of the bony annulus.
Yes.
Of the tympanic membrane all around once the colostoma removal is over. Saline.
Yes.
And now my colostoma removal, I'm convinced, is totally over. I need to just probably bring down the ridge and the bridge by a couple of millimeters to finish off, polish off.
Yes.
And I wanted to basically see the entire annulus for me to place the graft. Now I am able to see. I will just show that now. Can you see the bony annulus there inferiorly here?
Yes, boss.
Yeah.
Yes.
Please. Yes. So yes, alligator forceps. Yes, you can see the annulus lifted here. Okay. The medial mucosa nicely draping there. And again, the medial mucosa here. Yes. Double end knife. So I need to just elevate here a little bit. So I can place the graft nicely here now, all around here. Right. Ball probe. Can you now appreciate the eustachian tube area here, Nagana?
Yes, boss.
There
Also
was,
filled with qualified mucosa, if I am right.
see,
Qualified.
yes. I don't want to cause fibrosis there. I'm just dissecting with the ball probe. Can you see the eustachian orifice now? See there? I will just put a cotton there now. I can appreciate it well now. Okay. That's it. Ball probe. I think you give me the circular knife. Let me try and see for the last time whether there's any remnant tensor fold left there. No. One more cotton, please. Yes, the whole work is over. Smaller drill. Let me take away this cog. Sheehy's cog. And ಮತ್ತೆ ಆಮೇಲೆ ಒಂದು ಡೈಮಂಡ್ ಬರ್ ಕೊಡು ಬಿಗರ್ ಸ್ವಲ್ಪ ರಫ್ ಇದ್ರೆ ಒಳ್ಳೇದು ಡೈಮಂಡ್ ಬರ್ ಐ ಆಮ್ ಡ್ರಿಲ್ಲಿಂಗ್ ಆನ್ ದ ಕಾಗ್ ನಗಣ
Yes, boss.
Can you see this area, how deep this was? Can you see this cell? Yes. Can you see the entire cell being opened up here?
Yes, boss.
Yeah. Button. I'm through. I'm going to do the canal wall down a little bit and then put the graft. That's it.
So there are a couple of questions. Can I?
No problem. Saline. Now I can take any question because I know the exact level of the facial nerve. I know my lateral semicircular canal. I need to just reduce this a little bit, which I will do. Cutting bara kodu ಸ್ವಲ್ಪ ದೊಡ್ಡದು. Yeah, please go ahead with the questions, please.
Yes, sir. So this is a question coming from Dr. Rajkumari Khatri.
Yeah.
Sir, what are the precautions will you take while doing mastoid in pediatric age group?
First thing is look at the age. Remember one thing. Mastoid in a child is no different from a mastoid in an adult if the child is above the age of 2 years. Okay? The anatomy of the mastoid bone will not change a millimeter once the child reaches the age of 2 years. Your external auditory canal direction can get rotated a little bit as you grow into adulthood. But the mastoid anatomy, remember, will remain constant. Only if the child is below the age of 2 years, you have to be careful with the lower part of your postoral incision, which will have to curve it towards you because, you know, the facial nerve can get damaged there if the mastoid process is not there. If the child is above the age of 2 years, be rest assured that you are almost working on a adult mastoid. Okay? And look at this. I am still using a cutting burr basically because I am reasonably confident where my facial nerve is. And anyway, as I go closer to the facial nerve or the facial ridge, I will find some amount of bleeding, sudden increase in the bleeding of the bone. Saline? Yes? Okay. Manohar. Close ಮಾಡ್ತೀಯಲ್ಲ ಇದು? Okay. Yes. Graft ಅಲ್ಲಿ. Saline ಕೊಡು. Big diamond burr. What was the other question?
Yes, sir. So this, I think this one of the professor is asking. They are not named it. So for the benefit of the PG students who are watching this session, can you tell the 3 important do's or the must which a doctor should look into and 3 don'ts when operating a pediatric case?
3 do's and 3 don'ts, huh?
For the PGs.
First thing, look at the adenoids. Look at the tonsils. If the child has big adenoids, might as well do the adenoid first or in the same sitting and also do this mastoid surgery. Or you can stage it. Right? Second, in a child, always get a CT scan done. And third, if you do find a cholesteatoma, don't try to do intact canal wall and all that. Straight away going for canal wall down because if the disease is so aggressive at such a young age already, by 10 years if a child has developed this kind of what you call, yes, it means that the eustachian malfunction. Okay. Nagana?
Yes.
Are you happy with the drilling today?
Saucerizing you are doing, no? With big diamonds.
Tappa cutting bar kodu ondu. I am trying to saucerize the edges now. But were you overall happy with the cholesteatoma removal? Because you are an eminent otologist yourself. So,
Flattering.
No flattering.
I am learning from you.
No. See, I saucerized the sharp edges. Yeah? I'll place the graft now. Yes. Small cutting burr. See, the foot plate is so clearly visible, Naganda, now.
Yes, boss. Bluish.
Yes. Dikina chiku cutting. So, chiku diamond. I am finished. I'll just remove this one cell here. and close. As per Sanjay boss's orders, I am putting the yes. The whole thing has come off. Yes. Ball probe, smooth cut pick. Yes. Yes, that's the last piece of the cholesterol granuloma. Remaining thing will record drill koda. Okay. Cartilage 15 knife on the side tagomannu. Cartilage ತೊಗೊಂಡಿದ್ಯಾ? ಇಲ್ಲ. Okay. No, cartilage or okay. Top light on. External camera, please. Saline. Saline. Okay. 15 knife. नंदू से बात हुई? संजय कर दो सब, कर दो, बोलो हम खत्म करके आ रहे हैं। अच्छा,
You are removing inferior conchal cartilage, no?
yes. The spring cartilage, no? Clearly. कार्टिलेज है आपके पास? नहीं ना? अच्छा, ठीक है। Yes. Alligator forceps. Knife koda. Hey, sorry Guru. Ah. Okay. Yeah. Keep this. 1 graft. Graft ಅಲ್ಲಿ ನಿಯಟೋಪ್ಲಾಸ್ಟಿ ಮಾಡ್ತೀಯ ಮನ್ನ AdSense touch touch stop touch stop touch touch okay graft ತಗೋ 15 knife ಇದು 15 knife SMR elevator ಹಿಡ್ಕೊ ಇದು ನಾನ್ ಟೂತ್ಡ್ ಫಾರ್ಸೆಪ್ಸ್ ನೈಫ್ ಕೊಡು ಇದನ್ನ ಚೂಪ್ ಮಾಡಿ ಶೇಪ್ ಮಾಡು ನೀವು ಇನ್ನೊಂದು ನೈಫ್ ಅಲ್ಲಿ ಚೋಡಯ್ಯ ಸ್ಮಾಲ್ ನಿಯಟೋಪ್ಲಾಸ್ಟಿ ನೋಡು ಮನ್ನು ಇದು ನಾನು ಸ್ಟಿಚ್ ಆಗ್ತೀನಿ ಆ ತರ ಆಗ್ತಿಯಲ್ಲ I'm doing the neotoplasty. I think you can appreciate that. Hello.
Hello.
Yes, sir.
Hello, Dr. Haldipur.
Gauri madam also joined.
Yeah.
Yes.
This is Dr. Belsare from Pune, sir.
Are Madam Pune's Lata Mangeshkar.
How are you, sir?
Yeah, madam. I think
So actually, sir, what is the case like? Will you please explain?
Yeah, this was a attic cholesterol.
Okay, sir.
It really looked like a central perforation. And
So you have finished with MRM, right?
yes, I have finished with MRM. I found the foot plate. I'm putting the graft now actually, straight fix, smooth cut fix, gel foam. Oh, actually we are in Nagpur, madam. And
Sir.
actually, Academy has given me a keynote oration at 8:30.
Oh.
But whatever, really great to hear your voice.
No, I was supposed to moderate a session between 12 to 2. So
Acha, between for Vishwas Vijay Dev and
yes, sir.
yeah, V.S. Reddy is also there. I'm just at the end of my procedure.
Sir, no problem. It's my pleasure and privilege to be watching your case, sir.
No. We are done actually. The oozing is also stopped. Circular knife. ಗ್ರಾಫ್ಟ್ ಎತ್ತುತ್ತೀಯಾ ನೋಡು ಅದರಿಂದ ಅಥವಾ ಇದೆಯಾ? Okay, give me the gel foam. Alligator forceps. Saline. Yes. The graft is also adequate in size.
Dr. Deepak,
Yes.
have you done the total annulus excision, I suppose, in this case also?
In this case, the cholesteatoma itself had done the total annulus excision, sir, actually.
Okay.
Yeah. So I'm just putting back the flaps. Yes, and gel foam. It's an MRM, yes, madam.
Yeah, MRM.
Hey, 22 section ilva. Kodu gel foam kodu.
You are going to obliterate the canal as well with the cartilage pieces or leave it as such?
Manohar will be doing it with the muscle.
Okay.
But actually, we are already running late for the next surgery. What's the time, Munka sir, now?
It's 12:15.
Ah, correct. Dr. Vishwas Vijay Dev is ready in our Trustwell Hospital, Bangalore.
Yeah, Dr. Gauri, so nice to listen your voice. Same with me, I had to moderate at 3, but since I finished my case, I joined from the mobile.
Yeah,
and when
and again,
operating, I thought it's better to join.
Prakash Munka sir being a personal friend, even Sanjay Agarwal is happy to hear your voice here.
Yeah. Sanjay is also a good friend. All of us are good friends, boss.
Yes.
And it's always pleasure meeting us in person, but at least it's good, whatever we.
Thank you. Sir, I will be signing off.
Yeah.
With ointment, a stitch, ribbon gauze. Thank you, boss. Thank you so much. Thank you.
Thank you, sir.
ಕಾರಲ್ಲಿ ಏನು ಏರ್ಪಾಡು ಇಲ್ಲ ಅಲ್ಲ?
हेवी बरोबर. हे 12 आणि हे 12 आणि 20 म्हणजे 32 झाले.
Sir, Dr. Manjula here. Sir, there are 500 PGs. Would you say something to them before you sign off, sir? 500 PGs who are logged in various medical colleges. Deepak, sir?
Ranjit.
Okay.
Hello, Dr. Deepak, am I audible?
I think Deepak sir has signed off. I think he's got a session talk at 12 o'clock in the conference.
Okay, then we'll, sir can come later. Can we, should we move to the Trustwell and this becomes PIP?
Yeah, Trustwell is ready now.
Yeah, because there's nothing happening here. Or Nagpur, can we make go to Trustwell, or you would like to say anything?
Just a second.
I think it can be made PIP and move, Dr. Krishna.
Yeah, I'm just working on it.
Yeah.
Come on. तर तुमच्या हाताने मोजा बहुतेक असेल
30 आहे
एकदम मोज
70 आणि 30 आहे
नाही हे 3 आहे हे मोजले मी हे 30 आहे आता
हे 30 असते
मोजा तुम्ही
3 4
30 आणि या तिथे 7 आहेत ना म्हणजे 70 मोजून घ्या हे 10 म्हणजे हे 42 सगळे मिळून म्हणजे 21
Hello.
Vishwas sir, can you hear us?
Yes, ma'am. We can hear you very well.
Okay, can we start then?
Yeah. Good afternoon to everybody from Trustwell Hospitals, and it's my privilege to be before you with our team here, the anesthesia team being headed by Dr. N.S. Chandrasekhar sir. I hope you can see the video. N.S. Chandrasekhar sir, who's the director of anesthesiology and at the same time pain services, and he's also going to be speaking today on the various aspects of anesthesia and pediatric ENT and the various conundrums. And the entire team out here, Trustwell Hospital is geared up for the ENTrain Workshop, and thanks to Microlabs team for giving us this great opportunity to showcase this procedure, which as per the feedback and as per the survey sent out earlier, has got the maximum what you call options or response. So they want to see a pediatric septoplasty. Today, I'm going to demonstrate the pediatric septoplasty via the rhinoplasty approach so that I can demonstrate better and show you all the structures. For now, we have just infiltrated the patient, and then now the painting and draping is going on. Meanwhile, I would like to invite Dr. N.S. Chandrasekhar sir here to speak on the requirements for anesthesia in children. And he is an excellent speaker and is an encyclopedia of information with 40 plus years of experience. So over to you, sir. Thank you, Dr. Deepak.
Dinesh
It's
team,
foggy.
can you
That
make
means
us
it's
a
leaking somewhere.
focus
Give me
video?
another plastic.
Speakers.
Good morning, everybody. Greetings from Trustwell Hospital. I'm Dr. N.S. Chandrasekhar. I'm head and senior consultant anesthesiology, and I do pain relief and cancer pain relief. My colleague is senior consultant Dr. Jaydev, and consultant Dr. Josna, and we have 2 registrars, Dr. Nayana and Dr. Kavna. Today, I'll be discussing more on the conundrums of anesthesia in related to otolaryngology, what we commonly come across, and which is puzzling both for anesthetist as well as the surgeon. So I don't want to go into the detailed depth of any of the type of anesthesia, because each anesthetist has the whims and fancies of giving with their own techniques. But I'll be discussing what are the consequences where we have to be careful in pediatric anesthesia. Since last decade, regarding functional endoscopic surgery, there is a radical change in surgical techniques, and we are seeing many complicated cases our surgeons performing. Now it is expanded to the pediatric case also. So pediatric cases, now we are doing many of those angiofibroma, polyps, septoplasty, septorhinoplasty, all those things. The most concern in between the anesthetist and the surgeon is
Sir, your audio gone, sir. Dr. Chandrasekhar, sir, we are not able to hear you, sir.
Oh, sorry, it was not heard. Can you hear me, madam, now? Hello?
Yes, sir. Yes, sir.
Yes,
Okay.
yes, sir. It was heard till the last sentence, sir.
Okay. Earlier, you didn't hear.
We heard everything till
Okay.
the last sentence.
Okay, thank you. There's some problem with the battery. Mic is on. Thank you. Sorry. So coming to this, so we are witnessing one of the wonderful cases in pediatric surgery, particularly which I explained, angiomyxoma and complicated other surgeries. Every surgeon and anesthetist wishes to maintain a bloodless field. So we use vasopressors, adrenaline. Each time when adrenaline is taken up, the surgeon will always ask the sister will ask the anesthetist, how much I load for this? So today I am going to discuss what could be the dose of adrenaline, what is the safety, what is our limits, and what concentration we have to do. And in case if we develop any complications, how to address these issues. Let us go back to our MBBS days. Let us understand what is the pulse rate, heart rate we have to keep. I know my very good friend, Dr. Deepak Haldipur, always tell whenever a case starts, he says that Dr. Satish Jain always insists me to keep the heart rate down between 70, 80, 50 and all. Can we keep that kind of heart rate in a pediatric? Is it possible? Because pediatrics are the miniature of adults. So let us go back to our MBBS, refresh our MBBS days. Being, all our ENT surgeons, I don't want to go into the depth. Let us look at the heart rate. Heart rate in fetus is around, in FHS, we always measure probably around 140 to 160 or 120. Then at the birth, the heart rate will be there around 120, 130 pulse rate. And progressively, it will come to probably as the age advances, maybe around 70 to 110. With this patient, probably 8-year-old, could be the heart rate maybe 70 to 100. So now, why we have this kind of heart rate always raised, sympathetic, that is well-established sympathetic tone compared to the adults. So in an adult, if hypoxia occurs, the heart rate will go up. It will become tachycardia and eventually the bradyarrhythmias. In pediatric, the pulse rate is already high. The moment patient becomes hypoxia or child becomes any lack of oxygen, immediately the bradycardia will set in. So all anesthetists are very careful about the bradycardia to reduce the reduced heart rate. So, but here we have to reduce the heart rate also for your field of surgery. So let us discuss how much we can bring down the heart rate in pediatric population. Okay. Now, why this heart rate is always high in pediatric? So they have a well-established sympathetic tone. Let me go elaborate little detail. In fetus at the birth, the suprarenal gland will be always bigger than kidney. It's always well-established suprarenal gland, which is the house of all catecholamines. And it will, over a period of year, it's come down. That is why the sympathetic tone will be always high in the pediatric age groups. So now, so this is the keeping in mind. So what we give, how much dose we have to use for this pediatric cases? We have to be very specific. The adrenaline dosage or SOCA should be according to the New York guidelines. There is a New York phenylephrine group, advisory group, with the standard guidelines mention that it should be 20 mics per kg body weight, maximum of 500 mics, that is 0.5 ml of adrenaline, whichever way you use up to that, up to 25 kg body weight child. Okay. Now, what happens in case patient develop tachycardia now? So I have to give beta block. So our surgeon says that you reduce the heart rate. What happens if I bring down the pulse rate in a pediatric age group to a significant level? This is the most important event. situation probably, because if you understand the adrenaline consequence, adrenaline is a beta stimulant and as well as alpha stimulant. So beta stimulant raises the heart rate, while the alpha receptors acts at the periphery. So it causes intense vasoconstriction. Now, patient is having already 150, 160 pulse rate. And because of the surgeon's anxiety and anesthetist's anxiety, I give beta block. Now, if I reduce the heart rate, what happens? The pediatric gauge group, they highly dependent upon the pulse rate. If we reduce the pulse rate, the stroke volume come immediately. There are many reported incidences of cardiac stunning. The heart will immediately stop and it leads to rapid pulmonary edema. So we should be very careful in using the adrenaline as well as the beta blocker itself. So this is one of the important. We are totally once we give the beta blocker, the alpha action will be uninhibited. So patient will be extremely vasoconstricted and the heart rate is reduced. So there will be intense afterload to the heart, and the heart will balloon out. We call it as cardiac stunning. So there are many incidences which has been reported, and many mortality is there in that. So I insisted to use the very careful about the vasopressors and adrenaline. I wanted to demonstrate how much we have to use the vasopressors. Can you focus here? Yes. Camera can focus here. Because many times it is very puzzling. All the sisters will ask, sir, can I add 8 drops? Or can I take Zalakin 2 per adrenaline 5 ml and dilute it with another 10 ml? So let us be very specific how much we can use. So I'll be I'll be just demonstrating how we have to calculate the adrenaline dosage and how we should be useful for we can estimate the dosage for the pediatric. So this is the, can you focus here? Yeah.
Focus the camera here, please, on the table.
I'm loading the adrenaline. Yeah. Okay. I'm loading the 1 ampule of adrenaline. It is 1 milligram in 1 ml, that is 1 in 1000 concentration. Can you open this? So this is 1 in 1 ml of adrenaline. Now I'm making 10 ml. So this will become 0.1 milligram per ml. Okay. Now we have to take 1 ml of this. Sorry. Can you see? And dilute it to 10 ml. So this will become 0.01 milligram per ml. So we can use up to 5 ml of this solution, 0.01 milligram per ml, up to 5 ml we can use in this. And to add to your solutions anything, we can add 1 ml of this 0.01 milligram solution to every 20 ml. So we will get around 1 in 880,000 solution, which what regularly used for Zelokin with adrenaline. So this concentration you have to maintain, whether you you might require the more or less. We can, if you wanted to use more, we have to give a break for maybe 1.5 hours. Again, once because the adrenaline rapidly metabolizes, we can use it subsequent maybe 1 hour later or so. But we should not exceed the dosage. There has been a lot of cases which has morbidity and mortality has been reported. If you have any questions, I can definitely happy to answer in the over a period of time. Thank you, sir. Thank you very much.
Hello. Hello.
Yes, sir. Yes, sir.
Can you hear me, sir?
Yes, sir.
Very clear, sir.
Yes, sir. So coming back again, ma'am, namaste to Gauri Balsare, ma'am, for moderating this session. And if Dr. Vishnu Swarup Reddy, sir, is joining in from Hyderabad, thank you to him as well.
He's joining in a minute, sir. He's joining in a minute.
Oh, great. Great. Thanks. I mean, these are the people who I look up to and who have led the way in the ENT specialty in a big way. I'm very grateful for them to accept to moderate my session and guide us all along the way. So to begin with, my fellow in facial plastic surgery, Dr. Jerin, will be explaining about the case, and then I'll go to the photographs and the history and give a little more detail so that we can begin with the surgery proper. So
Good
can
morning.
the PPT, ma'am,
Good
ma'am,
morning. Good morning.
very good afternoon, ma'am. Thank you. Thanks for coming here today.
We are really happy to see that there is some different topic. Pediatric septoplasty is definitely a challenge. There are a lot of issues and there are controversies. We will be happy
Yes, ma'am.
that you will elaborate on this topic, which was never covered in any live surgery. So thank you
Yes,
for
please.
demonstrating this case.
I should actually thank Microlabs team headed by Mr. Durga Prasad and Manjula ma'am and all of them for coming out with this survey, which they send out to ENT surgeons well in advance, asking them what they would prefer to do, or rather what they would prefer to learn from the experts. And pediatric septoplasty actually rated the highest. And that's why we chose to do that. And today, ma'am, I'll just go through the case history. That is, our fellow Dr. Jerin Jose Thomas will go through the case history, and then I'll tell a few more details, and then we can proceed with the surgery itself. Can the PPT come up on live, audiovisual team? Ma'am, how is the camera feed? I mean, there are two cameras we have fitted. So
It's very, we can see only one camera.
Okay.
Retome actually we can see.
Yes, ma'am.
With a nose being painted and ripped. Yeah.
Actually, it's not a VTOM, ma'am. It's a modification done by Vikram sir and Gajanan Kashit sir. And they've thankfully given it to me, this apparatus, what they've done. So we have fitted a SPICE camera onto a coupler along with the lights. And we are also using company Futudent camera, which is a very small camera. This is the other feed from the Futudent camera. So we have two feeds. So if you feel that any one feed is not matching up, or it is not this one, you can always ask us. We will switch between the feeds. Then there's an external camera also to visualize, let's say inside, if you have any problem, we can do that as well.
Okay. That's a great, means we would like to see this jugaad also. Like
Definitely, ma'am. It is arising out of Maharashtra. So I would be more happy to tell about it also. Vikram sir, if he is there listening in, thank you, sir. And Gajanan Kashit sir as well. Can the laptop, I mean, can you get the PPT presentation of the patient, please? I will explain, and Dr. Jerin also will be explaining it. No, they have it. The Microlabs team has it. They can share it. Mr. Bhaskar, can you please share the PPT?
Yes, sir. Sharing it.
Yes, sir. So, and at the outset, my profound thanks to my mentor, Deepak Haldipur sir, and our senior faculty, Dr. Vijendra sir, for making this possible and taking us through all the common ENT surgeries, how each of us face simple problems every day. And the Microlabs team, especially the Micro Knowledge Academy, has been very, very generous to take care of the teaching aspect and bring out books also in this regard. Now, going over the history, I hand over the mic to Dr. Jerin. The camera on him, please.
Hi, good afternoon, everyone. Am I audible?
Ma'am, is the PPT visible?
Yes, yes.
PT is visible and he is audible also.
Yes.
Yeah, come, go there, go there, go there, go there. I'll need a pointed.
Good afternoon, everyone. Today's case is about Moksai, 8-year-old male child. He's been complaining of breathing difficulty since 2 years, and he has an external deviation of the nose to the right. His parents complain of snoring.
Take the table this way.
Along with mouth breathing at night. Occasionally, he has sneezing with blocked nose during winters, with added symptoms of sleep apnea. There's no history of trauma to the child. And next, we'll go to the facial analysis that Dr. Vishwas sir will go ahead with.
So herein, ma'am, since this child is 8-year-old, so the most pertinent question before us is why at all operate on this patient for septoplasty? Now, this child has something we call as a progressive septal deflection or a deviation, because of which he is really breathless and he is having symptoms of apnea as well. And that is almost an absolute indication for going ahead with the septal surgery. Along with that, he has seasonal allergic rhinitis, and that is when he struggles the most. So literally 4 months, he is tossing around in the bed and not able to sleep at all. In the rest of the times, he is having apneic spells, and that's the reason we had to take him up for surgery. So he's been consulting me since the past 1.5 years, and what I could notice is the deflection is increasing more and more, and the block is increasing more and more. And that is the reason we had to plan to take up for surgery. Normally, if it is a child we want to do septoplasty, the preferable age is 2 years after the female child attains menarche and the male child gets his mustache. But nevertheless, what we can also do in some of these absolute indications or trauma, where it's a congenital lesion or is a progressive deformity like this, we can operate early to give a patient a relief. So coming to the view of the patient on the frontal view itself, although this is not a strict rhinoplasty analysis, I would like to mention the pertinent points for the completion's sake. Now, looking at his entire face, you can see that the horizontal thirds, the nose looks shorter because it appears to be starting opposite the pupil rather than the supratarsal crease. So the horizontal third seems okay. As you see from the upper third, the brow tip line, which is a smooth aesthetic line falling forward to the tip, is broken at 2 points. It is broken here. So what is actually happening is the upper third is straight and then there is a deflection again. So you will see it subtly in the surgery also that there's a deflection happening at the mid dorsal point and the K area. So what is happening is, I can come this side. I can come this side. Sorry. Yeah. So there is a deflection from the mid dorsum points to the right side. So because of the deflection, you can see that the brow tip line is broken and the upper lateral cartilage assembly or the impression is more prominent this side. It is more straighter this side. As you go down, you can see that the lower lateral cartilage prominence is also prominent, whereas this side it is less prominent. If you go down again, you will see that there is asymmetry on the nostril. The one on the left side looks more oblong. This looks more rounded. If you take the entire nose itself, for a child, normally they have under projected mid dorsum, they have under projected tip. So we are not looking at aesthetic points here, but just to mention what all is the features, salient features in children. They have rounded tips. They do not have sharp tips or defined tip defining points. So this looks okay. And the underlying asymmetries are hidden by the moderate skin that he has. So if you look at carefully, you can see that there's a prominence on the right side of the cheek and a lower prominence or a deeper groove on the left side. So this is what happens. Normally, if we do a, sorry?
Can there be enlarged adenoid in addition to the deviated septum?
Yes, ma'am. In fact, we did an endoscopy. Dr. Jarin will be showing it next. So
Okay.
I'll just go through these views and then we will discuss again, ma'am.
Sorry for interruption.
That's all right, ma'am. Not a problem. So Now, the problem with leaving a septum unoperated at this age, which is deflecting badly, is manifold. One, obviously, the form and the function. The second is the midfacial growth. The part of the maxillary crest is responsible for the midfacial growth, so it can cause asymmetries if it is neglected. And also, you can have obstructive sleep apnea symptoms like in this child. At the same time, they can have malocclusion problems. And obviously, once they become teenagers, they are worried about psychological stigma as well. So this is the reason many times, along with correcting for the form and the function, that is the breathing per se, we can also think about the later growth part. So that's the three-dimensional part for us, because the nasal growth continues to happen. Next slide, please. Next slide. Yeah, so the profile view is very classical and you can see a lot of features there. Now here, the point from the subnasal to the menton looks long, whereas the nose looks short because it appears to be starting from opposite the cornea. So it's a shorter nose and a long forehead and a longer chin segment, if you look at it. Then if you go to the top part, the radix point is quite deep, and normally the nose is supposed to start from this point opposite the supratarsal crease, but here it is starting from way down. That's why the nose looks shorter. And you can see that there's a mild hump, or rather a pseudo hump, along with a polybeak deformity. Classically, in a child, we do not really worry about all these features, but for the sake of the rhinoplasty, I'm mentioning this. And he has a polybeak along with no definition on the supratip break or the infratip break and the lobules. So it looks more like a hooked nose or a parrot beaking with a slight ptosis. Now, if you look at the nasofrontal angle, it is almost obtuse more than 110 degrees. If you look at the nasolabial angle, it is also obtuse. Normally in children, it is obtuse and rotated up rather than being straight 90 degrees like in the adult. So this is an acceptable aesthetic standpoint for the child. And few more points in the profile view that you can see is the projection should be up till here because of the 3-4-5 ratio, but it is under projected. It is way back to the expected projection, and the columnar show appears to be adequate. So we cannot define the tip correctly by the double break point. You just see one point and where it turns around. So these are the features on the profile view. Next slide, please. So this again, the same point. What you can see is the columnar show or the nostril show is more on the right side, telling us that there is a asymmetry in the nostrils as well. Next slide, please. So this is the helicopter view. You can see a subtle movement of the cartilage from the mid-dorsal point to the right side. And as we open, you will also be able to appreciate the same thing. And the upper part of the nose appears symmetrical. As it goes down from the upper lateral assembly, it turns to one side. Next slide, please. So here we can clearly see the equilateral triangle ratio that has been maintained. But at the same time, you can see that the axis is tilted to one side. There is slight asymmetry of the nostril. This is more oblong, this is less oblong. And the supratip lobule is well defined, but the infratip lobule is not that defined. Tip defining points are also not defined. We would call this tip more of a bulbous tip rather than a sharp defined tip. But obviously, we are not looking at those things in a child because this looks more beautiful on the child rather than having a sharp tip. Next slide, please. Yeah, so the vestibular examination, or rather pulling the tip up and the tip recoil is what we do. You can see that the septum is deflected to the left and moving towards the right. You can see the caudal dislocation here. So it is moved off the axis. Now, if this movement of the axis is more than 30 degrees, that is when we will have to plan something called as an extracorporeal septoplasty. Of course, this is the plan. We will get inside and see what has happened. And we might actually wonder, why can't we do this surgery only through an endonasal approach? Now, what happens is endonasal approach, our axis, as you will see later in the endoscopy, our axis is totally limited to the deflecting segment of the septum. And there are a few other advantages which I'll mention on the go. Next slide, please. Yeah, Dr. Jarin can complete the examination part. Mike, please.
Welcome,
Mike,
Dr.
please.
Vishnu Reddy, sir. Vishwas, sir, Dr. Reddy also has joined. Vishnu Sarup Reddy, sir, has joined.
Oh, good afternoon, Dr. Vishnu. How are you?
Hello, can you hear me?
Yes, sir. Very well.
Yeah. Good afternoon. Sorry for being late.
No, that's fine, sir. We are just starting off now.
I was doing cochlear implant surgery at the local.
Oh, okay. Great, sir. Very nice to know. In fact, we just started with the history, and our fellow Dr. Jarin will speak about the examination findings as well.
Hello, good afternoon, everyone again. So the examination findings, we have a severe DNS on the left side with a complete obstruction of the left side and a caudal dislocation of the septum to the right side. The caudal test is negative on the left side, and the patient also presented with the congested eyes. On endoscopy, we found that we couldn't pass the endoscope to the left side, but on the right side, as we passed behind into the nasopharynx, we had a grade 2 adenoid hypertrophy, the pictures of which will be shown ahead. And also, when he presented with a high arch palate as well as postnasal rib.
Next slide,
please.
Don't stand.
This is just a picture of the right side showing the anterior caudal dislocation. Next slide. On the left side, it was completely obstructed. We couldn't pass the endoscope.
Table to move
and
that
the
side.
internal nasal valve was completely obstructed. Next slide.
Move fast.
Can you play the video, please? Play the video, please. Can we go back? Yeah. Yes. So the left was completely obstructed. The right side
After decongestion.
after decongestion, even all the way to the back. So that is showing the adenoids with mild postnasal rib. It's a grade 2 adenoid hypertrophy. Yes. Thank you, Bhaskar. Now on to Kishore sir.
Gauri ma'am and Dr. Vishnu sir, anything you want to ask us before we start off with the surgery?
Hello. Hello.
Yes,
Hello.
Dr. Vishnu. Yeah, we can hear you.
Yeah. Sorry, I missed it because there was some poor connection. Yeah, I think you have explained in detail about the deformity, and you're going to start by external approach. That's what I heard, and you are describing the deformity when I just joined.
Ready. Check. Yes, sir. The reason to opt for an open rhinoplasty approach is you can see that the septum is moving from this side to that side and almost at the lateral wall. We couldn't even pass an endoscope inside, and he's struggling quite a lot because of this. And that's the reason I had to opt for an open rhinoplasty approach. Otherwise, we would have gone the endonasal approach and only removed the parts which are relevant for breathing. Herein, our approach is defined for maximal exposure with minimal incisions, or rather with minimal cuts. So we try to preserve more structures rather than try to cut more structures. So if at any point our visualization is not adequate, sir, please let us know. We'll be happy to adjust our cameras. Hello?
Yeah. How old is the child, Vishwas?
Sir, he's 8 years old.
Okay. Good. I just had maybe 3 months ago a 7-year-old similar deformity.
Yes, sir.
I was just mentioning nose. I mean, that was my first patient with 7 years age for a septoplasty. Generally, I have done for around 10 years age. But this was my first patient with 7 years. And but I think I struggled using an endoscope and managed endonasally. But here, I think if you are demonstrating, it's really quite good to show external approach.
Yes, sir. That would be preferable.
And keeping an endoscope in hand may be helpful, Vishwas, to show inside.
Yes, sir.
I'm sure you may be having it. You're operating at Trustwell Hospital, isn't it?
Yes, sir. At Trustwell Hospital.
Yeah.
And I'm happy to say that Trustwell Hospital has coordinated almost 4 international workshops already, and they have been very benevolent to give their OT facility and their staff to us. With our Chief Director, CMD, Dr. Madhusudan, Dr. N.S. Chandrasekhar sir, and Dr. Deepak, who have been the guiding force for this hospital. So without much delay, I will just speak as I operate. Now, I will also tell the points which are relevant in the child, what to do and what not to do. That would be most important for us to remember. Now, for an incision in open rhinoplasty, as is for any adult, we would go the mid-columnar approach. We will try to stay as inferiorly as possible. Although we are not looking at doing any projection, the way we do it is have a stab incision. Sister, keep 11 number blade ready.
I think if the camera is focused, if you zoom the camera, it will be better. If they zoom the camera to the columella area, cameraman, external camera, if you can focus, I think close to the nose.
Yes, sir. I'm assuming you're seeing the incision.
No, it's very small because I don't know. Yeah, now we can see better. Yes.
Okay, so once I made the stab incision in the inverted V fashion, I go perpendicular right over the edge of the medial crura. Then I go up to the soft triangle, define it with the blunt part of the blade, and slide my knife down to meet the incision which I have drawn perpendicularly. Sister, give a different blade, please. Not cutting. No, 15 only. Give another blade, please. So the cartilages are very delicate in this child. So we will have to go slow. Keep mopping. Wet gauze piece. Yeah. So what we have done is we have infiltrated this child before half an hour to be able to get sufficient vasoconstriction. So the mixture we use is standardized by our anesthetist, senior anesthetist, Dr. Jaidev sir. We use a mixture of 2% lignocaine with adrenaline, which is diluted with 0.25% bupivacaine. And in a child, we would dilute it further with normal saline, about 10 ml. So the approximate quantity of the infiltration that I do will be almost, angle scissors, 5 to 6 ml. So once I made the vertical incision just near the medial crura, I insinuate my angled scissors in such a way to come to the mid-columnar point. Please remember that the skin is quite thin in children, and that's why you need to be slow. Don't have to hurry. Just keep moving the scissors in such a way that it dissects by itself. Don't use force. Dissects in such a way that the division itself spreads the tissues rather than you cutting with the scissors. 11 number knife, please. So then I use 11 number knife. Should give the other BP handle. Hold this here. Hold this here. Yeah. And use your blade in the reverse direction. Try to cut in the incision line that you've already made. So you can see there's some soft tissue still there. 11 number, please. Keep skin hooks ready and bipolar cautery ready. So there is some ooze that we can see right now. Again, 11 number knife, please. So complete the incision. The underlying scissors act as a guard for you to cut the soft tissues, and so that you don't have to cut the medial crura. Even if you inadvertently happen to cut the medial crura, you can be rest assured that you can suture it together, but it is better in children to be as conservative as possible. Knife, please. And not injure any structures. Suction. Keep suction ready. And show me the edges. I'm not able to see the edges here. Yeah. Use a 1 number size suction, please. Yeah. Knife again. Knife again. Keep the knife with him. Suction, please. Mop there. So I go to the opposite side. It being a delicate skin where the septum is not supported, you just have to insinuate very, very carefully. And once you insinuate carefully, just make sure, again, as I mentioned, don't cut too much with the scissors, more of a spread to be able to reach the point. Just a second. Knife, please. New 15 number knife that we took. So the incision was not complete here. As you can see, I am completing it so that I get a better angle at dividing the columellar skin.
Sure.
11 number knife, please. So please use sharp cuts most of the time rather than blunt cuts. Dr. Vishnu, you can mention any points that you think we are leaving behind as we go ahead.
Yes, Vishwas, I think the mid-columellar incision, I think, came a little bit lower side. Probably could have gone a little bit up, but doesn't matter.
No, in children, we keep it lower.
It appears like that.
Now, children, we keep it lower. The reason is there is movement of the supratip portion in growth.
Right.
And we don't want the scar to migrate up. And that's the reason we keep it a little low. I mean, that was intentional, sir.
Okay, okay.
Okay. So I use cautery to a point of 15, setting sometimes 10, depending upon how effective the cautery machine is. And
Yeah, there will always be a bleeder there. I think we should.
Yes, that's a mid-columellar vessel. That's a mid-columellar vessel. So that is what I'm trying to delineate now.
Yeah.
I hope it is seen on the screen, sir.
Yes.
Don't section. So you cut very cleanly on that. Buzz any additional vessels that may be there on the side. Yeah, skin hook next. Second skin hook. Take smaller ones. Take smaller skin hook. So there is some soft tissue attachment here. That also, again, I'll try to delineate. Bipolar. Gauri ma'am, any doubts at this point in time? Please feel free to ask me.
Good morning, Dr. Gauri. I think I'm not seeing you here.
Be gentle, Jared. Be gentle with the hold. Don't pull. Okay. Halar retractor system. Don't suction. Gauze piece. Bipolar. alar retractor system. Arrange the bipolar correctly. So there is one small bleeder at the base of the columella. Just trying to get that burst. Yeah. So now you can see that the medial crura is defined. So run your scissors gently along the medial crura and cut any soft tissue attachments there. And slowly you can get to define the intermediate crura as you go higher. Now this is the soft tissue that is connecting the intermediate crura of both the sides that I am trying to release. Again, you can see that the medial crura definition is coming up slowly. So what I've done is put one finger above to bipolar, please. To be able to push the medial crura outward, and then I'm using the scissor itself to cut into the skin. Now, the cartilages here are very fragile, so you need to exercise caution as you go ahead. So I'm using a combination of both feel and vision to go ahead and release the intermediate crura. I am not going to hurry here at this point, because for us, having the intermediate crura intact along with the medial crura, that angulation is important for the future growth. So we are not going to try to damage that. Need to exercise caution there. Now this side I'm going to do it, and I'm releasing the skin with one blade of the scissor itself. Can you see, sir, how it was done?
Yes, we can see very well. We can see the dome area, actually, left side.
Okay, so now
you can just follow the border. I think just following the border, the
go slow. Don't
just
push.
Following the medial crest, lower border.
Yeah. So now you can see that attachment of the intermediate crura to the skin. Now that is retained in many people when they're doing preservation rhinoplasty, but here, since we have to open up the septum, I have no other choice but to cut this and move ahead. We cut it as low as possible, rather keeping more tissues on the skin rather than more towards the cartilage.
Yeah, that gives a bloodless dissection as well. If you stay closer to the cartilage,
yes,
the field also will be bloodless, and it's very important to be in that field.
No, please.
Dr. Vishwas.
Yes, ma'am.
Is it hello?
Please. Yes, ma'am. I can hear you.
How challenging it is to do this opening of the nasal wall in pediatric age group, because the skin is
very thin, ma'am.
Thin, huh?
Yeah. So it is challenging, ma'am. I won't say it is easy, but at the same time, if we follow the basic tenets of rhinoplasty, of preserving more structures and going slow, trying to get everything into alignment before we do the incisions, then we can do it. The main point where we are likely to make a mistake, at least initially in my career, I also did it, was this area wherein we are trying to separate the skin from the cartilages in a pediatric population. So that's where we can tend to injure it. So if we go slow and sequentially, we are likely to be safe, ma'am.
And with the good infiltration, I think it may be a little easy to.
Easier, yeah.
Yeah.
See, once you reach the dome, I think the dissection should be downwards.
Yes,
and,
sir. So what I'm
as
trying
we
to
all
do,
see, yeah.
I am trying to go supraperitoneal plane, and I'm using the scissor at the edge of the Ella retractor, please. Mop, please. Mop means the whole blood has to be wiped out. Get me another skin hook, sister, from a different set. Hold this. Get me a free gauze piece. Yeah. Just give me a second, sir. There is some amount of ooze. We'll try to control it as we go ahead.
Vishwas, Dr. Vishwas, sir, I want to know that in pediatric age group, what is the preferred approach? Open structure, or we can do it like a typical septoplasty, which we do from inside?
Ma'am, we can do the endonasal or the septoplasty approach.
Right.
But closed rhinoplasty we would never do because we cut through the cartilages. That would be a strict no-no. Open rhinoplasty in the long term is quite safe, and it doesn't restrict growth much. It only has a mild restriction in the projection and the mid dorsum. Other than that, we don't see much of a variation in the growth. So something like this where the deflection of the septum is quite prominent. Gentle, please. Ella retractor, sister.
Very sharp, very gross deviated septums.
Yes, ma'am. We would prefer, definitely we would prefer doing an open rhinoplasty. Hold this gently, please. You need to be very gentle. Don't tear through. That's what I'm instructing my assistants, ma'am. Since the cartilages are all fragile, I'm asking them to be very gentle with the pull of the skin hook as well, which is at the intermediate crura right now.
But very beautifully you have dissected, Dr. Vishwas.
Thank you, ma'am.
I can feel that it is very challenging to do the same job in a pediatric population.
So this is the main
ligament of Pittangi.
Yes, ma'am. So what I cut at that time was the superficial ligament. So this is the deep ligament which goes to the top of the dome. So what we cut that time was in between the dome. What we are cutting now is at the top of the dome.
Right.
Dr. Gauri? Hello.
I just buzzed it at this point, and now I'm releasing it from the cartilage as much as possible. So our purpose is to keep more soft tissue at the skin rather than more at the cartilage and go supraperitoneal way. So here, we are not planning to do any tip work, or rather, lid retractor, please. Anything drastic on the tip. So that's why my lateral dissection will be limited only to an extent which I require to do the septal work and get the assembly back in position. Lid retractor, please. You have a smaller lid retractor. Smaller lid retractor, please. Keep peanuts ready. Ma'am, you can see here, this is the difference in a pediatric population's lateral crura. The lateral crura is almost vertical. Ma'am, can you see this here, the orientation?
Yeah, yes, Vishwas, we can see you.
Yeah,
Hello.
so it's almost vertical.
There is some communication gap. Hello?
Yeah, almost a lateral crural malposition that we can say, wherein the crura is oriented almost vertically along the upper lateral cartilage. So I try to limit my dissection here because this soft tissue is something that we would definitely want to keep. But the reason I'm doing this right now is to understand how much of the septum has been deflected from the K area. Bipolar, please. Give a saline wash there to delineate the tissues and show the tissues correctly. So these are the attachment of the SMAS layer to the skin, ma'am. Peanuts. So now what I do is I use a peanut on the septum and on the cartilage to delineate. Now I don't want to use the scissors anymore. I'm trying to push the soft tissues with the peanut itself so that I know the exact plane, because if I use a scissor and keep cutting, I'm likely to cause more bleeding. So let me try to reflect what has happened here. Now, can you see, ma'am?
Yes,
Hello?
Vishwas, we can see you. Hello.
Yes.
Yes, we can see.
Yeah. So this is the this is the lower lateral cartilage, lateral crura, and this is part of the upper lateral cartilage here. Can you see this, sir?
Yes, yes, yes.
If it is clear, then I'll proceed with the further dissection. So here I'm trying to get into the supraperichondrial plane by spreading it. Can you see, sir?
Yes, yes, very clear.
Yeah. So this is the place where the deflection has started, and that's why it is so very fragile. Now let's open the intercrural ligament so as to go further. Now I don't want to proceed on to the upper third because we don't have any job out there to do any osteotomies. If at all there is a deviation there, then we will have to do a micro-osteotomy through the percutaneous approach. So here this segment looks straight enough, so I'm not going to cut open the upper lateral and the septal assembly, which would be advantageous not to cut open in a child. Now here I'll try to see if I can insinuate my scissors a little more and release the lateral crura a little more to give me a slightly wider angle while performing the surgery. Okay, give a saline wash, hold this. Don't do suction, don't use suction. Cautery not working. Please clean the cautery tip, please. Yeah. Clean the cautery tip. Hold this glass piece and pull it out. Yeah, thank you. So as I go laterally, you can see that I have not gone strictly supraperichondrial because the muscles are attached over there. These are the muscles which help you flare your nose. And I don't want to be dissecting them off the cartilage. So I've tried to keep just a skin exposure width and not try to worry about, just hold this lid retractor, please. I need a better cautery which works at the tip, because as soon as this get blocked, no, it stops working. No, that's okay. So now I ask for a cartilage holding forceps. So with the cartilage holding forceps, we'll try to see where the anterior septal angle is. This seems to be here, and there's a caudal dislocation, obviously, so it has moved to the right side. So let us start splitting the intercrural ligament space and try to reach the edge of the septum. So it's good to expose the anterior septal angle because that gives us a definition of where to start the dissection as well. Can you see it, sir?
Yeah,
Is it-
we can see anterior septal angle.
Yes, sir.
Vishwas, yes.
Yes, sir. So
Very
please
well.
interrupt me if you're not able to visualize anything, or if I'm not able to
Yeah,
communicate across,
yeah.
sir. I'll be happy to stop and show. So I use sharp dissection at this point. I believe in going slow in this pediatric population because I try to avoid tears as much as possible. Relax.
Yeah, just staying in midline is very, very important here. And, of course, this case, the caudal deviation is there. Just to follow the anterior septal angle and then dissect downwards. If you go either way, you may damage the skin.
Yes, sir. So skin is the most crucial point here, along with the cartilages. Rest in between is okay to cut and move ahead. So I'm not planning to split the upper lateral cartilage here from the septum. Now my main intention is to find the caudal edge of the septum and delineate the septum from below itself.
What is the blood pressure the anesthetist is keeping up there, Vishwas, for the child?
Yes, sir. I can ask them.
Because general anesthesia always bleeding is a nuisance, but we have very good field, bloodless field.
Oh, we are lucky to have
bipolar is,
some of the best anesthetists with us, sir. They have spoiled us actually by giving such fields. And sometimes we expect this in different centers as well. Just a second. So I'm trying to see where the caudal edge is. By palpation, it is gone to one side. Get me the sharp scissors.
Probably if you use a septal elevator also, Freer's elevator, you will be able to
sir.
feel it.
So what I do, there's a trick that I learned from my teacher in the UK, is use a sharp pointed scissors. I use it like the edge of a blade and delineate the cartilage with itself. The attachments in a child won't be that strong, but at the same time, you need to make sure that you stay in the right plane. And trust me, the cartilages are very, very wobbly here. So I am literally holding the soft tissues and trying to see which is the cartilage and which is the soft tissue. So once I found the plane, then it is easier to insert the SMR elevator. But until I find it, I would not try to hurry and be overconfident. Yeah. First size speculum, please. I'll just readjust the patient position, sir. Please tell me if I'm out of focus. Get me the first size speculum, please. Yeah, thank you. Suction. Sir, is it seen? This part where I'm dissecting?
The speculum is overlapping a bit, but Anyway, you just carry on. Make yourself comfortable. Once you are in the plane, then we will be able to see better. Yeah, from here it is like endonasal septoplasty.
Suction, please. The mucoperichondrium is more stiffly attached, suction, in children. So this is the convex side I'm going at first. Scissors, please. Angled scissors. So I'm going towards the maxillary spine just to expose the lower part of the septum itself. Section. Give the sharp scissors, sister. Suction. Keep the suction elevator ready. So at this point, normally in an adult, we would like to cut near the antiseptal angle and expose it. I'm trying to be conservative here. Scissors. Okay. Sharp pointed scissors. The reason to be conservative is as minimal attachments to remove to aid the growth.
Yeah, now we can see the cartilage, quadrilateral cartilage.
Yes,
when
sir.
you
Suction, please. Fold it and give. Don't give like that. Fold it and give. Give me suction, please. Regular suction, please. Regular suction. The other suction elevator, if you can give me, is better. There's one more suction elevator, no? Yeah. So ideally, what would happen in an adult patient is we would split this layer and then expose the septum in entirety. So till the last minute, I will try to SMR elevator, the sharp one. Yeah. Till the last minute, I'll try to stick to dissecting with this caudal tunnel itself rather than going to the dorsal tunnel. Let me see if it is possible, sir. If it is not, then I'll have to open it if the deflection is too much. Scissors, please. Sharp pointed. Yeah. SMR elevator. So the septum is not supported well. So it's collapsing under the pressure of my speculum also. As you can see, it is moving inside. Take out your or keep it like this, far away. You need to help me. Okay. Suction inside, please. Just raise the table towards me, please. Cartilage holding forceps and sharp scissors, please. Table to go up, please. Yeah. So this is routine septoplasty that all of you are doing. Obviously, I elevate both the sides of the septum. Enough. Slightly down. Suction. Slightly down. SMR elevator. Sharp one. Sharp one. Yeah. Suction. Put the other suction elevator, sister. There are 2 suction elevators. Yeah, put the other one.
So getting into the right plane is very important here. If you're not in the right plane, it will start bleeding also.
Yes,
so
sir.
once you are in the right plane, there won't be any bleeding. You will have the so-called hydraulic dissection. The double-layered mucopericardium. I think we should get into
Scissors.
there.
Sharp scissors.
So you're going to the opposite side, is it? You're going. I think you're dissecting right side now.
Now I've gone to the opposite side, sir.
Right.
The reason is it is concave here. So at least the caudal edge, I will get it correctly.
Yeah.
And then I will start dissecting posteriorly.
Right. So once you are in the right plane, it won't take much time.
So just that my assistants are pulling sufficiently to help me, but then being a narrow space, we all have
I
to
know.
struggle for space here.
The
Sister,
ENT itself is struggling in the narrow places, Vishwas.
Yeah.
Wherever
Normally
you are.
normally it's a struggle between scissors, please. It's a struggle between the anesthetist and the ENT surgeon in that narrow space.
Yeah.
Today it is a struggle between me and my assistants. Who pulls more? Angle scissors, please. So I'm just splitting more inferiorly so as to be able to get a better exposure from the caudal root itself. And as you can see that deflection has gone all the way, suction elevator. And the cartilage is also bouncing. Pullman. As I'm doing it, it's bouncing front and back. Hold here. Yeah. Saline irrigation, please. So it is a dull colored cartilage in children. It's not a very bright colored cartilage because it is still not ossified. Suction, please. So many times what we'll get misled is thinking that we have not reached the right plane and we try to dissect more. Sharp pointed scissors.
The left side, I think your finger or something is coming across, Vishwas. Left side.
Yes, sir. Is that better now?
Now we can see better. Yeah.
Is the clarity good? Can you see the?
Yes, yes, very well. We can see very well.
Okay,
yeah.
we don't need an endoscope, right, to show?
Yeah, no, not at the moment. Not at the moment.
Not at the
unless
moment.
you go deep in, I think. Yeah.
I'm getting deep inside, sir. So I'm just asking you, if you feel that I have to show this part, I mean, which would be essential for the postgraduate, second size speculum, please.
Yeah, you can.
Please let me know, sir. I'll try and get my positioning right. I mean, it is.
Yeah, see, once you are putting the speculum, I think the vision is obliterating for us.
Okay.
But anyway, you carry on. Once you elevate completely, we can see better.
Yes, sir. Probably meanwhile, I'll ask our anesthesia chief to talk about the conundrums of anesthesia practice while I'm dissecting, so that that also can be learnt, because he's a man with a vast experience, and coming from him, there are a lot of things that I have picked up in my own practice. So it'll be good for all of us to possibly listen and see how to make our practices better with time. And why we are fortunate here, section please, in Trustwell is there are many times when the patients are all possibly very ASA grade 4 and nobody wants to take them up for surgery. Our anesthetists have been most nice to us. Angle scissors, please. Can you call anesthesia? Sir? Can you give the mic to sir? And as I am dissecting the cartilage, like this is not abdomen. No? Don't pull like that. Suction. Change the suction. So the mic will focus on him, or rather you can listen to sir as he speaks while the operative view will be there. Audiovisual team. Hello. Hello. SMR elevator, please. Sir, you can speak, sir.
Good afternoon.
Gauri ma'am, is it okay that if sir speaks in between?
Yes, no problem.
Because I'm just dissecting and elevating the
Yeah, we can see you are elevating the septum. And,
Yes,
because the hand is coming in the way anyway, the vision is obscured. So till then, let sir cover that important topic.
Yes, ma'am.
Good afternoon, everybody. Is there any questions which I can take up from the audience regarding anesthesia part or any of the issues or any in entire otolaryngeal topic?
So far it has not come, so we'll check and come back, sir.
Okay, thank you.
What is the doctor? Dr. Vishnu Sarup Reddy from Hyderabad. Can you hear me?
Yeah, I'm hearing.
So, what is the endotracheal tube we are using here for the child?
We usually use a flexometallic tube because the surgeon wants tube to be fixed towards the south pole. Either we might use the south pole tube or flexometallic tube.
Third size.
Yeah.
Okay.
Third size.
Keeping in midline.
Yeah, we have to keep it in midline because the surgeon wished to know the
absolutely
hairline.
That's right.
Lip
Be a
line.
good assistant.
That's right.
Huh?
Yeah.
Rather not the spray.
So, are there any other precautions you keep in mind when a child being operated? Rhinoplasty procedure. Anything other than adults, doctor? If you can think of.
Yeah, I think I have the most controversial is use of vasopressors in pediatric age group, which I already discussed in the morning session.
Right.
And we should not bring too much pulse rate in heart rate in pediatric age group. That is very important. A lot of mishaps and catastrophes has happened, and which is very difficult to revive also. That's one thing. And regarding the depth, regarding the post-op analgesia is also equally important, which I'm planning to explain as a post-op analgesia or pain management in otolaryngeal surgery as such after this question session.
And what is the blood pressure like you maintain, doctor, for this age group?
Sorry, sir?
Any specific blood pressure you maintain for this age group of children?
Blood pressure. See, usually most important is to maintain the mean arterial pressure around 60 to 65 to 70.
Okay, that's good.
So that is the 60 to 65 is the better, but pediatric we can give it a little higher also. Not an
issue. What analgesic do you give normally for these?
So we usually
child is like
usually give fentanyl infusion.
Okay.
For the procedure. The ideal actually it's a very good question actually. Usually, the best drug if for endonasal surgery for ENT and all for all the otolaryngeal surgery, Yes, dexmedetomidine. It's an ideal surgery because ideal
Sharp scissors
analgesic
and
agent because
cartilage holding forceps.
it does not cause much postoperative respiratory depression.
Right.
Secondly, the recovery is very good and it keeps the pulse rate low.
I see.
So that is one of the very good analgesics.
Right.
And also for it's a very good actually post-op analgesia in case if we are giving in the ICU if the patient is going on ventilator. It is very excellent analgesic agent, particularly elderly patient who are on ventilator or elderly patient who are coming for any of the mastoid surgery because it reduces the post-operative cognitive behavior. It's very important. Lot of elderly patients after anesthesia from day 1 to 2 to 3 months they will have cognitive behavior disturbances, and specifically dexmedetomidine prevents the improve the cognitive behavior. It's one of the very useful drug in particularly otolaryngeal surgery.
Yeah, suction please.
Yes, do you normally give any corticosteroids like hydrocortisone or dexamethasone?
See, I will tell you the plan of surgery. I think that overall I will cover. Nowadays we call it as ERAS protocol or enhanced recovery after the surgery.
Okay.
So this has come in last decade by ERAS Society. In 2010 it started. So it helps in the reduce the length of stay and length of reduce the cost benefit, and also it improves the patient acceptance post-operatively. It has been ERAS protocol has been followed in thoracic surgery and GI surgery. Now, specifically, they have introduced ERAS protocol in head and neck surgery. Of course, that is more for the head and neck oncology surgery, but still we can modify and use for regular surgeries of general surgeries of all the ENT. What we are following is for pre-medication, we usually give either midazolam along with the glycopyrrolate and the fentanyl. And pre-operatively, all the patients are before induction have to give antiemetic drug like MSET and esomeprazole we give, and at the induction we have to give antibiotic of your choice. Along with that we give dexamethasone and 2 to 4 milligram. Then we give Zamic or PAS about 5 to 10 ml depending upon the body weight. So it really gives the good surgical plane and analgesia throughout the procedure, because dexamethasone is a powerful antiemetic and also it reduces the airway edema.
Yes, anti-inflammatory as well.
Yeah.
Yes.
So and throughout the procedure we give fentanyl infusion with or dexmedetomidine relaxant infusion throughout the procedure. So
whether it is GA or LA you are giving, is it?
Even for the local also we same procedure, and for sedation we give usually dexmedetomidine with fentanyl infusion or dexmedetomidine infusion if the patient is elderly or we have more comorbidities.
Yes.
So this is one of the indication. It's one of the protocols where the post-op recovery is good, and also post-op analgesia will be good, and also the antiemetic, and because of the antiemetic drugs, patient will be more comfortable.
Suction, please.
Thank you, doctor. Thank you for the detailed explanation.
Yeah. Okay. So I wanted to talk about the pain management in head and neck surgery and otolaryngology. So we have two types of pain: acute pain and chronic pain. Nowadays, we are doing many cases of otitis, malignant otitis media and head and neck oncology, which is very painful. And because we have to address this pain pre-operatively, and also skull-base osteomyelitis and all. These patients, we have to control preoperative pain either with strong opiates like oral morphine or buprenorphine. Round the clock we have to give them along with the steroids, and we usually control with them. And during surgery also we require very high dose of opiates. And post-operatively these patients will be needed another 2 to 3 months of analgesic dosage, which we manage with always oral morphine is the drug of choice. Of course, that is the anesthetist who gives and who monitor it. But as a ENT surgeon, you have to be aware of it, what kind of the degree of pain. And the selection of drug for regular ENT surgery is depending upon the surgical invasiveness. That is, surgical invasiveness is, for example, if you're doing mild to moderate, like tonsillectomy or in septal surgery, is the one is the level 1 or mild to moderate. Then if it's a severe surgery, we have to give on oral narcotics or higher drugs. Whatever the drugs we select, it should be given by the mouth and by the clock, by the ladder. Ladder is the WHO pain ladder, which we know everything for the cancer pain. Now it has been incorporated into the post-operative pain relief also. So the better we have to give, whether the patient is having pain or not, we have to give round the clock. For example, if you are giving paracetamol post-operatively, better to give by orally every 6th hourly, 6 a.m., 12 p.m., 6 p.m., 10 p.m. For adult, 1 gram.
One side.
So we have to cover round the clock. Because any of those breakthrough pain will make them very, discomfort, and, they experience a very bad pain memory. So, or we have to give Ultraset or the tramadol with paracetamol 6 a.m., 2 p.m., 10 p.m. Minimum 2 to 3 days. We have to give. We should not give. There is no role of PR. What I'm emphasizing is there is no role of PRN or SOS dose. We have to
regular. Should be regular. Yeah,
regular. We have to give. That is very important. And invariably, any analgesics, we have two complications. Complication in the sense side effects. One is they will have a vomiting or gastritis or constipation in the long time. But we should not be too much worried about that, since we have many good drugs for us to control all these things.
Yeah, for tramadol, we always give some Ondanset and some Zofar, before giving tramadol, I think. That is always a routine practice.
Better to give prophylactically 4 milligram BD or 8 milligram BD orally. And oral preference is always better. As the patient wants to, the moment we start orally, we have to give with the oral drugs. So, but any of those malignant otitis media or any of those neck surgeries, we have to give narcotics only. Strong opiates are the choice, and we have to continue till the patient 8 to 10 days.
And sharp scissors, keep it ready.
So you give morphine, doctor, for these patients? Or oral morphine?
Oral morphine. We usually give oral morphine. That is, we have to give, we usually start on 10 to 20, minimum 12 to 30 milligram, 20 to 30 milligram. We should be given every 4th hourly or 6th hourly, along with the laxatives we have. Laxatives is a must for oral morphine. Or sometimes we
constipation is a problem with
and sometimes if the patient is unable to take, we usually put what we call as buvular patch or a buprenorphine patch, which 10 microgram is an excellent pain relief drug for 7 days. So sometimes we put that, so 7 days patient can have good pain relief. So if any vomiting is there, we can always address. So these two are quite a useful drugs for post-operative pain management. So if
there is a question. Explanation, Doctor, is very important.
There is a question to Dr. Vishwas, sir. Can I take it?
Yeah, please.
This Dr. Urmila from Kathmandu.
Get me the speculum, 4th size.
Sir, Vishwas sir, she's asking you, what is the lowest age limit for an extracorporeal septoplasty in pediatric patient with grossly deviated septum, as you have demonstrated?
Yes, ma'am. So to answer that question, nice question, Urmila ma'am. there are two growth spurts in children, especially the nasal growth. One is at 2 to 5 years of age. The second is at the 14 to 16 years of age. So we get two windows to operate on the child. So the first window is the age between 6 to 12 years. The second window is when they are in the pubertal age group. That time they come to us for correction of both the nasal deformity as well as the breathing. So the earliest age is possibly a 6 or a 7. But sometimes you also get patients in the neonatal ICU being referred to you with a deflection of the caudal septum blocking the nostril and the pediatrician not being able to pass the catheter. That is because of the pressure during the delivery. So that usually corrects itself, auto-corrects itself in 2 days' time. If not, very rarely, if it remains behind, we need to do a approach via the sublabial incision and correct it. Otherwise, most of the patients that if you're planning to choose to operate for a septal deviation, especially an extracorporeal septoplasty, a 7-year age window would be most ideal, ma'am. Ma'am, does that answer your question?
I'll wait for her response, sir. She is on the platform, so I'll just check and come back to you, sir. Thank you.
Thank you, ma'am.
But that was a very valuable information.
Yeah, so
and I want to know that if there is adenoid hypertrophy, will you simultaneously remove the adenoids in the same sitting?
Yes, ma'am, we would definitely we would, because here the main purpose is to get the child to breathe well, and any advantage that we can give to the child to breathe well, especially with this child having apneic spells, if the adenoids were really very, very big, occupying the nasopharynx, then I would definitely go ahead and ask my colleague to do the adenoid surgery.
And what about the anti-allergy treatment, maybe nasal sprays or something? Will you put them for?
Ma'am, the child is already on anti-allergic treatment.
Okay.
He's already on anti-allergic treatment. So he still has breathing issues despite the anti-allergic treatment. So that's the reason we had to plan the surgery, ma'am.
But after the surgery, will you continue for a while? Like
Yes,
till
ma'am.
the child breathes through nose.
Yes, ma'am. For a week, possibly I wouldn't give the sprays. After that, I would definitely give him the sprays back. Obviously, he will be on the anti-allergic medications for that duration.
Okay. Thank you.
Thank you, ma'am.
Vishwas?
Yes,
Hello?
Dr. Vishnu. Yeah.
Yeah, I think if you give a good saline wash, that is dried blood and all, will clear, I think.
It's fogging the area. So
yeah.
Dr. Vishwas, sir, can I make one announcement with your permission, sir? People
Yes,
are
ma'am.
asking how to download the certificate. Yes, just for all the people, for the instructional session, you just go to the instructional session by clicking on when you go to the platform, on the downside, you have a icon where you can directly take you to the instructional session. There are 3 instructional sessions which you can complete, and once you complete, you can immediately download the certificate. But for the participation certificate, you have to, after registering, you have to participate. Then you will get the credit point as well as the participation certificate. Thank you very much. Thank you, sir. Vishwas, sir. Sorry for intervening.
No worries, ma'am. I mean, we are just dissecting right now. So I want to mention, or rather show, some areas of surgery which we are not supposed to touch in a pediatric septum. And this is something that we usually don't see on a endonasal approach. Put the straight suction, not this. Put the straight suction.
Vishwas?
Yes, sir.
I think you need to use the endoscope. Otherwise, we cannot see much. The speculum, Killian speculum is now we can see better.
Now you can see. Okay, yes. So I'll turn tilt it to one side. I'll try and release a little bit more, but I don't want to split the upper lateral, put a lid retractor here.
Yeah.
Small lid
it should
retractor.
not.
Take it from the second set. I'm sorry for the ooze that he is getting. We'll just try to control.
No problem. I think we can see, but the only thing the speculum is coming across. We don't find the field is bloodless only. For us, it's not bloody or anything.
Put it.
You know.
Not that small. Okay, you can put that. Okay. Anything bigger? Opposite side must be bigger, no? No? Okay. Yeah. So, give a wash.
Now we are getting some view.
Just a second, sir. I'll give a better wash and show it to you.
Yeah.
Is it clear now, or I'll get a smaller speculum to show it?
Yeah. Yeah.
Need a second size speculum. Better, sir?
Yeah, that's better, certainly. But inside, I think if you want to see deeper in, I think we need to put an endoscope.
I'll show with the. I'll show in a while, sir. I'll show that.
Right.
So what has happened here? You can see that the upper lateral cartilage is here, sir. Can you see?
No, actually.
This one. This is the upper lateral cartilage on both the sides.
No.
This one.
Yeah.
So this is the T assembly where it starts. So this is the septum, and then the upper lateral cartilage on both sides. Ideally, in an adult, we would go ahead and split this and then open it up and create a dorsal window for approaching the septum, ideally. But in pediatric population, we try to retain it as long as possible. If we can do it without it, we would retain it. But if I find that I reach a point where I cannot actually go ahead, I will have to take it out. Now, to understand the septum in the pediatric population, most of it is cartilage. Very less of it is bone.
Yes. Yeah. So you hardly find any bone. Yeah.
Yes, sir. So in that, there are three zones of importance. One is called as the sphenodorsal zone. This one. This is the sphenodorsal zone. This is the zone responsible for the height and the projection of the nose. The sphenodorsal zone. That's the reason we don't touch the cardia, or we don't take out a hump, or we don't try to separate the upper lateral cartilages too much here. So the other zone, please relax your lid retractor. The other zone is the sphenospinal zone. Can you see, sir, here?
Yeah.
So the septum resting on the maxillary spine. That is the sphenospinal zone down there. So this is the this is the thickest part of the septum there that we all know. This is about 3 millimeter thick. Now, this is the zone which is responsible for the midfacial growth itself. So what it does, it pushes out the midline palatine process downward and outward. So when it pushes it downwards and outwards, what happens is the midfacial growth happens. So many times we have this habit of taking out the inferior strip and then inferior chondrotomy and doing the septoplasty. The most safest zone for a pediatric septoplasty is the anterocentral zone. That is this zone here. Anterocentral zone, which is the thinnest area and the most deviated area, fortunately. Can you make out, sir?
Yes, I think we need to get a little. The speculum is still blocking, but.
So is that better now?
Not really.
I'm so sorry.
No. Yeah, now we can see. I think we're getting a little view. Yeah. Now it's better. Now
so that is the sphenospinal zone. Hold this.
Yeah, you can show it now.
Yeah. This is the sphenospinal zone. Can you see the deflection there, sir? And the spur that is there?
Yeah, correct. Yeah.
So what happens is we need to have the cartilage approximated to each other rather than trying to remove this cartilage.
Right.
Okay?
Yes.
So it is folded on itself. Can you see, sir?
No.
Here,
Yeah,
septum
now
has
we can see.
folded
Yes, now
on
we can
itself.
see. Yeah, yeah, yeah.
Yeah, that's the reason for the gross buckling that is seen in this child.
Correct. That's
So
right.
for us, the safe zone is to operate in this area and not go too posterior. Do not split the junction between the posterior plate of ethmoid and the cartilage. That is the point which actually makes the upper part of the nose grow up. We try to retain that as much as possible. Sharp SMR elevator.
Yes,
So
that's very important for the dorsum.
yes, sir. So when we are doing endonasally, we don't see all this unless you're using an endoscope. And in endoscope also, what happens is, because we are concentrating on one certain area, we might think that we have not touched the critical zone. So we will need to constantly orient ourselves, remind ourselves that we need to stay away from the critical zones so as not to cause any midfacial growth. So what I would do in my patients is always consent them for a second surgery after 18 years. Though I will follow all the precautions required to not touch the growth centers, though I will be very sure that I have not cut the areas where the growth centers start working, I would definitely consent and only then proceed with the surgery. So this patient here, also I have done the same thing. I have consented them for a second surgery after he turns 18 years and only then taken up for surgery, because we are not going to handle the K area or we are not going to handle the tip here. So with time, what can happen is there can be changes in the tip and in the K area. Sir, please tell me if I'm not visible. If the area is not visible, I'll be happy to showcase it time and again and move inside to show the better visualization. Sir, can you see now how the septum is lying flat on the maxillary spine because it is bent to one side? I'm sorry if the light is... Now it's better?
Now we can see. Now we can see.
Can you focus inside, Jaren? Leave that. Focus inside. Leave it. Gauri ma'am, if you feel that you cannot see that part, please tell me.
No, I can definitely see it is almost horizontal.
Yes, ma'am.
Yes.
Yeah. And that explains that the child had total obstruction on this side. And
Yes,
probably because it is S-shaped, it is blocking both the sides.
Both the sides.
Almost,
now, what we usually do, ma'am, in an adult septoplasty, we will cut this strip, isn't it?
Correct. But what differences you will make in since
so here we'll cut the strip just adequate so that this part of the septum lies onto the maxillary spine. Just adequate. In an adult, we might actually excise more, thinking of how much we'll retain on the dorsal edge. But in pediatric, we will just go incremental. We won't go at once and take out the whole thing. So my plan here...
is there do people remove it completely and put it back again or not? It's not done.
Yes, ma'am.
So I want to know from you.
Yes, ma'am. So extracorporeal septoplasty is an accepted surgery in the pediatric population, and the long-term growth does not get affected much. But herein, my plan was that initially, I just want to show you the part where I might change from an extracorporeal septoplasty and just look at doing the septum part via the rhinoplasty approach. Now,
so
ma'am,
you will excise that excess cartilage from that strip of excess cartilage and see if that can be
handled from inside. Now, extracorporeal septoplasty requires me to split it at the K area and also split it at the inferior border. So again, I'm touching the growth centers that might lead to moderate growth restrictions. So what I'm trying to do here is being conservative there as well and trying to see. So my approach is just because I know how to do extracorporeal septoplasty, I wouldn't do it. Keep thinking all the while, is it going to affect the child's facial growth? Is it going to affect the child's nasal growth? This is what I'm going to think most of the time.
Another thing is, after extracorporeal, we are supposed to fix it to two spots.
Correct,
one
ma'am.
to the nasal bone and one to the maxillary crest, and that bone may not be that well developed that you can probably make a hole and fix it. So
Yes, ma'am. I want to show one thing, cartilage holding forceps. Now he has a high arch palate. So what has happened is the septum, can you see, ma'am, is buckled to one side. Now I just release the septum and I might be able to pull the septum to the right side.
Right.
Because the maxillary crest, can you see how prominent the maxillary crest is, ma'am?
Yes, yes.
This, sorry. Yeah. I'll just focus it. I'm so sorry about that. Yeah.
And you might go through the nasal cavities to recheck your plan, through the
Yes.
nasal cavities on either side.
Yes, ma'am.
Yeah.
So what I'm seeing here is a very prominent maxillary crest. And I can split the cartilage and the vomer, but I would not split the cartilage and the perpendicular plate of ethmoid. This is what I'm very, very particular about. So, but as I told you, if you're doing extracorporeal septoplasty, I would have to do it anyway.
Yeah, but as far as possible, not to separate cartilage from the ethmoidal plate. So
Yes,
that is
ma'am.
a very good point.
Yes, ma'am.
Pediatric, because in adults we do that first to see how much we can.
Yes, ma'am.
Yeah.
So what I'm seeing here, I don't know if you're able to appreciate, ma'am. Do you want us to show with the endoscope the various areas of deflection and the points?
We can see actually. There is no problem.
Okay, ma'am. So the septum which is curved like this, I'm trying to get it into alignment to this side by shifting it off the maxillary crest. Just give me a few minutes, ma'am. I'll try to do it.
Dr. Vishwas, sir, there's
Yes,
one
ma'am.
request from Dr.
Certainly.
Megha from Hubli. If you
Certainly.
can explain the step of this surgery, so you can do it at the end also. At the end also, sir.
Yes, ma'am. So what we have done so far is just raise the mucoperichondrial flaps without tearing it, because we want to see how the septum is affecting the breathing circuits. Now, on visualization inside, we realize that the septum has duplicated on itself, especially near the maxillary spine. And I am trying to remove that soft tissue of the mucoperichondrium or the mucoperiosteum that has caused it to deflect on one side. Cartilage holding forceps, please. So we can afford to remove the mucoperiosteum on this side, but then we need to make sure that the septum sits again back on the same point from where we removed it. Ma'am, can you see now how the excess is turning? Scissors, please. Cutting scissors. Yeah. Angle scissors. Angle scissors. Is it visible now?
Yes, now it is visible, Vishwas.
Just
Yes,
got a
Now,
bit.
in this direction.
Yeah. So this is that excess which is there below.
Yeah.
So what I'm trying to do is remove it just enough so that it sits back on the maxillary spine. Here, my purpose is not to make the child look very beautiful or anything like that. Just to minimal enough to give him a breathing circuit. So I'll do that, and as ma'am suggested, have a look inside the nasal cavity and see if it is good enough for the child to breathe. #11 number blade, please. So I use specific cuts. Give on the round blade, please. Round handle. Rekha ma'am, would you want any specific step to be explained? we have gone through in the regular rhinoplasty approach and then exposed only the caudal tunnel. We have not exposed the dorsal tunnel. We have gone exploring from the anterior septal angle so that we retain the attachment between the upper lateral cartilage and the septum. So trust me, being a child's cartilage, it is fragile. The area is small, but I have great assistance right now today with Fatima being the senior nurse here, Afzal and Dr. Jarin here, who are retracting very well so as to give you that visualization with a simple outside camera itself. Turbinate scissors. So once I make the initial cut, ma'am, I use the turbinate scissors. Turbinate scissors, that is Fomon scissors. Turbinate scissors. Yeah. So this turbinate scissors keeps getting blunt because we keep utilizing it very many times. Sometimes I cut the bone also. So as I'm cutting it, I'm just making sure that my turbinate scissors slides on the bone and not flies high. If I fly high, I'm going to cut more cartilage. So I want to sit on the bone and cut only the part which is deflected. So this is how I would follow to keep the septum intact. Is that clear, ma'am?
Yes,
Yes, yes.
So can you see that extra part here?
Yes, now we
I'm
can
going
see,
slow just so that this septal cartilage sits on the bone. I'm not trying to remove too much like we do it in the adult septum. So in the adult septum, what we do, we are only looking at what the dorsal height of the septum will leave behind. Here we are not looking at what we leave behind on top, but what we are leaving on bottom. Turbinate scissors.
Correct.
So what happens most of the time, at least in patients who undergo pediatric septoplasty via the endonasal route, once we put the mucopericardial incision, once we put the speculum, we might not be able to see the entire 180 degrees at one go. So for us, the view we get is a tunnel view. And we start thinking that, okay, this is how much that has to be removed. And then we remove the septum and then we realize we have removed too much. So it is better to have a visualization, sharp SMR elevator, visualization of the maxillary spine and the roof at the same time as you're operating to get a correct removal. Ma'am, does that make sense what I said?
Yes, yes.
Turbinate scissors. Can you see the inside part, ma'am, where I'm trying to split? I don't know. I'm so sorry if visualization is bad. But
See the interior part well now.
See it well. Okay, take out the suction. So as I told you, I won't go near the perpendicular plate of ethmoid. My focus is only on the vomer and the septum right now. Third size speculum. So maximum, third size speculum, third size. Maximum, it allows me only 3 sizes. Next size, give me the next size.
Yes, yes. Out of 5, I think only 1 or 2 may be entering because the child is 8-year-old.
Yes, ma'am. Saline irrigation. What's the time?
2:10.
Okay, get me the Tilly's dressing forceps. Yeah, or Lux forceps is good. Lux forceps is good. Yeah. So that piece what we have just separated, I'll try to remove it. So that's the piece which was lying horizontal. And you can see that the bone has also gone to one side, ma'am.
Yes, yes.
Can you see it now?
Yes, yes.
Let me the sharp scissors.
Will you have to use a gouge and hammer?
I'll just elevate it, ma'am, and see how much of it is contributed by the periosteum, how much of it is by the actual bone itself.
Yes.
So gouge and hammer, ma'am, in a pediatric population, again, I will exercise a little bit of a caution because the palate is going to be thin. So if I might use a medial osteotome, which is more flatter.
Can you use a drill?
Yes, ma'am. The drill is a very good option.
Diamond burr and little longer handpiece.
Yes, ma'am. It's a very good suggestion. Yeah, that's a very good suggestion, ma'am.
So that we can get a very controlled,
Cut on that.
Of the, yeah.
So it looks like the bone also has curved inward. I'm just getting at it right now. Give me a second. Hold this. Suction. SMR elevator, sharp SMR elevator. I'm able to move the bone, ma'am, with the SMR itself. Can you see, ma'am? I don't know if it's visible. Just I'll try to showcase that. Can you see that movement there?
Yes, sir. You're able to see it.
This one. So I'm able to get that movement with our small instruments. I don't need to do a gouging yet.
We can appreciate some movement of your periosteum elevator from outside, though we are not able to see anything.
Just a second, ma'am. Now? So that was all lying horizontally. Can you see that, ma'am?
Yes, now we can see.
That was all lying horizontally. So I just lifted it off the nasal floor.
Correct. Wonderful.
So I just used my SMR elevator. I have not used any gouge or anything like that. So the broad spine that we saw was actually the bone which was sleeping down.
Correct, correct.
So again, I am not going to excise that or remove it inadvertently. As you said, ma'am, we will go inside, fifth size speculum, please, and see what our blockage is and then plan further. Fifth size, please. Yeah. So I have a very thin size fifth speculum, which is good for the pediatric population. So I can see that there is some blockage still there near the floor, but I'm able to pass at least till the middle turbinate now. Earlier we couldn't even pass that. Now I'm able to go at least till the middle turbinate and my suction is going inside. So there is still some work left at the septum level and the maxillary spine level. Wipe this, please. So the bones that we elevated, ma'am, are actually causing an obstruction. So I will have to remove it. Get the lux forceps. So it is okay to remove the vomerine bone, which is excess, but it is not okay to cut the perpendicular plate of ethmoid. And the another reason for not removing the perpendicular plate of ethmoid is because it's a thin bone, the likelihood of fractures carrying on to the skull base. And it is better to use the turbinate scissors for a controlled cut in case we are going posteriorly, rather than using an instrument which will likely transfer the energy from your hand onto the. So I cut inferiorly and not superiorly. Superiorly is just a division which had been done already. Lux forceps, please.
So that's a valid point.
Yes, ma'am. So there is some ooze because the lot of fractures that the patient has had earlier and has left abnormal vascularity. Just give me a second, ma'am. I'll control it and I'll start showing you the points. Okay. Lux forceps, please, or SMR. Give me sharp SMR. Give me the second size speculum. So every time I open up a very strongly deviated part, there'll be some ooze for some time until the clotting happens and it settles down. I'll just show you in a while. So these are all the small chips of bone that I'm taking out, which had been lying horizontally and making the patient unable to breathe comfortably. These are all the bony parts. These are all the bony parts which had been lying horizontally there. And now I'm trying to remove it. I mean, there's nothing major to a septoplasty because all of you are all doing it. Just a few salient points on what not to do. Third size, please. Rather than what to do. There are a few things again on the septum that we should not be doing. One is a vertical incision. Give me packing for some time. Get me a bipolar cautery. Or touch unipolar. Touch. Touch. Not working. Not working. Give me a bipolar, please. So underneath that reflection of the nasal bone was a vessel which was troubling us till now. So I'm trying to cauterize it with the bipolar cautery. I'm sure all of us experience this very often when we try to correct the maxillary crest itself.
Yes, I think it's very important, Vishwas, to stop it, and otherwise septal hematoma is also a risk.
Yes, sir. Especially in the pediatric population, as I'll be mentioning later, we prefer not to pack the nose, rather only quilt the nose, quilt the septum.
Right.
Hold.
Yeah.
Speculum, I mean sharp SMR elevator. So as much as possible, we remove all the sources of oozing. In fact, I will tell our anesthetist to I will tell our anesthetist to get the BP back to normal before we start closing.
Right. Even putting a small patty soaked in adrenaline.
Yes, ma'am.
At the floor of the maxillary crest many times works better than putting a bipolar cautery which doesn't work on the bone.
Exactly, ma'am.
There is a small artery there which bleeds with spurts.
Yes,
so
ma'am.
Maybe even this is a good.
Can I show that part inside? Can you see it, ma'am?
Actually, your hand is coming in the way.
This one, ma'am?
Yeah, now we can see better. Yeah.
Yes.
So that's the piece of cartilage which is sitting beside the. I'm sorry, I'll just get the SMR. Get the SMR. Yeah. So this is the part which is sitting beside the vomer. So and that is causing the blockage on the left side of this one.
Totally deviated means something needs done.
So this is the maxillary vomer, ma'am. This is what you can see. And just beside it, this cartilage piece is sitting. That is safe to remove.
Correct.
Packing, please. Neuropathies with adrenaline. Turbinate scissors. Take this. Got the adrenaline? Not yet. Turbinate scissors. Lux forceps. Yes, Dr. Vishnu, anything that...
Yeah. Fine, Vishwas.
Turbinate scissors. Fifth size speculum. Get ready to change my light, please. Neuropathy is ready, sister. Just give me a second. I'll remove this piece of cartilage and then get back to you. Lux forceps. Thank you. Yeah. Do you have a release dressing forceps there on the set? Cartilage is not getting hold. Yeah. This also is not holding it. I need something which holds. Yeah, straight grasper you can. I don't know, but it's not pediatric, no? Yeah, it's a long one. Nevertheless, can try. Okay. So that was the piece that was sitting beside the warmer. I'll just go and examine inside the nasal cavity, ma'am. Yeah, I'm able to pass the speculum till the posterior part. Comfortably, as you can see, not forcing it through, it is just sliding through. Another reason that we need to be careful about the mucoperichondrial flap, you can see that this maxillary crest is there, but that does not contribute to the breathing. So I'll see only if it can be raised. Carefully, I'll raise it. Otherwise, I would try to retain most of the maxillary crest because that is helpful in the nasal growth. Now that is on that side. Let me see on right side. Right side also I'm able to pass it. So now let's look at what has happened. Second size speculum, cartilage holding forceps.
Even nasal vault has started looking straight now.
Yes, ma'am. So we released all the stressful forces. Let's put the lid retractor. So still there is this excess in the caudal edge. Can you see, ma'am? So I retained this intentionally so as not to remove it until I see what is the final picture. Because if I were to do an extracorporeal septoplasty, I would require all this to manipulate it. So I've left it there. So now if I tend to just remove adequately and align it correctly in this fashion, then most of my septoplasty work is done. So there are two.
Yeah, it is looking really good. Now, when you have straightened it, only thing is it should stay in that.
Exactly, ma'am. So again, here is the same principle what we used behind, ma'am, posteriorly. Just remove incrementally.
Correct.
Not too much. So I'll use a knife, 11 number knife, and just remove enough so that we can suture the septum to the spine later.
Okay.
So if you can see, ma'am, I started the cut little posterior from the area where I can posterior septal angle. Reason is I need a good bind on this because this is very thick cartilage. This will sit well on the anterior maxillary spine. So never cut from the anterior unless you want to change the angles. Can you see how it is posterior, ma'am, not anterior? Way
Correct.
up to the caudal edge. Yeah.
Yeah.
Turbinate scissors. So I was telling a few points about what not to do on the septum. Scoring on the septum is a strict no-no. We do not score on the septum. In fact, if you want to straighten the septum, use a batten graft, which I might show now how to use it, rather than trying to score and straighten it, because scoring tends to leave much more problems than putting a batten graft cartilage. So again, be conservative in what you remove. Wait till posterior, lux forceps or any forceps. So this was that piece in the caudal edge. Now all the while, I'll be tempted time and again to remove this piece. But if you ask your assistant to relax, you actually realize that it's not 2x's. Now, when we pull like this, what happens? It gets deformed. So we keep tending to think that this has to be removed. But if you now look at, now look at this, it's sitting flush right on the spine. Although it is not straight, it's sitting right on the spine. So now what we have to do is suture this to the midline. Suture this to the midline. Then put a batten graft to straighten this cartilage. Then our work is mostly done, because you can see that we have not split the upper lateral cartilage, but still we are able to get the cartilage straight. So part of the problem was the maxillary crest being too high or the spine being too high because of a high arch palate. Second problem was due to the cartilage itself being fragile. Third part, that the nasal bone K area envelope had not advanced to accommodate this kind of septal assembly. So what we have just done now is reorient the septum to the various fixation points. Now I want you to have a look inside, ma'am. Can you see how the septum cartilage is sitting right on the bone?
Yes, we can see very well.
Yeah, that is what
right.
we want to achieve, sir, because the growth is going to happen at that point. And that is going to push everything forward.
The front part looks very straight and the length looks quite good. Means not excessive. Posteriorly, we can see some deviation to left side.
Yes, ma'am. So I'll also examine that. We'll see inside, ma'am. Ma'am, can you see anything?
No, we can't see. We can't see anything beyond that point.
Now?
Yeah, now we can see better.
So this is right on the bone, sir.
Yes,
it's right on the bone.
Yeah, it is. Yeah.
Correct.
Okay? I'll just suction that. Give a wash there, please. So at the cost of being repetitive, being minimalistic, understanding the final outcome, that you want to be conservative to allow for good midfacial growth and nasal growth, it's definitely better than trying to look heroic and giving the child a beautiful nose. Here, ma'am, I think this was the piece of cartilage which was seeming excess, isn't it?
Yes, yes, yes.
Yeah, that I'll remove it, ma'am. Sharp scissors, please. Keep a 50 PDS ready. So just to show in the next 10 minutes, 2 important techniques that we all need to do for all our septoplasty patients, even if it is an adult. One is fixation to the anterior maxillary spine. Second is usage of a batten graft inside itself. You don't need to do an extracorporeal septoplasty to straighten the septum. You can do with SMR elevator, please. Sharp. So I'm passing my SMR elevator all the way posterior, ma'am. No deviation that is obstructing me. I've gone up to the rostrum. I'm sorry, I'm not able to show that. Kindly excuse me. So posteriorly, there is some deflection of the spine, but then as the nose goes posteriorly, the cavity widens. So what happens is the posterior nasal space is wide enough. So I don't need to really go and remove millimeter by millimeter maxillary crest deviations posteriorly, because the nose, as you know, definitely widens towards the posterior end. If I'm able to pass the 5th size speculum easily, give me that. If I'm able to pass it easily without any kind of obstruction, then I have reached my goal. So I'm almost at the posterior point. This as well, I'm almost at the posterior point. Let me examine once again for the benefit before we actually try to be confident about the closure, I mean about the exposure. Actually, I would prefer to show this point and with the endoscope. Can we get an endoscope ready? Clean this, please. Give me the SMR elevator, sharp. There was another small ledge of bone which was sitting to the left side when I put the speculum inside, and that I felt needed to be handled for the patient to breathe better. Turbinate scissors. Take this. Lux forceps, please. SMR elevator. Wipe it. Wipe it. Are there any questions from the audience, ma'am? I can answer it as I'm finishing off the last part.
Sir, the same question, I think. Yes, sir. You can. Dr. Hamid is asking.
Turbinate system. Turbinate scissors.
Dr. Krishna, you can go ahead. You can tell.
Yeah. So there's a question from Dr. Shaul Hamid from Hyderabad.
Yes, sir.
Asking, how do you plan to handle the maxillary crest area in this particular case?
The maxillary crest, sir, what we found out in this patient was it was bent on itself in a U-shaped fashion. So the bent maxillary crest was actually forming a tunnel on the left side. So I passed my SMR elevator under the tunnel and lifted off the bone, and thereby we could get it corrected straight away. But most of the time, if there is a posterior maxillary crest bend, I don't try to manipulate it too much, but because that is connected to the growth centers. I try to be as conservative as possible. So many people advise putting the burr over there, turbinate scissors.
Is it advisable to do osteotomies in pediatric age group?
Ma'am, nasal osteotomies, yes, we can do, but that's only for patients having a wide open book deformity, especially when you do dermoid surgery. If it is for cosmetic.
Like in this case, after correcting the septum,
yes,
if
sir.
you feel that, the external vault also looks little deviated.
Hello.
Is there any scope of doing osteotomies in such cases? Now, in this case, the bony vault looks straight. Only the cartilaginous part was looking deviated. So once you correct the septum, I think everything will look straight. But if it looks little wide, is there any scope of doing osteotomies?
Ma'am, so if there is a nasal septum deviation at the bone level, that means to say the bone attached to the skull base is also slightly deviated.
Correct, correct.
So that means I will have to do a root osteotomy to be able to move it to one side.
Correct.
Which I would avoid totally, because now if you can imagine an I, letter I think you can see it in my hand. I'm not sure. Give me a marker pen, please. You can imagine the letter I, one head of it at the skull base, one head of it at the palate, and the septum in between forming the I.
Okay.
So I have released the stressors at the lower I.
Correct.
Though this is deviated to one side now, so what can happen is because the stressors have been released, it will readjust itself by reorientation like this.
Okay.
I hope you got what I said, ma'am. I'll need a marker to show that.
Yes,
so
yes.
The growth is always like this. It moves upward like that and downward like this. So because we have released the stressors at this point, now there will be readjustment of the bone also, because it's a growing skeleton. If it was an adult, I would have to do a root osteotomy, split the whole thing, move it to one side, because it's already a matured bone. So just to show you here, the stressors let's say it was like this from the beginning. Now what we have done, we have taken out this part and allowed it to be straight like this.
Correct.
Now we expect it to readjust itself.
Correct. Correct.
Yes, ma'am. Now I can find that the nasal bone looks straight actually when I'm palpating it. Now because of edema, we might not be able to notice. I'll try to keep the septum in orientation, keep the 5-0 PDS ready. No, I said cartilage holding forceps, please.
Vishwas?
Yes, sir.
Yeah, we can certainly see a
This
change
one.
in the external appearance. It looks fairly straight actually. We can, the so-called probably as is the septum, so is the nose. It certainly, if you are putting in the midline
lid retract
before you suture, it looks there's a lot of change externally also.
So this is what we are supposed to achieve, sir. I mean,
Yes.
I've been as conservative as possible. Just opened the caudal window and done this. I mean, we could have definitely done it through this route, but then what happens is we would have struggled where the septum had deviated badly. We would have really struggled this point. So it is better to have a good exposure, see the areas top and bottom, remove only the parts which need to be removed and fix it back to the center. So I'll proceed with the fixation to the center because now I'm able to pass my fifth speculum all the way back. Second size speculum and 5-0 PDS. I think Dr. Hamid asked a question, sir. Did I answer your question? Was it enough or you want any more clarification? I'm happy to answer that.
So there are a couple of other questions, though you answered it earlier.
Yes, sir.
One is regarding the approach to this particular case. Pediatric septoplasty, you approach to rhinoplasty approach. Are there any other approaches which we could have done for this particular case? This is a question coming from a couple of medical colleges. They're asking, are there any other approaches we could have approached this particular case other than rhinoplasty? That is one question.
Endoscopic approach, sir.
Yeah, endonasal. To add to that, one doctor has asked follow-up, sir. Endonasal septoplasty. Why you didn't talk?
So what happens?
See, I think he already explained.
Correct.
Probably better exposure. Actually, yes, I have certainly done this kind of cases. Endonasal, Dr. Vishnu Swarup Reddy. Yes. Yes, I mean, this is another way with a better exposure and it's good for demonstration also. Yes, we could have struggled and you could have done with the endonasal approach also the same thing if you are more experienced. But it's a little bit of struggle and endoscope will help certainly to look better with the endonasal approach. But here we want to demonstrate as well at the same time. And certainly it gives a better exposure.
Sir, I just beg to differ. One point only, rest of the points I agree. Endonasal and endoscopic definitely we can do and we can get a good result. But the biggest problem will be knowing what parts to remove and what not to remove because you don't get the comprehensive picture. It is like missing the forest for the trees. So I would at least.
Vishwas, I know, I agree with you, but I mean, that's where experience matters.
Yes,
in the
sir.
sense, unless you are doing regularly, then only, your practice will make you perfect, as you know, with the technique. Yes, both the techniques are good, no doubt about it. But I think, yes, yeah, I agree with you, but, it can also be done. I think, in fact, I think that's what is the debate, isn't it? Generally, is it really necessary to make an external incision? And but I mean, certainly you've done a wonderful job. I think it certainly looks very good and fairly straight. That's what you do, okay? But not that it can't be done, not that it can't be visualized.
Yes, sir. Agree with you. So what I would prefer telling our youngsters is if you have practice of doing a good rhinoplasty, start off with guidance from elders. we would not prefer the closed rhinoplasty approach, because you have to cut through the cartilages, which is actually counterproductive. But if you can manage to do this with your instrumentation gently and softly, then this is a better approach. Endoscopic, yes, sir. Now, since it is caught on the imagination and it's used extensively for all of us, my only worry will be, how will I manage if there is hold this. If there is an extensive deflection on the side, left side, as you saw it, so that release it, but hold it gently. Yeah. Otherwise, yes, sir. All approaches are good and depends upon how you have been trained and how you have practiced and experienced it. So what I'm trying to do is putting a figure of 8 stitch. I just need you to hold this while I put the suture. So key here is to expose the part of the spine and attach your suture to the periosteum. Now, there are a lot of schools of thought here as well. Some of them, just hold it away. Some of them make a hole in the bone.
Yeah, actually, in fact, it's not necessary. As I said, you can periosteum, you can suture it nicely with the periosteum.
So you can see there is still some deflection there. Can you see, sir?
Yes, yes.
So that means my application of forceps, please. The suture is posterior. So I will need to move the positioning of the suture anterior. So this is what can happen sometimes. So you just revise the suture and place it in the right position.
Yes.
Can you see, ma'am, when I tighten it, it kind of moves to the side. Can you see this? So I'll just revise that stitch by taking it out and placing it in the right orientation. It's actually tough to take out and it spoils the suture every time we do that. But I just don't want to be doing that, giving a small deflection at the end of the surgery after having done so much of a correction. And I also need cartilage forceps. To put a batten graft to straighten it. So get me a cartilage, whatever we have. .26 gauge needle. Take a lid retractor. Hold lid retractor and hold. Cartilage, please. Where did she put all the cartilages? Yeah. So I just want to show you this, sir. So putting a batten graft can actually straighten that piece of cartilage also if it is too fragile. So this here would definitely be helpful in the future growth. Now, if let us say this is too fragile, what would happen again when the forces of contraction come up? It will again buckle. So it may be better idea to get it straight speculum, please. And get it straighter like this. 26 gauge 1/2 inch needle, please. So this is a better technique than scoring or cross hatching that was being followed historically. One more.
See, Vishwas, hello?
Yes, sir.
Hello?
Yes. Yes,
yeah,
sir.
the scoring, it will never work. It's only one, it's been described in literature, there are some publications also. A lot of people do, but I don't think it really works unless you score through and through. In practical experience, the scoring should be almost like through and through. Then only you will be able to straighten it. Otherwise, simple scoring, it will never work. It may be fine on the table, but once you see the result final, once it heals, it doesn't really work. The
Agree,
guy
sir.
called Churikian or somebody has described in the literature. But I think scoring is just for the sake of
Yes,
some
sir.
people do it. But what is the outcome?
It is not
matters.
predictable, sir. It is not predictable.
Yeah.
It can vary with time. So on the table, as you said, go short. Yeah. Cut. It will look great on the table. Give it to the sister. She can cut. Her hands are free. But then I wouldn't want unpredictability at this point, because we have been able to control most of the deflecting points, and now to leave nature to heal on its own without giving control to the stressors would be a disaster. So what we are doing, sir, if there is a bend in a cartilage, we always take one stitch above and below it and at it. So 3 stitches are minimal to get a cartilage which is bending in the right straight line. So you saw that I put one suture on top, I'm putting one below, and I'm going to put one in the center. Manjula ma'am, any questions? I can take them.
So no, as of now, we just check.
So far, nothing has come, sir. We'll wait.
Yeah, what happens is septoplasty is done by most of the people, so I hope it is clear and the points that I mentioned are taken.
Very clear. You explained step by step, so it's very clear, sir.
Cut, please.
See, Vishwas, hello.
Yes, sir.
Dr. Vishnu. See, the severe deflections, not correcting at this age and having mouth breathing for a long time will have certainly change in the facial skeleton appearance and all. I think this is a very controversial debating surgery, and I think you have shown that I think could do a wonderful job, and certainly it will help for the better facial skeleton growth by correcting it rather than leaving it alone and let the child breathe through mouth.
Exactly, sir. You reflect my points. And having a midfacial growth abnormality and an adenoid-like facies, and a child who obligate nasal breathers to breathe through the mouth all the time, struggle. So that is something that we used to leave it alone for long days. Now there are techniques, there are instrumentations, and there are protocols for that. So definitely we can help our patients. Now, another thing that has come in the recent vogue is the maxillary expansion that many people are practicing for patients having midfacial growth issues or malocclusion issues secondary to a long-standing neglected adenoid. So, cut that please. If we happen to, I did mention about the 2 growth spurts earlier. If we happen to intervene before the second growth spurt, what happens is the cartilages will take care of themselves. We don't have to intervene and do surgery again, because you are providing a security for the growth. It's like saying, instead of doing a maxillary expansion and all, get your cartilages aligned, give that space for the growth of the nasal skeleton to happen, and I'm sure it will follow the lines of healing. Long-term results I have seen for myself. I have my own results which I've operated 8-9 years back, And I know for sure that open rhinoplasty doesn't cause any kind of major growth disturbance. The scar, if put lower down, it tends to definitely migrate. I mean, higher up, it tends to definitely migrate up. So I have now tried putting the scar as low as possible. But then that is an inconsequential thing. Over time, it almost disappears. Now, another point I just want to add here is, if you have seen, I have taken the cartilage all the way up. This is not a thing that we need to do. Just give me the 11 number knife. We need to have the batten graft under this part, and not reaching up or flush with the cartilage. Because one, obviously it adds a cosmetic deformity. Second, this is the direction of growth here. So we do not want a cartilage here to intervene and deflect the growth center. Ma'am, is that clear? Anything else you want me to add? Specular, please, relax. So what happened with the caudal septum is, it was, get me the other one. It was away from the columnar pocket. Now what has happened, it has come into the columnar pocket, and thereby we are able to get it in good alignment. Now can you see that the deflection has gone, sir, when I stretch the cartilage?
Yes, sir. It is straight. I think once you show endonasally inside both the sides, I think certainly I think both the sides. I'm sure there must be very good airway now.
Yes, sir.
ये 7% है, जरूरत होगा तो आके ले जाएंगे.
Dr. Vishnu, do you want to add some points to whatever we have mentioned? Anything in your experience? I mean, you have seen it from now 25 years, I'm sure.
Yeah, I think, as we all know, first adenoid should be addressed. And then, of course, if the septum is deviated, at least if it is deflected to one side, perhaps you can wait. But if it is deviated both the sides like here, I think we must correct it. So then only I think the natural growth takes place, rather than a child breathing through mouth forever. Until the olden days thinking of just don't do anything, wait until 15 years or 18 years is a ridiculous statement. You don't want a child to suffer for so many years in life with a blocked nose and mouth breathing. That concept has to be changed, the thinking has to be changed. And when there is research and it has proved, the correction, early correction, will certainly make the quality of life better for the child. So that's why I think we all should agree now that olden day thinking should be changed, and one should accept that a pediatric septoplasty can be done in deserving cases, keeping in mind what all you have shown, the growth points, not to disturb, and the conservative resection in the floor, what you have shown, very minimal correction of the deviated cartilage to resect and keep the septum in midline. And certainly I think is a way forward for, it is, and that too, you have shown the procedure under an external approach, which is something new, a pediatric rhinoplasty. I think I'm sure. I think it is something nobody has shown, the external approach, for the pediatric septoplasty, which you have shown very nicely. And as you said, in your experience, you have not seen any problems, whether it's the scar or whether it's the growth, having your own cases, looking at the cases done before. I think it's a change of thought and awareness for all the ENT surgeons that we have to change our thought, that not to wait until 15 years and let the child suffer, 10, 15 years.
Give it to me.
And that's what I can say, Vishwas.
Thank you, Dr. Vishnu. I mean, those are points which we want to actually convey to our colleagues, that
yes,
open rhinoplasty is not the thing to worry about right now. The thing to worry about is the septum, which we have touched the parts which are not to be touched. So
the other thing is how delicate you handle the tissues, how meticulously you have shown every step. That's what matters. That's the practice. How you, that's very, very important.
Can I add a point here, Dr. Vishnu?
Structures. Yes.
Can I add a point here? So
yes.
Here the transdermal stitch, I'm not tightening too much. I'm just getting it in just alignment for it to be in the, because we are not looking at creating a tip definition point. We're just looking at getting the domes together.
Okay.
Long. Not so long, little long. Yeah. Scissors, please. So the way to
another important thing, endonasally, the mucosa, traumatizing mucosa in children is the most dangerous thing, which can cause synechia and adhesions and blockage. That's the youngsters all should remember that the nasal mucosa should never be traumatized. And if there are two raw areas, then synechia will form. That is the most difficult thing in children, and very difficult to correct it also. So we have to prevent. So dealing with the nasal mucosa, whether whatever technique you follow, whether you do endonasal or external, the most important thing is not to traumatize the endonasal mucosa to prevent synechia.
A very, very valid point, Dr. Vishnu, about endonasal approach and synechia formation. In fact, a lot of children suffer from synechia related obstruction than the septum related obstruction.
Absolutely, I agree. And will the
Dr. Gauri, hello?
Putting the splints will help you?
In this case, ma'am?
Yes, means will you put the those tube-like splints, inside?
Yes, ma'am. Doll splints, yeah, we can put, ma'am, but I just do a quilting stitch just to approximate the septum.
Yeah, means this was in continuation with how to avoid adhesions.
Oh, okay. Regarding synechia, okay. Sorry, ma'am. Yeah, definitely it would help, ma'am. Putting the internal nasal splints. So this is just basically closure, ma'am. So the point of closure is again this. They get that smallest lid retractor. The smallest lid retractor. Now, when we attach the cartilages, we need to make sure that we don't have much tug on the skin. We allow the cartilage to rest at its natural position and get it to approximate where it was earlier. So if it was an adult patient, we would manipulate it. We would rather pull it forward, pull it backward, pull it up, pull it front, change the rotation projection as is required. But here you can see that small lid retractor in position, ma'am. It is just trying to get
the natural
position to the natural position. You can see that this part of the cartilage is bent a little. Can you see, ma'am?
Yes.
Yeah, that's a fragile part. I don't want to be handling that because that is going to give our projection later. So I don't want to be acting too very. Hold it just gently.
How early in pediatric population you can do osteotomies? What is the literature?
Ma'am, 4 years for a midline nasal dermoid when they have operated. There have been some centers where they have done osteotomies to close the book. Because once the dermoid is removed.
Is it always with that dermoid surgery or even otherwise? I want to ask you.
Ma'am, otherwise, if there is a, as I explained earlier, ma'am, if there is a strong deflection because of the nasal bone itself going to one side, I would still handle the inferior portions and not try to manipulate the superior portions. Is that what you're asking, ma'am? Did I get the answer right?
Yes.
Okay. I would still not handle the bones and try to stay away from osteotomies as much as possible.
So till the child is 17-year-old.
Yes, ma'am. Yes, ma'am. So this is what we are getting back into position. This was never there, but you can see that there is some amount of rotation here. That rotation we had, I mean, if cameraman can come to the profile view. Cameraman. This was there on his pre-operative profile view, some amount of rotation, the nasolabial angle being and I'm not putting very tight sutures there. I'm just getting it together. All we want is to form a scar between the lower lateral and the septum. Get it from the side. From there you focus, please. From there, camera focus.
Between Vicryl and PDS, you always prefer 5-0.
Yes, ma'am. Yes, ma'am. Especially in children, ma'am, I would prefer a 5-0 PDS or a 6-0 PDS. Cut.
Take out the camera.
Cut. Short.
See, the Vishwas, the other indications. Hello.
Enough.
Vishwas.
Yes, sir.
The other indications for external rhinoplasty I can think of is cleft nose, cleft lip nose, and as you said, the nasal dermoids, and any badly traumatized patients, any injuries or accidents. These are the cases. Certainly, I think external rhinoplasty is certainly very helpful in pediatric age group. This is one thing I can think of. Where endonasal have restriction, where you can't do endonasal approach.
Yes, sir. Sir, I'm just wanting to mention a few points here. Now, normally when we are closing adult rhinoplasty, we are trying to get the tip diamond or the rhomboid shape by taking one suture on top and one suture below. Now, in a pediatric population, we don't try to get the diamond, but we try to get a circle at least, because the tip is bulbous, not bulbous, the tip is more rounded. So as I told you in the profile view, if you can see again on the laptop, Krishna sir, possibly you can show the profile view, how the tip is a little rounded and it is not very sharp and defined. And also in the profile you can see that the nasolabial angle is a little more obtuse than acute. Has the profile view camera come up? Put the lid retractor. So can you see this? The tip diamond, normally we would give a rhomboid shape at that point. Here we are not worried about that. Profile view, please. Not basal view, profile view, sir. Side view. So can you see the rotation, sir? nose is facing upwards. The nasolabial angle is not 90 degrees. If our profile view camera can come in, I don't know where he is. Please come there. Length is not enough. Take out the camera from the shoulder and bring it there.
You can hold it in your hand.
You hold it in your hand, no? Can't. Huh? Oh, is it? Okay. Okay. Futudent camera, can you move to the side and show the light? Can you show from there? Yeah, just keep it in your hand and show.
Just hold it.
Vehicle rapid 50, please. Reverse cutting. So we try to keep all the structures which we cut in the beginning back to normal. Only when you join these things, can you see the side view? Come back a little. Sorry, the focus is not great right now. Scissors, please. Yeah. Come back a little. Back. Can't this guy get the camera then? Can't you get the camera here? External camera. Try. I mean. So can you see the rotation? Yeah. Come to show the lip also. Show the lip also. Yeah. Yeah. You're good.
I think
you're
you
good.
have to put back the soft tissue left.
Yes, sir.
Yeah.
So this is what we had pre-op rotation. So same thing we are trying to get back. Something has come in the way. What is that? Focusing. No? We are trying to get the external camera here. Okay, you come this side only. Come this side. I'll move out for a while. It's okay. You can fix back. What's the time? Huh? 3:10. Show from here this view, please. Please, on the PPT, please put the profile view. Just want to show this because this is essential for us to know. Yeah. So if you remember the angle, can you show this view, please? Okay, suture, please. PDS, you showing. So if it was an adult, I would try to create the tip at this point. But no, I'm not worried about the tip and all that right now. All I'm worried is to get the structures back to normal. So this is the rotation that you can see prior also, and we are recreating that. We're not trying to advance it and then take it forward like this. So this is just what I wanted to convey. PDS, please. I think what I'll be doing now is to just close the various areas we have opened. Get me the late retractor. So there is a school of thought which says that the septum is excess. Can you see that the septum is not excess and it's actually, it was deflected. We got it into midline. Get back to the old camera, please. You can take out the PPT, sir. Can you take out the PPT and put back onto the hold this, PDS, please? So all that which was split earlier has to be put back, including the ligament of Pitanga. I'll show it in a while how we do it.
Okay, that will reduce that pocket.
Yes, ma'am. And also it will help it pull. Now what happens, ma'am, the purpose of the ligament of Pitanga, if you look at it embryologically, if you can imagine an elephant trunk. So the ligament of Pitangai is that longitudinal ligament or longitudinal muscle in the elephant trunk, which phylogenetically became condensed to form the ligament of Pitangai. So the way the elephant raises its trunk is by contracting this muscle up. So for the the nasal growth also, that muscle is quite important. And that's the reason it is important to, or rather relevant to put the Pitangai ligament back to its original position.
Correct. Thank you.
And this was that cartilage which had gone down. So I realized we had not sutured that. So I'm just getting it back in alignment now. Where is that short suture we had? You kept it aside, is it? The PDS? We could have had that one. Jerin. Yes. Which is the center? You need to keep it there. Ma'am, any other questions or points that you want to mention, ma'am?
Not really. Very good demonstration. And really, this topic needed to be addressed by a stalwart like you. And we really enjoyed the way you dissected that initial part, because that was, I found that it is a very, I thought that it is a very difficult dissection. So thank you very much for demonstrating this case.
Thank you, ma'am. That's very nice coming from you. Feel good, but I don't know, I'm not a stalwart and all, but then I try to do what I do on every other day just to showcase what I'm doing so that everybody can follow the same thing. The theme of this workshop, as defined by the Microlabs team, was common ENT surgeries that everybody could perform. So the purpose, as defined by Deepak sir, is to give people the confidence to be able to do these surgeries back in their practices. And if I've stuck to the basics and told the simple things, maybe I've served some purpose here.
Definitely.
Sir, there is one query, very important query from postgraduates. They're asking if they want to learn these techniques of rhinoplasty, what would be your advice to where should we go and learn about it?
So for postgraduates, one thing is there are a lot of courses and conferences these days. Just the other day, I was mentioning to our colleagues that every other month in the year 2023, there is a course and a conference. So in January, there is a Singapore course and the Pan Asia Academy of Facial Plastic Surgery course. February, we have Dr. Virendra's course in Pune. Then March, we have Dr. Sunil Tanwar's course in Jaipur. Then April, we have Dr. Vishnu Reddy's course in Hyderabad. Then May is the course that I run in Bangalore. So this is all part of our association called FRCSI, which trains people in facial plastic surgery. Likewise, in June, July, August, there's a course in AIMS Delhi. So our purpose is to reach across the country and teach people facial plastic surgery, which also includes rhinoplasty. So if you're interested as a postgraduate, you can start attending these workshops and conferences, build your CV, present more papers. That's what Jerin has done. And he's the fellow who is recognized by the International Federation now. And that's how he is proceeding. It's a one-year fellowship that we do. And he rotates amongst multiple centers, which give him various kinds of training. That is if you're interested. If you want to do only rhinoplasty, which at least I would request you not to do only that, because the field of ENT head and neck surgery has gone way beyond what we were doing many years earlier. And now facial plastic surgery is a very well recognized and well respected specialty, having a good work-life balance. So I would encourage you all to take up the entire gamut of facial plastic surgery and train adequately. And then you can take up exams in the international level also, which is called Michael Rapid, please, and fine AdSense forceps, called as the International Board Certification for Facial Plastic Surgery. That will kind of give you that international accreditation to perform facial plastic surgery in India. Michael Rapid and Jelly, please. Jelly. Ma'am, does that answer the question, or do they want any more points to be mentioned? And we also run observership programs. Sorry, I forgot to mention that. Observership programs, which put the jelly properly, which are short observership programs. Various centers have accepted to take observers for the short periods. I think one of the centers that has accepted is Dr. Kshitij. Can you see this ligament of Pitangai, sir?
Yes, we can see.
Ma'am, that so when we have cauterized so that it becomes easier to identify it, that was the deep ligament of Pitangai, if you remember, and that was attached to the dome, upper part of the intermediate crura. So we get it back to that portion itself. Take out those sutures which are extra.
So just to give an update, we have 700 live users watching your surgery, plus 725 medical college satellite centers are also in addition to this are viewing your surgery, sir.
Ma'am, thank you. I mean, that is thanks to Microlabs team and not my surgery that we have such great viewership, because you have maintained the quality of the program throughout the 5 years that you have conducted, and have been extremely kind of graceful on the ENT fraternity. I always take your name as one of our teachers, because you have started a program when nobody was kind of doing this kind of big ENT programs to the benefit of the postgraduates, consultants alike. And the viewership, I'm sure, is a reflection of what you have worked so far. And thanks to the Microlabs team, I think at this point I should remember Mr. Pradeep.
Yes, sir.
who is the initial, late Mr. Pradeep, who was the initial brain behind this program to have a separate training program for ENTs when the country didn't have much of training programs for ENT. Cut this, please. Short. You always cut short. You never use the scissors cross. Okay? You hold the scissors straight.
Good afternoon, Vishwas. This is Dr. Ilambardi from Chennai.
Hi, sir. How are you, sir?
Fine, Vishwas. I have been watching you for the half an hour. And
thank you, sir.
Excellent demonstration, Vishwas.
Thank you, sir.
You are showing Pitangi ligament and its suturing.
So nice to see you in the audience, sir.
Yeah.
This is the superficial ligament, ma'am. Can you see it?
Yeah. Okay.
So this, sir, goes below towards the intermediate crura or below the intermediate crura. So that gives the fullness as well as helps the skin get pulled along with the nasal growth.
Okay.
So that's why we have to get it back.
So you have put two different sutures, one for the deep ligament and
yes, ma'am,
one for the superficial.
Yes, ma'am. I hope it was clear on demonstration, the deep and the superficial, when I initially cut that, ma'am. Was it appreciated then?
Yes.
Okay. Need more jelly. So you can see the first suture for the deep ligament is here. The second suture for the superficial ligament is just under the intermediate crura.
Yes. We are seeing it. Yeah.
Ma'am, and then you wanted to know what we use for transmitting this video relay. So what we are doing here is a jugaad, as you mentioned. We have a endocoupler. We have a endocoupler, which Dr. Vikram has developed, and that's based on the pinhole camera principle. And normally we would have put a VTOM or a exoscope and attached it to the endoscopic camera. But now we found that with the coupler, why is it so blur? Some blurring out happening, no?
The normal endoscope is.
Ma'am. So normal endoscope camera, no endoscope, but a coupler in place. So if there is a chance, I will show how the coupler looks. It's a very simple plastic, probably 100 rupees device. So where is 10 lakhs? Where is 100 rupees? So that is where we have come to with the Indian jugaad. And I'm proud to say that our own people have developed it. Vikram sir, I should thank you for that excellent device that you have made for all of us to benefit. I don't know if he's listening, but then yes, Kulkarni sir. Okay. Probably the external camera can show how we have made that transmission possible, because
Yes,
if you
yes.
record a case, it would be very useful to do it in this manner now.
So can we see it?
External camera, please focus on the device that is actually sending the endoscopic image right now. So there is obviously a stand which holds the endocoupler that can be custom made as per your requirements, and it is attached to the OT table. Put a saline wash here, please. Here, I should see the edges of the skin while I'm suturing. That is the purpose of the saline wash. Yeah, thank you.
So we can see some stand.
Yes, ma'am. So we have put the camera within it. It's a spice camera. So it gives excellent clarity, almost 4K, 8K, I can say. And then we have run the endoscopic wires and put an endoscopic sleeve around so that we are in the sterile zone. And there are two headlight, or rather lights. You can see this. These are two lights here, which are giving the it is that light which we use for portable endoscopy, ma'am. Wait, goes, please. That light, we have got it attached to the camera there. So that is giving a general illumination. Along with Michael Rapid, put jelly and give. Along with our own lights that I'm wearing, you can see I am wearing a headlight.
Correct.
Then we have the top light as well. So almost a very bright illumination here for us to give you this picture that you're seeing. So we have kind of experimented around with this for a long time to understand what works or what is better on the screen. And thankfully, we have the Futudent camera also. Just shift to that image, please, Futudent. Yeah, you can tell the transmission guys to show the recording. So the Futudent camera is a very small 4K camera. It fits onto the loop, and we have acquired it in Trustwell Hospital now. So it is for all recordings, and it is quite affordable as compared to the VTOM and the other devices. Long, please. Slightly long, not so long. Not so long. Not so long, short, yeah. So the corner stitches, so this is the recording of the Futudent camera that is being shown on the screen. Can you see it, ma'am?
Yes, yes.
So we can focus and all that. So especially
The previous picture was quite, that was better. Actually.
Correct, ma'am. So what has happened with this Futudent camera is it's more of an intraoral camera. So it was initially developed as a dental camera for the teeth, and all that. And then now they are adopting it for cardiac surgeries. So in closed spaces, it is much better quality. So like the other day I was doing a cleft palate. It was good quality on the cleft palate because it is in closed spaces where the illumination is not too bright. So we choose between the cameras to get your output also, recording also. So the tools that are available right now, ma'am, we can comfortably say that we are again spoiled for choices, and we have enough and more tools in our hands to be able to record great quality videos. So I just want to tell about that sutures what we placed. So I placed the Vicryl Rapid at 5 points. One is the subcutaneous tissue, and one is the corner wherein there's a diversion between the vertical cut. Can we see it? My hand coming in the way, sorry. So there's a cut vertically and then there's a cut horizontally. So that corner we get the Vicryl Rapid, the other corner as well. Then we also get one suture between the vestibular mucosa wherein we have made the incision. So 5 stitches and then the subcutaneous V point stitch to close the mid-columnar incision. So very specifically 5 areas where we can use it. The rest of it on the skin, always we would prefer a Prolene stitch because it is less reactive. As mentioned earlier, I would prefer a PDS to a Vicryl because Vicryl is a polyfilament and the reaction to Vicryl is more tissue reaction and more vigorous scar formation. We want the scar formation to be as minimal as possible because that can deflect the cartilages or deflect the ligaments. So I would prefer using a PDS over a Vicryl. Prolene on the skin for the reason that it is a monofilament and it has least tissue reaction as compared to other suture materials. So on the skin, when we put the Prolene, the healing and the entry point and the exit point of the needle and the suture is not much visible later. Whereas if you put a Vicryl or a Vicryl Rapid, there is some tissue reaction or darkening or pigmentation, and that can give rise to a scar, though not raised, which is visible. Something like a post-inflammatory hyperpigmentation. So that's why I would prefer avoiding a Vicryl on the skin and prefer long, please, long, yeah. Yeah. With me 60 Prolene, please. Hold this. The basal camera can come in and show us the basal view. Steri-strips R1547. No, I'll be using quilting, so no packing. So take a Vicryl 40 on the long needle holder, or I can use the Vicryl Rapid only.
For quilting sutures, do you use the same 50 or you will use little thicker suture?
3 and 4 is preferable, ma'am.
Yes.
Yeah, because here what has happened is the septum had deflected so much that the mucoperichondrium was thin. So I thought a Vicryl Rapid 50 should be sufficient to give a good approximation. So if I use a bigger needle or a bigger thread, when I tighten the thread, sometimes that might be the point where we can have a septal perforation.
Okay.
So what happens is we use all our breakfast and lunch strength on the suture, and that can be counterproductive many times.
But 50 needle, isn't it very thin to go and pierce the cartilage as well as both the sides perichondrium?
Yes, ma'am. It is thin, but the advantage of the 50 Vicryl Rapid is it has a reverse cutting needle. So the concept of reverse cutting is the sharp edge is not superior and it is inferior. so it doesn't cut through much through the cartilage or the mucoperichondrium. Now here I just want to show this. Get the basal camera, please. Can you focus on what I'm doing? Yeah, ma'am, I just want to mention this point. Sorry to interrupt. Can you focus here on this part? Yeah, little zoom, please. I want them to see the sutures. Zoom, please. Zoom, zoom, zoom. So the edges here, ma'am, in a child, we would try to put a vertical mattress because we want the edges to evert. So this is a concept which we use in facial plastic surgery in areas where there are growing skin or growing skeleton. I'll try to explain it with a diagram. Just put it into this one, put it. So get me the marker. So normally when we put a suture, we will get it into approximation with a simple edge. So over time, once you remove the suture, the wound tends to contract and heal with a inversion. So what we do is we put a suture in such a way that there's eversion on the table. So once you remove the suture and the tissues heal, they become equiplanar rather than going inverted. Now inverted edges are the ones which show from a distance. So in a child with a growing skeleton, if you have excess skin on top, as the skin heals and as the nasal growth happens, the scar will adjust itself to a equiplanar level rather than you give a equiplanar stitch and then it becomes inverted. So does that make sense, sir? Yeah. Prolene. Hello.
Yes, sir.
What's the time?
So 3:30.
Yeah, I think we'll be finishing in another 5 minutes. So possibly the next theater can get ready. And I'm very fortunate that I'm operating alongside the doyens in ENT, Deepak Haldipur sir, Sanjay Agarwal sir, and Vijendra sir. It's a privilege to be also talking to you all continuously and interacting with Dr. Vishnu Reddy, whom I look up to, who was the founder chairman of our facial reconstructive and cosmetic surgery India, and Gauri ma'am, who has been there and guiding us in the right things to do in life and in ENT. And for the great audience who has stayed up with me during the lunch to listen to whatever little I know and I'm able to put across to you. I hope I could communicate across. So please let me know if there are any places where you want more information, and I'll be happy to talk to you or interact with you later. Cut, please. Cut from the side, yeah. Dr. Krishna, any questions that have come up?
A couple of questions. One is, this is Dr. Jasmine from Bangalore. Sir, we see you're using a loop, sir. How much of an advantage and what are the advantages does the loop provide?
So the loop is a great advantage when you're doing this kind of sutures. You need to see exactly the skin edges so that the edges get everted. Now, what magnification you are seeing on the screen, I am seeing little more than that. Possibly you are seeing 2x, I am possibly seeing 2.5 to 3x, 3 times the magnification. So that helps because your entry point, your exit points have to be perfect. It has to be 2 millimeters away from each other and it has to be equidistant. When it is equidistant, the scar heals very well, and then the parent won't be worried about this child having a scar out of the surgery. Second thing, what I can tell about the loop is, it's a disadvantage if you're doing larger surgeries or areas where there are a lot of tissue to be removed or a lot of tissue to be handled, because even a single drop of blood will look like a waterfall. But then if you're doing small areas, it is better to do with the loop. Now the loops that you buy have to have your own prescription glasses so that you can look outside the magnification for some time and inside the magnification most of the time. Only then you can get a balanced view of the surgical field. If you're constantly looking through the loop for long hours, then it will lead to a lot of headache and possibly some amount of blurriness, because you'll get used to watching everything with magnification. So I've got this loop from the Univet company, which is custom made to your interpupillary distance. It is custom made to your working distance. So they actually ask you measure everything, and then they supply the loop over 4 to 6 weeks. Ma'am, you asked something?
No, we are watching you on the way you are suturing.
Hello.
And this point was,
Hello, this is from Vijay NT Care Center, Bangalore. We are already ready with our next case. To save time, we have done already some steps.
Yeah, we are seeing in the PIP picture, small picture. Nilesh, we are seeing.
Yes, sir.
Yeah.
You tell us, sir. You let us know when to start. Then we'll start, sir.
So I will just do the quilting stitches, sir. So we can definitely go to your theater. I have done with my surgery. I'll just show you the speculum in the last pass, so as to see the passage, whether it is clear. 5th size speculum, please. Get the steri-strips ready. So this is the passage that we can see all the way down into the nasal cavity. And this also effortlessly passing in all the way down into the nasal cavity. So hopefully he'll be able to sleep comfortably without much apnea. And thank you so much for a patient listening and watching my surgery. Thank you. Yes, ma'am.
this will not be needing plaster, isn't it? This doesn't
Only
need a
steri-strips, ma'am.
plaster,
Only
will it?
steri-strips.
Hello.
Just to reduce
Only
the edema,
steri-strips,
and get the ligament of Pitanga
Correct.
to sit back very well.
Correct. Thank
I
you.
won't use the splint though.
Splint you are not using.
No, sir. I would not use the splint because we have not done anything over the bone.
Not for internal splint also?
Internal, no, sir. I'll be putting a quilting stitch. We have sufficient space now internally.
Okay.
इधर ही लगा लो ना, उस जगह पे सिद्धेश की.
Thank you, Gauri ma'am, and thank you, Dr. Vishnu, for moderating my session. Thanks to Microlabs and the audiovisual team, which could manage the uninterrupted video. And thanks to my team at Trustwell Hospital, the anesthesia department, especially N.S. Chandrasekhar sir, Jaidev sir, then Jyotsna ma'am, and the entire anesthesia technician team, especially our sister and brother who have assisted us for the long hours here, and to the entire staff of Trustwell Hospital for making this event possible. And final thanks to the Microlabs Micro Knowledge Academy for believing in us and giving us cases so that, or rather an opportunity so that we could demonstrate better. Thank you. Signing off from Trustwell, and see you all soon.
Thank you, Dr. Sir, for the wonderful demonstration of the pediatric septoplasty case there. And thank you, Dr. Gauri Madam and Dr. Reddy sir. We move over to the another center now for a couple of other cases from Dr. Vijayendra sir and team. To moderate this session, we have our eminent faculty here joining in us today. We have Dr. Prakash Munka sir joining in.
Hi.
वो बैग भी दे दो. उनका बैग.
Hello. Hello.
Yes, sir.
Hello.
Yes, sir.
Hello. Yeah. Good afternoon, sir. We are hearing you, sir.
Good evening.
Good evening, sir.
Yeah. So at the outset, I thank the Microlab Heroes Division for this wonderful arrangements. And as we are running short of time, almost 1 hour behind, we have started the case. The first case is a case of stapedectomy. Dr. Vinay will be demonstrating that. And also I congratulate Vishwas for a wonderful demonstration. I've been watching from 1.5 hours. Vishwas, thank you very much. I learned so many things from you. It was an excellent demonstration. And I hope all the audience have really enjoyed your surgery, including me. So with these few words, let us start rolling the ball. So I will give my mic to Nilesh for narrating the history of this patient. Mic to Nilesh, please. We are doing a local anesthesia. He's a 36-year-old boy. So he's got a bilateral hearing loss. Operating this case under local anesthesia. I'll hand over the mic to Nilesh to narrate the history of this patient. Nilesh, please. Time already we have elevated the flap and curated the posterior rings, and we are ready to start directly the procedure with the stepidotomy.
So good afternoon all. This is Dr. Nilesh from Vijay ENT Care Center, Bangalore. First case will be demonstrated live by Dr. Vinay Kumar Vijendra. It is a case of stepidotomy. So he is a 36-year-old male who is presented with bilateral hard of hearing, right more than left, since last 3 years, which is associated with buzzing sound. So this is the pure tone audiometry. It is showing 65 decibel hearing level in the right ear and 53 decibel hearing level in the left ear. The reflexes are absent both the sides. We'll see the CT scan of this patient. So here I'd like to thank my guru, the radiology guru, Dr. C. Ramchandra sir and TNET Diagnostic Center, who has done this CT scan free of cost, because we have asked them, this patient is poor and we are operating in the conference, so they have done it free of cost. So we'll see the ossicular chain. First and foremost thing, we have to confirm whether ossicular chain is normal in any case of otosclerosis. So here you can see the normal ice cream cone appearance, the head of the malleus, the body of the incus, and the short process of incus. So this is normal morphology, and we can trace the long process of incus here. And this is called double dot sign. That is, lateral dot is the lenticular process of incus and medial dot is the head of the malleus. And you have to see whether both the dots are merging with each other or not. So here you can see both dots are merging with each other, means IH joint is intact. Then to see stapes, we have to go again up in the scan. You can see stapes, the anterior crust, the posterior crust, and if you look at the foot plate is very thick here, you can see, and there is a otosclerotic focus over the fistula antefenestrum. So very thick foot plate with otosclerotic focus over the fistula antefenestrum with the intact ossicular chain. It is a otosclerosis case. Here cochlea is normal, so the foot plate is thick, anteriorly otosclerotic focus is there, ossicular chain is intact. So these are the CT scan finding in this case, and the diagnosis is bilateral otosclerosis with mixed hearing loss with tinnitus. The procedure plan is right tympanotomy and procedure. That will be the stepidotomy in this case. As we already know, it is a case of otosclerosis, but always you should be prepared for, as Professor always says, the ear is a Pandora box. You never know after elevating flaps what you will get inside the ear. So always you should be prepared for that. That's why we have written the procedure as right tympanotomy and procedure. We'll confirm the diagnosis and then we'll proceed for the stepidotomy. And you have to explain patient that it is not done for tinnitus. It is mainly done for hearing improvement. So I'll hand over mic to Dr. Vinay Vijendra, who has already ready with his case. He has done some prior curating and a flap elevation, everything. He will explain you the details of the surgery. So this is a live transmission from Vijay ENT Care Center, Bangalore. Hello.
Good afternoon, Vinay. We have been watching you curating and elevating and curating while watching this surgery in PIP.
Yes, sir. Thank you very much. First of all, I'd like to thank Microlabs Eros Division for giving me this opportunity. And we were just watching the wonderful surgery by Vishwas sir. And it was really very well done and well explained, and it will be a tough act for me to follow. Dr. Nilesh has already explained the details about this case. This is a straightforward case of otosclerosis. You can see a thick otosclerotic focus near the fistula antefenestrum. Just to save time, I have elevated the flaps. So to make the flaps in stapes surgery. First, we make a vertical incision in the 12 o'clock position and another incision in the 6 o'clock position, and a horizontal incision about 6 millimeters from the annulus, lateral to the annulus, to join these two vertical incisions. And I've elevated the flap here and curated the posterior rim. So you have to curate the posterior rim enough to see the facial canal superiorly and the pyramidalis process posteriorly. So now you can see the facial canal very clearly and the pyramidalis process as well, along with the stapedial tendon. You can also see the posterior crust, which is quite thick there, and the promontory also. And the foot plate is also very clearly visible. So the otosclerotic focus is very clearly seen, Kautik. You can see the thick otosclerotic focus here close to the fistula antefenestrum and the facial canal. And even on the promontory, you can see a otosclerotic focus. The foot plate looks very thick here. And you can see the incus is moving, but the stapes is quite fixed. So this confirms our diagnosis of otosclerosis. And now I'll proceed to make a fenestra, a control fenestra of 0.3 millimeter using a fish perforator. So making this control fenestra is very crucial. In case we encounter any fracture of the foot plate or subluxation of the foot plate, we can always use a 0.2 millimeter pick to lift up the fragments once we make the 0.3 millimeter fenestra. So this is a 0.3 millimeter fish perforator, and always make the fenestra in the posterior third of the foot plate. I'm holding my instrument between my thumb and my index finger, going posteriorly. Always make the fenestra in the posterior 1/3 of the foot plate so that you don't accidentally damage the saccule in the vestibule. The foot plate looks quite thick. I'm gently rotating the instrument between my thumb and index finger without applying too much pressure on the foot plate. You should be very gentle while doing this.
Dr. Vinay,
Yes, sir.
With the thick foot plate, will you like to use the skeeter drill?
Skeeter drill is also an option, sir. I would always like to use the perforator first. If I still feel it is not possible with the perforator, then I will try to use the skeeter drill, because I feel I have more control with the manual perforators.
Right.
Even if I use a skeeter drill, I will only thin out the foot plate.
Exactly.
And once I see the blue lining, I will use a manual perforator to complete the fenestration.
Now, the only point was, suppose if it's a thick plate, you
Yes, sir.
need to increase the pressure of your perforator, which should not be.
Yes,
So
sir.
it's a controlled one. And if you thin out with a skeeter, probably that is better.
Yes, sir. But you can also use the same pressure. Only thing is, it might take a longer time to penetrate through the thick foot plate, sir. 0.3. You can see a small impression of the lower end of my perforator.
Yeah.
Now I can feel the give way sensation.
Right.
You can see a small perforation has been made, but I still have to widen it. It's not completely 0.3 millimeters still. Old one could be 0.3.
With the thick foot plate, it is very important to keep the pressure to the minimum. And
Yes,
one
sir,
should
that's
not
true,
tend
sir.
to press it because to hasten up, somebody may have prompted to do that. That may lead to fragmentation of the foot plate and other problems.
Yes, sir. That's a very valid point. When the footplate is very thick and we feel that it is not, the fenestra is not easily made, we tend to increase our pressure. So that should never be done. Even if it takes a long time, try to maintain the same sort of pressure that you would do in case of a thin footplate.
Right.
Only thing, it might take a little longer to make the fenestra.
Yeah. One
But if
has
you
to be
apply
little
pressure,
patient
you'll end up
and do
with
it very gently.
complications. So now I can see that my instrument is moving completely 360 degrees,
Right.
which means that the fenestra has been made.
Good.
And also it is more of a tactile sensation. You can feel when the resistance has reduced. That means that the fenestra has been completely made. And you should get a round, even fenestra.
Yeah.
Now I'm happy with the control fenestra. There's a little bit of bone dust around, which I can leave for now. So after making the control fenestra, we're very safe because after this, even if you encounter any fracture of the foot plate, you can always use a 0.2 millimeter pick to go medial and pick up the instruments from medial to lateral. So you can pass that 0.2 millimeter pick into the vestibule and pick up any fractured fragments if you encounter any fracture.
Right.
So after making the control fenestra, the next step would be to drill out the posterior crus. So in this case, you can see the posterior crus is very thick and it is almost adherent to the promontory here. So I'll carefully just drill it out.
Please
using the
centralize.
Yes, sir. 1 minute.
Yeah. No.
Okay now, sir?
Yeah.
So one must be careful about the facial canal also when you're trying to drill out the posterior crus. I'm using a contra-angle handpiece to reach this area. And try to drill at a very low speed. Tick. The chorda is coming in the way, so I'll just try to push it away a little bit before I attempt to drill the posterior crus.
Vinay, we are seeing some autosclerotic focus in the round window niche area.
Yes, sir.
Will it affect the final result?
Not really, sir. As long as the round window membrane is moving freely.
Okay.
So now I'll try to drill out the posterior crus again.
This is a 0.6 mm diamond burr.
Yes, sir. Yes, sir. 0.6 mm diamond burr, and I'm using a contra-angle handpiece So it makes it easier to reach that area.
Okay.
And always keep an eye out on the facial canal. Section. Very thick posterior crust in this case, and also it is adherent to the promontory.
Yeah. Can we keep a gel foam over the fenestra site and then do this procedure?
Generally don't use it, but yeah, to prevent bone dust from entering, you can do that, sir. Yeah, it's almost completely drilled out, just a little bit more. Yeah, now I'm happy. The posterior crust has been completely drilled out. After drilling out the posterior crust, the next step is to disarticulate the incudostapedial joint, and then I will cut the stapedial tendon. 45-degree pick. So I'll just push the incus just to locate the IS joint. The incudostapedial joint is somewhere here.
Yeah.
I can just score it out with a 45-degree pick. Now the incudostapedial joint has been disarticulated. Next, I'll cut the stapedial tendon. Now this order is also very important. One must always go in this order. First, drill out the posterior crust, then disarticulate the incudostapedial joint, and finally cut the stapedial tendon. That is because to drill the posterior crust, the stapes foot plate has to be very stable. And the stability is provided by the intact incudostapedial joint and also the stapedial tendon. So always drill out the posterior crust first, and then take the advantage of the stapedial tendon when you're trying to disarticulate the incudostapedial joint. Always try to disarticulate the incudostapedial joint along the direction of the stapedial tendon, because that provides some bit of counter pressure. And after the IS joint is also disarticulated, cut the stapedial tendon close to the pyramidalis process. That is because the stapedial tendon comes out when I remove the stapes suprastructure. If you cut it close to the stapes here, the stapedial tendon will be hanging here, and that might keep coming in the field of your surgery. So I've cut it close to the stapedial tendon, close to the pyramidalis process. So the stapedial tendon will come out along with the suprastructure when I remove it. Now the anterior crust is usually very thin and long, and it easily gets fractured. Now I just have to push the suprastructure towards the promontory. And you can see the anterior crust got fractured easily. There are some adhesions here between the promontory and the stapes suprastructure, alligator forceps. Now I've removed the suprastructure. Gives me a lot more space to work with once once the suprastructure is out. .4. So now I use a 0.4 millimeter fish perforator to further widen the fenestra. Again, the same principles. Hold the instrument gently between your thumb and index.
Yeah.
Don't apply too much pressure. Gently start widening it.
Just gentle rotation.
Yes, sir. Dr. Vijayendra always says your instrument should be floating in the air. So that's how little pressure you have to use to make the fenestra. And it's more of a tactile sensation which lets you know that you've made the fenestra. So initially when you're rotating the instrument, there'll be more restriction to the movement of the perforator. But as the fenestra widens, you will see that there is very free movement of the instrument, and that itself shows that the fenestra has been completely made. Now this is a 0.4 millimeter fenestra. You can see that it is very circular and very clear.
Yeah.
Is it clear, sir?
Yeah, fine.
0.5. Here I feel the footplate width itself seems a little small. That is because of the otosclerotic focus all around it.
Yes.
Yeah.
Now 0.5 millimeter perforator.
Yeah.
Again, not using any pressure, gently rotating my instrument. So the control fenestra takes a longer time, but once the control fenestra is made, the subsequent enlargement of the fenestra is much easier.
Yeah.
Now you can see it's 0.5 millimeters.
Yeah.
Finally, I will use a 0.6 millimeter perforator to make the final fenestra of 0.6 millimeters. Is it clearly seen, sir?
Yeah, say nicely.
Yes, sir. It's come out very evenly.
Circular and nice.
Circular, yes, sir. Yes, sir.
Yeah.
Like I was saying, in this case, the footplate looks a little narrow. That is because of the otosclerotic focus all around it.
Yes.
Because there's otosclerotic focus near the facial canal, near the fistula antefenestrum, and the promontory. So all three sides, it is obscuring the footplate, and it looks a little narrower than what we usually see.
Yeah.
And never suck directly on the fenestra which you've made. Always suck away from the fenestra, because that is the vestibule, and you must never make the vestibule dry. 0.6.
And that's one of the commonest cause of SN hearing loss in the post-op period.
Yes, sir. Yes, sir. Now you can see a little bit of bone dust all around the fenestra. So I'll use a 0.2 millimeter pick in order to remove that from medial to lateral, because I don't want to further push it inside using a 0.6 millimeter perforator.
Right.
0.2 millimeter. So the 0.2 millimeter pick is a very useful instrument whenever we encounter any fracture of the footplate or a floating footplate. After making the control fenestra, you can pass this inside the control fenestra and lift up the pieces from medial to lateral. And in this case, because there are bony fragments around the fenestra which I've made, I'm using the same instrument. You can see there's a small projection in the instrument of 0.2 millimeters.
0.2 millimeter.
Yes, sir. So I'll go here and I'll lift up those pieces from the periphery. So that will further widen the fenestra a little bit. And also it prevents these bony fragments from going into the vestibule. Before placing the piston, I try to remove these bony fragments from the periphery, just to make sure that the piston doesn't further push this inside the vestibule.
Yes, correct.
So again, I'm trying to suck, but I should be careful to suck away from the fenestra.
Yes.
0.2. 0.2 pick. Few more bony fragments. Yeah, now one whole rim of bone dust came out.
Yeah. Yes, yes.
Suction. Once more, 0.2. After I removed that piece of bone dust, you can see that a lot more of the foot plate has come into view anteriorly.
Yeah.
That bone dust was sitting anteriorly and was obscuring the foot plate. After removing that, I can see the anterior part of the foot plate very clearly. Slowly. Yeah. Just one small piece here next to the promontory which I want to remove.
Inferiorly.
0.2. Yes, sir. Inferiorly, one small bit is there.
Yeah.
Yeah. 0.2. Yeah, now it came out.
Yes, yes.
And now it made it nice and circular. So that is the importance of using this 0.2 millimeter pick.
It
So
looks
in
wider
these,
also. Wider also.
Sorry, sir?
It looks wider also now.
Yes, sir. Yes, sir. So whenever we come across any bone dust like this or any small fragments going into the vestibule, we can always use this 0.2 millimeter pick to lift up those pieces from medial to lateral very carefully and gently.
Okay.
So next I'll take the piston. Before that, I'll just infiltrate a little bit of local anesthesia post-auricularly. So because I'll be taking post-auricular soft tissue, seal the fenestra at the end of the procedure. So now if I infiltrate, by the time I place the fenestra, the infiltration would have acted.
Vinay, before that, will you wait for the perilymph flow to see?
Sorry, sir?
The perilymph flow,
yes,
you
sir.
see for it first before putting the piston?
Usually it won't be too much, but just before putting the piston, I'll again use a suction there so that I get a clear view of the foot plate, sir.
And in how many percentage of your cases you get the perilymph gusser sort of thing, lot of fluid coming out?
Fortunately, I have not seen any case of perilymph gusher, sir.
Okay.
Sometimes it is more than usual, but I've never seen something like a gusher where it is difficult to stop.
Yeah. This is a normal perilymph leak only. Yeah.
Right.
Yes, sir. This is quite normal.
Yeah.
So generally, in about 90% of the cases, we take 4.25 millimeter piston, and that is the most common piston that we use. And here again, I've placed it in the 4.25 millimeter slot.
Diameter point?
0.4, sir. 0.4 millimeter diameter Teflon piston.
Okay.
We always use Teflon piston. Alligator. So you should always open the loop of the piston very widely before placing it, so that it loses the memory, and it should stay open when you're trying to place it around the long process of the incus.
Yes.
So I'm using alligator forceps to just hold it open for some time, about 20 to 30 seconds, so that it stays open when you're trying to place it in the fenestra.
Right.
Cut ಮಾಡಬೇಕು.
Have you measured the length?
Usually I take 4.25 millimeters of this. In most of the cases, that will be the length which is required. In case it turns out to be a little short, then we use a different piston. And if it is too long, then we take it out, cut it, and put it back in, sir.
But before putting, you don't measure usually?
Not routinely, sir.
Okay.
This is for both females and males, Vinay?
Yes, sir. Yes, sir. 4.25 is what we routinely take.
Okay.
But there are advantages of keeping it measured from the middle of the, incus, and then taking the length. Just
yes,
because
sir.
in that case, you don't have to redo again and again. If you know the length, what I am going to put in, that is always better.
That's true, sir. That is a valid point.
Yeah. Because there cannot be a universal size for all. Basically, there are changes, so.
Yes.
There is no harm keeping a measuring rod and doing it. It's just a two-second job. So.
Prakash Mukha sir, measuring is basically our visual impression.
No, sir, I think it is always better to measure because what I feel that one size may not fit all. And then I have seen some cases, especially those who have seen the floating, it has not gone up to the length or it is hitting back. So what Vinay says, he will fit it and then he will check for it. It's always better to preempt and measure. That is my feeling.
Yeah.
That will tell better.
According to Vinay, it is for most of the cases. If it is shorter in length or longer in length, he will redo it. That's all.
Right.
Because in most of the cases, this will be a accurate length from what we've seen. But yeah, your point is very valid, sir. It is always better to measure before placing it. Now I place the lower end into the fenestra and the upper end around the loop of the piston.
Right.
I have to further open the loop of the piston wider.
Yeah.
Alligator.
Yes, closed a little bit.
Yes, sir. Because I took some time to suck the perilymph and then try to place it back. So by then it had closed a little bit. So now the lower end again goes into the
Yeah.
fenestra. Degree pick. And once the lower end is inside, I've placed the loop around the long process of the incus. I'll just try to push it in a little bit.
Yeah.
And now it is around the long process of the incus. Suction. Degree pick.
You do what you call the bending and this test now.
Hanging, bending and hanging.
Yeah.
Yes, sir. Bend test and the lift test.
About the adequate length.
So now can you see the lower end of the piston, sir?
Yeah. Yes.
Yeah, it is of adequate
nice.
length. It is moving also quite freely.
Really?
So about 0.2 millimeter of free space should be there around the fenestra for good sound conduction to happen. So there is a 0.6 millimeter fenestra and a 0.4 millimeter diameter piston. So there is adequate space around the fenestra for proper sound conduction to happen. The lower end is also very clearly seen. Is it appreciated there, sir?
Yes. We are seeing very coming out all around.
Now this is the bend test. You can see the lower end of the piston when I do the bend test, and it is not coming out.
Right.
So if it doesn't come out when I do the bend test, it means that the piston is of adequate length.
Right.
And the lift test again, where I lift the shaft, the long process, the incus, and again make sure that the lower end does not come out of the fenestra.
Very good.
Again, I'll show you the lower end of the piston.
After crimping also you can test.
Yes, sir. Crimping also I'll do. But before that, we have to confirm if the length is adequate.
Right.
And you can see that there is free mobility of the piston.
Yeah.
Lower end is also very clear, sir. The length is adequate.
Yes.
And about 0.25 millimeter length of the piston should be inside the vestibule for good conduction of the sound.
Okay.
And finally now I will crimp the piston. Again, I use alligator forceps for this.
Right.
So crimping this piston is a very challenging part of the procedure. You have to open the mouth of the alligator forceps very wide, go all around it and gently crimp the piston without applying too much pressure.
You use the same alligator forceps. There is a
yes,
available, but you use this.
Yeah. So I go all around it without touching the loop of the piston, and then gently start closing it.
Yeah.
Now it got crimped, sir.
45
degree pick. So gentle pressure is important. Don't try to close it at once. So slowly I closed it, and the loop of the piston got locked around the long process of the incus. You should also make sure you don't crimp it too much, because that might lead to necrosis of the long process in the long run. And finally, I'm just placing the chorda tympani in front of the piston just to add some amount of security so that the piston does not slip out.
Yeah.
So now the chorda tympani is sitting in front of the piston. Now the final step is to take some post-auricular soft tissue and seal the fenestra.
Okay.
Because there is 0.2 millimeter free space, we'll try to seal it with soft tissue. I've already infiltrated just before taking the piston.
What other sealing options you have?
Vein graft can be used. Some people use blood clot also.
Ear
But,
lobe,
I
ear
have not
labial fat.
tried any of those.
Vein
Sorry,
graft
sir.
should not be given because you
Ear labial fat also you can
you have to
use.
Fat,
revise.
yes, sir. Fat is also an option. Correct.
Fat is there. So,
But
or
one
just a drop of
disadvantage
blood
with
is
fat
itself is
is
good.
it might float a little bit.
Right.
So this is areolar tissue which we use.
Okay.
And we have to use what is called the non-touch technique because this has to be very sterile. It is going directly on the vestibule.
Yeah.
So make sure you don't touch this tissue anywhere.
Okay.
It's only the sterile instruments which you're going to use and transfer it from instrument to instrument.
Okay.
Without making sure it does, making sure that this does not come into contact with any other surrounding.
Yeah.
Correct.
So stapes surgery is very delicate and you have to take utmost precautions.
Yeah.
Cody? Here it may look quite small, but when you place it near the foot plate,
Yeah.
it looks
More than sufficient. Yeah.
really big. Yeah. Head turn ಮಾಡಿ ಸ್ವಲ್ಪ ಈ ಕಡೆ.
Vinay, you are doing it under general anesthesia?
Local anesthesia, sir.
Yeah, yeah. Okay, fine. Very good. Very good.
All the stapes surgery I do under local only.
Okay.
So with the soft tissue, you can manipulate the position of the piston also. It is a little anteriorly placed. So with this, if I place this anteriorly first, it moves a little bit more posteriorly. So
Yeah.
minor adjustments to the position of the piston can be made with this soft tissue. One more soft tissue. So now I'm pushing this piece anteriorly and the lower end of the piece is sitting posteriorly. So I push this between the piston and the facial canal and also use the other end to seal the fenestra posteriorly like this.
Yeah.
Now it has been sealed 360 degrees.
Yeah.
And in the end, I keep a small piece of gel foam just to absorb all this perilymph which has come out. And once that is absorbed, the fenestra gets nicely sealed. So I'll just keep this dry gel foam.
Yeah.
Alligator.
You won't use gel foam at all, huh? In the middle here.
No, sir. No, sir.
Okay.
We'll take it out. This was just to
Absorb the perilymph.
absorb the perilymph which was there.
Okay.
Yeah, it's perfect.
Now you can see it is completely sealed there.
Right.
Yeah.
So once the perilymph is absorbed, that pushes the soft tissue down, and now it's completely sealed.
Yeah.
Only thing is, I want to again push the chorda tympani in front of the piston.
Just inferior to the piston.
Yes, yes, sir. Curve pick.
If you put back the flap, it may.
Yes, sir. Yeah, it may come back into position because it's lifted up a little bit.
Yes. There is a small bone dust in the chorda.
Sir? That is some soft tissue here, sir.
Soft tissue or bone? Yeah.
Yeah, now I think it's sitting nicely in front of the piston inferiorly. And you can see the fenestra again very clearly.
Yes. Yeah.
And it is very nicely sealed.
Yes.
And it has come out nicely. Now I'll just reflect back the flaps.
Yes.
Alligator.
Yeah.
Vinay, excellent.
So thank you, sir. Thank you very much. Sir.
Just one point, I wanted to say, like many people nowadays, they do reverse stepedotomy. So have you ever tried in which cases? What are your indications for that?
Reverse stepedotomy I've tried while doing in cadaver, sir.
Yeah.
It is easier to learn because there is more stability of the foot plate. You can try placing the piston more number of times because in a cadaver you have to practice multiple times.
Right.
So in such cases, a reverse stepedotomy is a good option because the stability is more. You can try placing the piston multiple times.
Basically, it is said if you are doing reverse stepedotomy, that is a more safer procedure because.
Yes.
But you usually don't practice.
Alligator? No, sir, not in patients, sir. We do this routinely.
Yeah. So what are your indications of doing reverse stepedotomy? Any indication in clinical practice?
No, sir, not done anything so far.
Okay.
Do you have any comments, sir, about reverse stepedotomy?
Reverse stepedotomy, what I feel for the beginners, it is a good procedure because there is a more safety margin. Your foot plate is protected. You may not subluxate it. And then while putting the piston, because here in the reverse one, you do everything, then lastly you remove the superstructure. So that gives the stability to till the end of the segment.
For that, you require more space. Yeah.
Yes, sir.
Yes, sir.
Hello.
Yeah, Dr. Vijayendra, sir, your opinion.
This reverse stapedectomy, what will happen once if you make a wide fenestra, the stability of the foot plate will be lost. So when you try to subluxate, definitely in more than 50%, there'll be fracture of the foot plate or subluxation. So many things can happen. So actually, this is the best technique where no damage will happen to the foot plate. When you do 0.6 mm, or else what will happen when you try to do a reverse stapedectomy, when you're making a fenestra, sometimes the whole foot plate may become a big fracture, maybe there. So many things can happen. So at that time, when you're trying to subluxate or remove the suprastructure, the whole foot plate will come out. So in 50% you can succeed, but not in all the cases. So this is a very safe technique than that. I learned this technique from Professor Hugo Fish. From 96, I've been doing the same thing. So that reverse stapedectomy, you may succeed in thick foot plate. Sometimes what happens when you make a wide fenestra, the stability of the foot plate will be lost and it may subluxate or it may fracture or so many things can happen when you try to remove the suprastructure after putting the piston. So that is I don't like to do that.
That is exactly the point, sir. I wanted to make, and I have made in one of the panel discussions where there were many people agreed to that that reverse hysterectomy is the safest. There are hardly any chances of any untoward things. And these are the points which you said. I just wanted to reiterate from the expert's mouth. So I raised this question to Vinay.
Yeah, I don't like that procedure. It is not a safe procedure for a kind information. This is a very safe procedure.
This is the safe. You do everything under vision. You have got the whole space in the world.
Correct.
Here, in the reverse, what we do is we first make the fenestra, and then you are after putting the piston, we are trying to take out the suprastructure.
Correct. And when the put the piston in the vestibule and try to manipulate, the lower end of the piston will be in the vestibule. That will be damaging the vestibule also. That is also another disadvantage in this. Okay. This technique I learned from Professor Hugo Fish.
Yeah.
So the same thing I've been continuing from 1996. No regrets, no problem.
Here the
very happy.
Most valid point is, sir, everything should be under vision. There should not be anything you are doing behind something. Like in the reverse, you are doing it behind the piston and you are trying to dislocate the suprastructure. So it should be under vision. It should be a gentle one. You should not apply any force. That is my intention. Am I right, sir?
And now I've elevated the flaps, sir. It has come back to its original position. That is also very important. Try to reflect back the flaps to its original position. I kept a wet gel foam on the flaps while elevating the flaps so that the flaps stay moist till the end of the procedure. If it becomes dry, then you might not be able to elevate it back to its original position. Now it's reflected back, and you can see it is completely reflected back.
Yes.
Now we'll just check the hearing of the patient.
Yeah, Vinay, excellent demonstration, Vinay.
Thank you, sir.
The way you have demonstrated, I think you are going to give some free time to your dad, Dr. Vijayendra sir.
And Vinay, once you have done such a nice job, patient is under local, you can do a whispering sound testing. What is that?
Yes, sir.
Sir, we'll check the hearing of patient, sir, now.
Yeah. And that is one of the greatest advantage of patient.
వినపడుతుందా? బాగా వినపడుతుందా? ఎట్లా వినపడుతుంది?
బాగా వినపడుతుంది సార్. అవును సార్. నవీన్ కుమార్ సార్. 36 గాన్లపర్తి సార్. అవును సార్.
Speaking from a very long distance, everything is answering.
Yes, sir.
Can you see, sir?
Yeah. Sir, this is one surgery where you get the instant.
So such a long distance.
Yeah.
గాన్లపర్తి సార్. అన్నయ్య వచ్చాను, ఆయన వచ్చాను. అవును సార్. ఇద్దరు సార్.
Excellent, sir.
Yes, sir. Good results. Excellent results, sir.
Excellent. Good work, Vinay.
గిడ్డినెస్ ఏమైనా ఉందా? ఏమీ లేదు.
Good work, Vinay. I think giddiness is too early to expect, no?
Hello?
Sorry, sir, I didn't hear you.
Since there was no leak, it is hardly you expect a giddiness too early.
No, sometimes if the piston length is too big, then we may expect giddiness. So that is one of the advantages of doing the procedure under local anesthesia. So in case the piston length is long, then that might cause some amount of giddiness. So we always ask the patient before shifting the patient to the ward.
Great.
So that is one of the advantages.
Yeah.
Any other questions, sir?
I think if the audience don't have anything from the chat, let me check.
Just pull up.
Is there any question in the audience link?
Thank you.
I'm checking.
In the chat, there is no question.
Yeah, in this it is not there, but from the audience link, if there may be, please share with us. Or let us move to Dr. Vijendra's case. If there are any questions, we can
come back. Yes, right.
Sure, sir. Thank you very much, sir. Thank you to the moderators for the wonderful and interactive session. Yes, thank you again for the opportunity. Now we'll move over to the next surgery, sir, which is a case of cholesteatoma. Jelfo.
Dr. Vijayendra sir, we are with you. If Nilesh can or anybody can explain the clinical findings.
Sir, are you able to see my presentation, sir?
Yes, yes.
Yeah, we are seeing Dr.
Yeah, sir. So Vijayendra sir will be operating a case of extensive cholesteatoma with lateral semicircular canal fistula. So she is a 23 years old female. She has presented with right ear foul smelling discharge with hard of hearing with giddiness since 5 years. Giddiness, though it has started off late since last 3 months. So this is the endoscopic video. You can see there is a granular meningitis completely covering the pars tensa. There is a pulsatile discharge near eustachian tube orifice. Maybe there is a perforation. An entire attic is gone here. It is totally destructed because of the extensive cholesteatoma here.
Yeah.
You can see the attic is completely destroyed with the cholesteatoma, and you are not able to see any ossicles here. No malleus head, no incus body. So this is the dual pathology, sir, where the pars tensa is also involved with the granular meningitis retraction with perforation over the eustachian tube orifice, and entire attic is gone. So pure tone audiometry is showing 75 decibel hearing level in the right ear, while the left ear is normal. So we'll see CT scan of this patient, sir.
Yeah.
Yeah. So we are interested in the right ear, sir. So this is the right temporal bone. So we'll see the scan throughout to check the sinus and the tegment, because we are planning here canal wall down procedure. So here the sinus is coming in the picture.
Yeah.
You can see it is the anterior placed sinus. It has made thumb-like impression in the mastoid air cell system, which is the sclerotic. Here you can make out this thumb-like impression in the mastoid, which is sclerotic. And in the upper part also it is anteriorly placed. Then the supralabyrinthine area is occupied the soft tissue density. The superior semicircular canal is normal. This is the ampullary end of the superior semicircular canal. This is non-ampullary end. And this is the non-ampullary end of the posterior semicircular canal. This is the ampullary end of the posterior semicircular canal. Then the lateral semicircular canal, if you see, sir, there is a fistula over the dome of the lateral semicircular canal. The rest of the dome is thinned out, and there is a fistula at 2 places with bone in between intact.
Yeah.
So here you can see this is the bone. There is a fistula anterior to this bone. There is a fistula posterior to this bone. And when we go down, there is thinning out the lateral semicircular canal dome. So there are 2 fistulas with some intact bone in between. Then when we come down, you can nicely see the facial nerve. This is the internal auditory meatus labyrinthine segment, first genu, and this is the horizontal segment of the facial nerve.
Yeah.
Then coming to the ossicles, as we already seen endoscopically also, there was absent head of and body of incus. So you can see in the epitympanum, nothing is there. It's completely absent here. And when we come down, you can see the handle of Malleus is there, and incus lenticular process is mildly necrosed, which is in connection with the head of the stapes, and stapes crura are intact, sir. Both the crura are intact, anterior crus and posterior crus, and you can see the head of stapes also, and entire sinus tympani, the lateral sinus, everything is occupied with the soft tissue density. So we'll see the tegmen plate now. As we saw already, the sinus is anteriorly placed here, though it is intact. We'll see in the coronal cut what is the status of tegmen. So here you can see again the fistula is coming into the picture. As I said, there is a one bone is sitting over this fistula. Anteriorly and posteriorly there is fistula. The tegmen is severely thinned out. There are some focal areas of dehiscences. It has become papery thin. Laterally there is dehiscence. Medially there is dehiscence. Multiple places there are dehiscence in the tegmen, and rest of the tegmen has become papery thin. In the anterior part it looks thick, but as we are going in the mid part and the posterior part, you can see it is severely thinned out with areas of focal dehiscences. So entirely till posterior part also it is multiple dehiscences are there. Then here you can nicely see the vertical segment of the facial nerve. This is again lateral semicircular canal. If you trace it again anteriorly, you can see the fistula in the lateral semicircular canal. This is the fistula in the lateral semicircular canal. And then I was telling all this as a soft tissue density because CT scan is not diagnostic of cholesteatoma, but here endoscopically already we are knowing that it is cholesteatoma. So what we do routinely nowadays the diffusion weighted imaging to see the bright focus like this. Here you can see this is showing the diffusion restriction. Endoscopically already we know that it is cholesteatoma, but even radiologically also if you do non-echoplanar DWI imaging, you can see the bright focus giving the diagnosis of cholesteatoma. And it was quite obvious on endoscopy also that it is cholesteatoma, but the routine protocol, we always do HRCT temporal bone with one T2 cut and non-echoplanar DWI imaging. So the diagnosis is, it is actually right dual pathology where there is a right grade 5 pars tensor retraction, though after clearing endoscopically we'll be able to see more clear. It looks a retracted tympanic membrane with the granulations, and there is a perforation on the eustachian tube orifice. So it will fall under category of right grade 5 pars tensor retraction. And there is an extensive atic cholesteatoma with lateral semicircular canal fistula with dehiscent tegmen and with severe mixed hearing loss. So our plan is right canal wall down mastoidectomy and tympanoplasty with ossiculoplasty and meatoplasty. Here counseling is very important. We saw that cholesteatoma has eroded the labyrinth at two places, lateral semicircular canal. And if in this case, that bone also we saw, it is separating these two fistulas. If this cholesteatoma is eroding the lateral semicircular canal, we may have to do the labyrinthectomy to clear the disease. In this case, what will happen? Patient may lose her hearing and will have giddiness for a few weeks. So key factors in the CT scan where there is a tegment defect, multiple lateral semicircular canal fistula. And as I told, counseling, you have to write in your own handwriting, as the professor has already written here, that if cholesteatoma is eroding the labyrinth, then labyrinthectomy it is indicated. And in this situation, patient will lose her hearing and will have giddiness for a few weeks. This is explained very clearly to the patient and her attenders also. So this will be the live transmission from Vijay ENT Care Center, Bangalore. I will hand over my mic to Professor Chandra.
Just one thing.
Yes, sir.
Since there was tegment was thin out, was there any features of meningism?
No, sir. No signs of symptoms of meningitis, sir.
Okay, great.
So currently, Sangeeta madam is doing some steps. So I'll give her mic to her. She will explain what all she has done till now.
Yes.
To save time, we have already started that case also when Vinay was doing this type of case.
Right.
Very good evening, Mr. Chairperson.
On.
At the outset, I would like to thank Molecular Peroxidation and the Mutera of started case. We can see, like Neeraj has already explained in detail.
There's a wide atic defect here.
with cholesteatoma here in the anterior attic. And here, actually, it's a subtotal perforation.
அதான் வாய்ஸ் போயிடுச்சு. ப்ளூடூத் போட்டேன், அதுலயும் வரல. அதுல ரெடி எதுல கனெக்ட் ஆயிடுமா? வரல.
Hello.
Yeah.
Yes, ma'am.
Hello, sir.
Yeah,
So as you can see, it is a subtotal perforation here, which is covered with granulation. As you can see here, this is a eustachian tube orifice. The subtotal perforation here covered with extensive granulation over the promontory. And it's a dual pathology, as Nilesh has already mentioned, and there's a huge attic defect here, where the head of the malleus body of incus not seen with cholesteatoma. Just to save time, I've harvested the graft. I harvested the soft tissue. When you are planning for a canal wall down procedure, we take the incision very close to the conchal cartilage, so that more soft tissue is retained post-auricularly, so that you can obliterate this cavity. So here I have harvested the post-oral soft tissue, and here I have released the post-oral soft tissue, which we generally do at the starting of the procedure, because if you do the same procedure at the end, by then the adrenaline effect is gone. So usually we do this procedure at the beginning of the procedure. I will show you that. Here, this is a soft tissue which I have harvested from the post-oral soft tissue released already, and this will go fall into the cavity, just reducing the size of the cavity. I have done all these steps just to save time. And here actually, because this flap was getting pulled, it was getting pulled like this. So to release that, I have taken the superior incision here. Should I start drilling? Xylophone cotton ball. I'm just placing xylocaine cotton ball there in the middle ear cavity. Cotton ball. As we've already planned for a canal wall down procedure and the incus body is also absent, I'll straight away go for a canal wall down. Better. You should always keep in mind, because the sinus was anteriorly placed, so you should always watch out for the blue lining of the sinus, because it was anterior placed. Usually you encounter a low lying segment along with that, though in this case it wasn't there, but still you watch out for it. Always have a wide opening of the mastoid, so it gives better space to work around the middle ear. And in the same time, you saucerize the cavity also. Wash. So as you can see, there's a pink line here. suggesting it is a low-lying dura. You can see the pink line here.
Yeah.
As you can see, the pink line is extending down, almost abutting the posterior bony meatal wall. You come a bit lower so that you can enter the antrum. For the benefit of the juniors, it is always better to open the antrum, visualize the dome of the lateral semicircular canal, and then do a canal wall down procedure so you'll know how much of the ridge that you need to lower, rather than blindly lowering the ridge. As you can see, there are a little bit of air cells that are seen. The principles of the canal wall down is always a wide saucerization of the cavity, adequate removal of the bridge, adequate lowering of the ridge, that is up to the level of the dome of the lateral semicircular canal, removal of the anterior buttress and the posterior buttress, wide saucerization as I initially mentioned, and a good obliteration of the cavity. Some of our cavities and an opening of the sinodural angle always. As you can see, the soft tissue that you are seeing here. You can see the colostoma there. This is the colostoma there. So I'll elevate the flaps and then go down. Wash. Wash, wash. Alligator forceps. How was the picture quality there, sir?
Good.
Oh, thank you, sir. Sir? Yes, sir. Subtotal perforation. 45-degree pick. Wash, wash. This is the subtotal perforation margins which you can see here. 45-degree pick. Alligator forceps. As you can see, this is a perforation here. Where is scissors? Number blade. So now I'm going to elevate the vascular flaps. These are, you need to take utmost care when you're elevating these flaps, as the healing of your post-op cavity depends mainly on these flaps. Cotton ball. This is the inferior incision for the inferior vascular flap, that is from the 5 o'clock to the 6 o'clock. And the superior incision, initially when I put the retractor, this was getting pulled here. So I've already taken the superior incision for the superior vascular flap. That is from the 2 o'clock to the, sorry. That is from the 2 o'clock to the 12 o'clock. Number blade. Before removing the bridge and lowering the ridge, you need to elevate these vascular flaps. Double end knife. Cotton ball. And here, as you can see, because of the huge attic defect, it is giving way, and protect these vascular flaps with a cotton ball. Pick a cotton ball. As you can see, the huge attic defect, as you can see here. The huge attic defect with the cholestotoma here, wherein the head of the malleus and the body of incus are absent. I'm showing the pathology once again. This is the subtotal perforation, wherein I freshened the margins. And this is the grade 5 attic defect, wherein the scutum is completely eroded with extensive cholestotoma, as you can see here. Cotton ball. Sir. As you can see here, when I'm touching here, the movement is seen here.
Most of the posterior meatal skin on the posterior side is already eroded.
Pardon, sir?
Most of the postoral skin, this is the posterior meatal wall on
Yes,
the
sir.
superior and the posterior side is already eroded.
Scrotum, yeah.
Yeah,
Yes, sir. Yes, sir. Here it is. It's already eroded, sir. This part is already eroded.
Yes.
Scutum is not there at all, sir. Here
Right.
it
That
is going inside. Whatever remnant flap, I'm trying to push it with a cotton ball.
right. And that's also very small area.
Yes, sir. Yes, sir. Very, very small. And this part down, I don't want to elevate because the fistula is there. There's a double fistula, like Nilesh has mentioned. So I don't want to push it too deeply there.
Yeah.
Cotton ball.
Doctor, have you tried Merocil instead of cotton ball to avoid cotton ball fibers in these cases?
No, sir.
Small pieces of Merocil.
No, sir. We are very comfortable with this cotton ball dissection. Innೊಂದು cotton ball ಕೊಡು. Cotton ball.
Now I think probably posterior meatal wall is to be, this bridge is to be brought down, no?
Yes, sir, yes, sir. Hardly there's anything left there.
So there is already communicating. Yeah.
Usually, if at all the ossicular chain is intact, you have to first visualize the ossicular chain, disarticulate the IS joint and remove the incus and then remove the bridge. But here, because the ossicular chain is not intact, the body of incus is not there, we can confidently go and remove the bridge here.
Yeah. Okay.
Cotton ball.
The cholesteatoma has done the job of your dissection or drilling.
Double in night cotton ball. Now I'm further reducing the bridge.
Yeah.
So that to widen the cavity here. Wash this stuff.
From the beginning, you are using the same size barbit, not changed.
Pardon, sir?
From the beginning, you are using a single same size barbit.
Sir, I'm sorry, I didn't get you, sir.
No, from the beginning, you are using only one size barbit. You haven't changed at all.
Sir, no, I did change. The beginning one was a 3 mm cutting burr.
Okay.
So that I can drill a little faster.
Okay.
Actually, right now there are no important areas are involved, so she can go a bit faster, you know.
Yes,
and you
sir,
can
yes,
use
sir.
the wider burr.
Now I'm reducing the ridge. Simultaneously, I'm saucerizing the cavity.
Yeah.
Yes.
It should always be a shallow cavity. It should not be made deep. And so
Pardon, sir?
the cavity should always be shallow from all the sides.
Yes, sir. Because of the fistula, I'm not able to debulk this.
Right.
Because if it is adherent and though Nilesh has mentioned, the endosteum is intact. I'm opening the sinodural angle. Here, as you can already see, there is a blue line of the tegment here.
Yeah.
Here with the tympanic note itself, see there's a sound that is different here. some different here. This is, we are very close to the tegmen here. As you can see, there is blue lining of the tegmen already here, sir. Are you able to appreciate that, sir?
Yes, yes.
There's a blue lining of the tegment here. As Nilesh already mentioned, there's dehiscence at multiple places. Cotton ball, double N9. As you can see here, so it's already dehiscent there. Though there is this blue line rather, it's not loaded. There's blue lining here. There's blue lining here. Scissors. Now I'll debulk this part so that we can retain the skin around the dome of the fistula. So that this skin also can be retained, and later towards the end of the procedure you can thin it out. Double knife cotton ball. I'm just protecting the flaps because they are very important for post-operative healing of the cavity. Cotton ball. Sir. Now I'm entering the middle ear. And this is the annulus I can clearly see.
Yeah.
I'm elevating the annulus. Then as per the CT also, there's no high jugular bulb.
Yes. You can safely take out everything because we are far away from the jugular bulb and no ossicles are there.
Yes, sir. Yes, sir.
So
4% xylocaine, cotton ball, adrenaline, cotton ball. Focus in xylocaine, cotton ball. I'm just protecting the flaps. I'm further reducing the ridge. And lowering the bridge others simultaneously.
have to do bother about the fallopian canal because facial nerve is intact, so we have to take care of that.
Yes, sir. Yes, sir.
In such an
So
extensive
because of the fistula, I didn't want to. Pardon, sir?
In such an extensive cholesteatoma where no superstructures are there, it is the only thing we have to protect is the facial nerve.
Yes, sir. Yes, sir. Now I'm removing the posterior buttress. Pardon, sir? Now I'm removing the posterior buttress. The posterior buttress, the floor of the middle ear and the mastoid tip has to be in one straight line.
Right.
Till then, in fact, sometimes you can reduce it much below the level of the dome of the lateral semicircular canal.
Right.
You can boldly remove it because the facial nerve goes lateral to the annulus. So you
Yes.
needn't worry about the facial nerve. And most of the cases that we do now are revision cases, and everybody is very scared about the facial nerve.
True.
But the facial nerve does not come medial to the annulus, it is much lateral to the annulus, and you can safely reduce the posterior buttress.
Yes.
And this part you open it like a book.
Yeah.
Like once Professor Vijayendra exposes the semicircular canal, then we will know the level of the semicircular canal. But because this posterior buttress can be removed until you see the cauda, origin of the cauda. Till then, safely you can go ahead and remove the posterior buttress. Posterior buttress is that part of the posterior bony meatal wall that meets the tegmen. And this has to be removed so that the floor of the external auditory canal and that of the mastoid tip is in one straight line. And simultaneously, you reduce the ridge also. But here, because of the fistula, I'm not able to visualize the dome, though partially I'm able to see it. Actually, once you visualize the dome of the semicircular canal, it's much easier to reduce the ridge. And simultaneously, you drill this ridge so that you get to visualize the sinus tympani better. Now, because as Nilesh mentioned, the lenticular process is adherent to the head of the stapes. To safely visualize that and remove, I'm reducing the posterior bony meatal wall here so that you get a better access to the sinus tympani. Sir, as you can see the cauda, sir.
Yes, yes.
Here there's a cauda.
Yeah.
Till that you can reduce the posterior buttress. In fact, you can reduce it even more once you visualize the dome of the lateral semicircular canal. So there's no need to fear of any facial nerve coming in this area at all. Alligator. What? So I'll hand over the mic to Dr. Professor Vijayendra. Sir will take you through the rest of the surgery, sir.
Yeah, sure.
Thank you, sir.
Good evening, respected chairpersons, my dear colleagues, friends who are watching this surgery. Sangeeta has done a wonderful job as of now. So I'll continue because the fistula is there, and I'll show you how one can manage the fistula here, and also the rest of the cavity, how to maintain. I'll just take you through this. And the skin, try to retain as much as possible. And now have a look at the anatomy. So give me smooth cut pick. Probably this is the processus cochleariformis and head lateral process. Malleus is the handle of the malleus. And this will be the facial canal. And this is the dome of the lateral semicircular canal. And let me see. Some bony projection is there. Probably the fistula will be somewhere here. Probably. Still, I'm not saying. Most of the time, through the matrix, you can see the fistula. Give me iris scissors. Iris scissors. There's some granulation polyp is there, which was seen through the endoscope. Exercise that. Now what you have to do is double inline. You create a matrix around the suspected area of the cholesterol, the fistula. So for that, what I do, see what if matrix is there attached to this cholestoma matrix. You create an island of matrix around the lateral semicircular canal. Can you see that? How I am creating a matrix island of matrix? Hello?
Hello, we are hearing you, sir.
Can
You are
appreciate,
meticulously-
I am creating the an island of matrix around the suspected area of the
Semicircular fistula.
which you should remove at the end of the procedure.
Yes,
Don't
sir. Yes,
try
sir.
to remove it. That is the idea. Okay.
Yeah.
Suppose if you remove it and if you keep exposing the membranous labyrinth, and if the membranous labyrinth is intact, even while irrigation also you can damage the membranous labyrinth. Okay. That
Okay.
is the idea why one should always retain the matrix till the end of the procedure. Okay.
Yes,
So
sir.
that's
Yes,
what I had done. I created an island of matrix around the suspected area of the fistula. Okay.
fistula. Yes, sir. Yes.
Yeah. So this is one of the way how to manage the fistula. Cotton ball. So this is a tegment plate. See, I cleared the tegment plate, the cotton ball dissection. Can you see that? It's very clear, huh? See, this cotton ball dissection is very, very nice. See, very nicely you can sweep that, and there's no any squamous epithelium here, okay?
Yes, sir.
Fine. Now I'll go superiorly. Double lining, cotton ball. This is a superior flap. Can you see that? Now this is the anti-attic space. Now join this superior flap. That is the anterior buttress. See, now can you see that? Now
sir.
I'm
Yes, sir.
elevating the annulus anteriorly. So now I'll go towards the ischiation tube orifice. And this is the anterior attic space. See, this area is the anterior attic space. And this is the cog. See, this bone is called the cog. See, this cog separates the anti-attic space from the attic. See here, that is the cog. So I have to remove the cog. Usually cog will be very thin. See, now I fractured the cog. Can you see that? Once if you fracture the cog, the attic will become a single room, anti-attic and post-attic. See now the anti-attic cotton ball. And now I'll march towards the ischiation tube orifice. There you get the ischiation tube orifice. There's the annulus there. There's a canal for tensor tympani. And that is the ischiation tube orifice area. Now, let me start elevating this flap. Always the skin, try to retain it till the end. Give me this. This is a little thick here. Iris is a kodi. Double NF cotton ball. Cotton ball. Badodu kote, chikkad kodu. Iris scissors. Here in this area, anywhere maybe the fistula may be there. So that's why I'm very careful here. Until you identify good anatomical landmark, always be suspicious. You see some glue is there. Can you see the glue there? That is probably from the whole window area. See now, see how gently I'm elevating.
because I expect a patient over there. Curate. Probably the patient may be decent. Still, I am not sure. This is always safe. Curating. Cotton ball. Still, I don't have a good any landmark. Alligator forceps. So better go for a little higher magnification. Pardon? Double N9. Millimeter by millimeter, I'm elevating. This is the process cochlear reference. Now I got a landmark, okay?
Yes,
Hello?
sir. Yes, sir. Yes, sir. We are watching you, sir.
Yeah, so I am actually till this I was searching for a good anatomical landmark.
So now you
I
are seeing
didn't find-
processes cochleariformis. Yeah.
And this is the facial canal.
Yes.
Just I am keeping little cotton there with adrenaline.
Yes,
Just
sir.
I want a clear picture when elevating the matrix over the facial canal.
Okay. Okay.
When bleeding is there, you wait always. Huh?
Yes, sir. Yes.
Whenever in the critical areas, don't blindly try to do. And this patient, she has come all the way from Bihar.
Okay. Okay.
Yeah. See, that is the process of cochleariformis.
Yes, sir.
Can you
Yes.
see that?
We are seeing it
That is the
clear.
process. Now that is the facial canal. Now I can march towards the stapes. But Nilesh has told the stapes is there.
Yes.
Now it is very easy for me to identify the stapes there. But very easy pick.
But very long history of giddiness, sir. Almost 5 years.
Yeah. Non-cottonal kudi. There are two things which you can identify the stapes. One is go to the processes, this pyramidalis process.
Yes, sir.
See, this is a sinus tympani. Not a polypid mucosa is there. There is a pyramidalis process. Can you see that pyramidalis process there? Hello?
Yes, sir. Yes, sir. With the sepidus tendon. Yeah.
There is a good landmark.
Yes.
So start dissecting in this direction.
Yes.
You'll get the stapes.
Yes.
See the separated tendon. Can you see that?
Yes, sir. Yes, sir. So posterior to anterior dissection you are doing.
See, now it is, I'm going towards the stapes. Now I'm palpating the stapes is there.
Okay, yes.
See, can you see that? How I
Yes, sir,
dissected?
yes, sir.
See,
Yeah,
beautifully you can see the
yeah.
stapes. Huh?
Yes, sir, yes, sir.
So it was totally, completely embedded in this.
Yes.
But still, this is the best way to get the
yes.
stapes. Now what I do, particularly small coding, you can see the lenticular process. So separate the lenticular process
from the head of the stapes.
Like a cap, it will come out.
So why do you want to remove it, sir?
Because squamous epithelium is there over that.
Okay.
So if you remove that, see that squamous epithelium automatically will come. Huh?
Okay.
You cannot dissect the squamous epithelium
from
over
the
the lenticular. This is the best way. Huh?
Okay.
And also when you want to do ossicular reconstruction,
yes,
I want the head of the stapes to be crystal clear like this.
Okay. Okay.
Is this point clear?
Yes, sir. Yes, sir.
Always see now how I like a cap, I removed it.
Yes, sir. Yes, sir.
This is squamous epithelium is there. Huh?
Yeah, yeah. Yes, sir.
So to dissect that is this is the best way. Remove the cap, automatically the squamous epithelium will come out with the
in the lenticular process, remaining lenticular process.
Is it clear?
Yes, sir.
Give me cotton ball small. Double NA. Now always you should suspect the fascian or descent medially.
Yeah.
So you should be very, very careful. This facial canal is there.
Yes.
Now I am going towards the foot plate area. Here I anticipate fascian or descent there. That's the facial canal. Can you see that?
Yeah. Horizontal part is seen cleanly.
Yeah. Now so far bone is there. Huh?
Yes, sir.
But still down if you go, there may be
some descents.
Most of the time it will be there. Okay. Yeah. Always when you're doing that, you should anticipate the descent fascian is there and do it. Okay.
Yes, sir. Yes, sir.
But if is long. See how I'm getting the cleavage between the foot plate and the
facial nerve.
Facial nerve.
Yeah.
This is a posterior sinus tympani.
Yes, sir. Yes.
Just below the stapedial tendon, there is a lot of polypoid mucosa is there.
Yes.
Adrenaline pack. So, like keep little adrenaline there. And then when I'm bleeding, you don't do that.
Okay.
Because you're working near the stapes.
Yes,
you
sir.
should
Yes.
have a crystal clear picture.
Yes.
Okay.
Yes. Yeah.
So when blood is there, you'll not know what is happening underneath that. Huh?
Yes, sir.
Wait. Only thing, wait. Or else what you can do now, I got a lot of work to do.
Yes,
in
sir.
alligator forces. I can reduce now I know the dome, the lattice instruction or where it is.
Yes.
There is you can reduce the ridge now.
Yeah.
Clean ಮಾಡಿ double ಎಣ್ಣೆ ಕೊಡಿ. Now protect the flaps. Most important, this is like a gold, 24 karat gold. These flaps, okay?
Yes, sir. Yes.
Now I'll reduce the
Ridge.
ridge.
Yeah.
Have any doubts, please feel free to ask. Irrigation. This is a posterior buttress. Huh? Can you see the Carda shadow? That white thing is a Carda. Huh? Hello? Can you appreciate that Carda?
Yes, sir.
Hello?
Yes, sir.
Yeah, yes, sir. We are seeing, sir. Yeah.
Then now that is the dome of the lattice hemisphere canal. That is the dome of the lattice hemisphere canal. Up to that I reduce it. Now probably that this is a shadow of the patient now. That blood vessels have come now. Okay. So that is the limit of the reducing the ridge.
Ridge.
Okay.
Yeah. Okay. Yes.
Now one round of polishing of the cavity, I'll do it.
Okay.
When you go to the aerial view, you'll know the shape of the cavity. Okay. Now, always my cavity should be smooth and uniform. So for that, I keep polishing. Okay. Several times I do polishing. ಚೆನ್ನಾಗಿ ವರ್ಕ್ ಮಾಡ್ತೀನಿ ಇದನ್ನ ಹಿಡಿದೆಯಾ ನೋಡಿ. As Sangeeta told, the first principle is saucerization of the cavity. Okay. The edges should be everted like this. Okay. Hello.
Yes, sir.
This is called saucerization.
Right.
Yeah. Yes, sir.
So dictum in canal wall dome procedure is the more the amount of bone you remove, less will be your size of the cavity. How means, see, now I am drilling this much of bone and everting the edges.
Yes, sir.
This
Yes,
is
sir.
called saucerization.
Saucerization.
If I do such good saucerization, my soft tissue will easily slide here. Suppose we don't do saucerization, if you have a overhanging bone, it cannot jump like this. So that is the reason. So I have to nicely widen the cavity edges like this. Huh? Is it clear? This is called saucerization. So the more the amount of bone you remove, less will be the size of the cavity. Why means the soft tissue collapse will be excellent. Look at this, how I am polishing the cavity. Huh?
Doctor.
So now I remove the posterior buttress in such a way the floor of the external canal match that should be single line. There is no match side ridge at all. See, friends, we see so many cases of revision cases. Now, in my practice, at least 60% of the cholestoma cases, what we do is revision cases.
Okay.
In this 60% of revision cases, 95% the main cause will be the high facial ridge. 90%, okay? Because you are scared about the facial now. So friends, So you should do a good dissection and you should know the level of the patient now and you should reduce the ridge. So people speak so much about the cavity problem, cavity problem, cavity problem. Why you get cavity problem is if you don't reduce the ridge, you get cavity problem. See now if I reduce the ridge like this, the mastoid bowel and the ridge everything in a single line. There is no room for accumulation here. If you have
Yes,
a
sir.
high facial ridge like this, there'll be a deep pocket here.
Yes,
That
sir.
will cause accumulation and cavity problem. So the main important thing is you have to reduce the ridge up to the dome, the lateral semicircular, or even up to the level where you can see the shadow of the fascia now. And if you remove the posterior buttress, the floor of the extracanal mastoid tip should be in a single line like this.
Yes.
Then there is no cavity problem. So this is one of the most important points not to have cavity problem. People speak for months together, years together about cavity problem. In our cases, we don't see any cavity problem at all. And most important thing is, if you see my cavity post-operatively, it is hard to believe that we have done a canal wall down process. That perfection we have achieved with over a period of time. Okay. At the end, you will know again that I'll show. So the most important why I am emphasizing is one has to reduce the ridge nicely up to the level of the dome of the lateral terminal. And if you remove the posterior buttress nicely, there should not be any projection between the mastoid cavity and the ridge. And also you should open up the synovial angle nicely like this, okay?
Yes, sir.
Now that's over. Now let me go to the stapes area. By this time, whatever the bleeding was there, it will be controlled.
Yeah.
So like that, you should plan your surgery. Don't keep on wasting time there only. I kept
Yes,
the adrenaline cart and ball. So definitely by this time, the bleeding would have been controlled. Madam. Not very big. Long. There's a lot of polypid mucosa, which is completely embedding the stapes. Huh? Can you see that? Small cotton ball. Very thick polypid mucosa completely covering the stapes. There is a posterior crus. Can you see the posterior crus here? Now there is an intercrural space also. A lot of polypoid mucosa is there.
पैड नहीं मिला। अभी करवाते बाकी सब मैंने क्या हुआ पैड सर नहीं मालूम। पाँच
Can you see the footplate there? Hello?
Yes, sir.
Hello?
No, sir.
Sir, we are listening, sir.
We are listening.
Yes. Yes, sir.
See, that is a fistula antifenestrae. From that side I come. Now I dissect the polypoid mucosa from the anteacrusly. Beautifully it came out. Huh? Now this is a posterior sinus tympani. You also this. Can you see that? I am removing that from the posterior sinus tympani. Now I'll remove this polyp from between the between the promontory and the.
பரவாயில்ல இந்த மருந்து நம்ம எப்படி இருந்தாலும் இது கொடுக்கறோம்ல.
This is the sinus tympani. So I cleared the polypoid mucosa from the sinus tympanic area. Look at this, how I removed this all polyp which are embedding the whole stapes.
This mass was encircling the whole of the stapes and the stapedial tendon, isn't it, sir?
Yeah, you are seeing, no?
Yeah. So, say half an hour before where we were and now what we are, there is a lot of difference.
Yes, another half an hour makes more, some more difference. Just joking. Okay. Just
Yeah, I can make out, sir. Yeah.
See, now the stapes, you can see there is a fistula antifenestrae.
Yeah.
This See, the footplate is so clearly seen now. See, the stapes is quite freely moving. Huh?
Yes, sir.
So, if you want to do reconstruction, you have to scrutinize the stapes like this, and make it freely mobile. Then only your hearing results will be good. Huh?
Yes, sir.
Small gel form. Small gel form.
इधर में दे सकते
And now that direction also came out. Now it is very clear. See, this is enough, huh? Because step is little. Now I can do a good reconstruction. Okay, look at the step is. Look at the round window reflex.
Yeah.
Now this clearance of the disease around the step is over. Okay.
Yes, sir.
Yeah.
Can you see the round window reflex?
Reflex. Yeah, reflex is seen nicely, sir. Yeah.
Clearly seen, huh?
Yeah.
Okay. So this one big hurdle is over. Another hurdle is there around the semicircular canal. Now I will just do anti-buttress removal, alligator force, and create the flaps. I want to know how my flaps will come double ending. See, try to retain the skin as much as possible. It will be very useful for lining the cavity.
Yes, sir.
Iris scissors. Now I got an idea. Iris scissors. Tip clean maru. Double knife kodi. Here, if you see the mid-layer mucosa, it is totally hypertrophied and polypoidal mucosa. Okay? Can you see
Yes,
that?
sir. Yeah, yeah.
Double ending. And also there is a perforation was there anteriorly. So this whole thing is a completely, I have to exercise this. There's a
Yeah.
margin of the perforation, you can see that. Can you see that?
Yes.
Hello, where Sangeeta
Yes,
has
sir.
she has trimmed the rim of the margin of the perforation here.
Hmm.
So now this whole mid-layer mucosa is totally hypertrophied and polypoidal, which you have to exercise it, okay?
Yeah.
Is it clear?
Yes, yes.
Give me 45 degrees thick. Iris is a kodi. Usually we split the flaps into superior and inferior.
Hmm.
So I split the flap here. So this will be superior flap. Malleus scissors. Probably malleus handle is there in that.
Yeah.
Yeah, there is a malleus handle is there.
Will that handle help in reconstruction? Because
But it is necros. No, it is totally necros.
and then there with lot of hypertrophied mucosa, probably if we try to bridge, it is better to have the stapes and we can give the stud cartilage as you used to give and put a fresh graft.
See, this is a necros handle of the malleus. Can you see that?
Yeah.
So this is the superior flap now, okay? Similarly, I'll elevate the inferior flap, double NI. Iris scissors. All these granulation polyp you have to
remove.
Excise it, huh?
Yeah.
Double NI. Pattern ball. So there is the annulus. Now what I'm going to do, I have to elevate the annulus 360 degrees so that when I place my graft, anteriorly it should go and sit over the bone. Okay?
Yeah.
That is the idea.
Sir, just one question.
Yeah.
Dr. Mahadevaya sir has taught once when I was attending his courses that in such an extensive granuloma, do a good canal wall down surgery with a myetoplasty and let it be a wide canal and you line it with the temporalis fossa in continuity. So that does not hamper the hearing and it's a very good result. I had done very cases like that and it was good result. But nowadays, everybody talking about the cavity obliteration, cartilage and all that. So can you clarify the situation, sir?
See, now I am trimming this
yeah.
polypid mucosa. Can you see how I retained a thin layer of middle mucosa and then shaved it off? I never removed the middle mucosa. I shaved the polypid mucosa, saving the middle mucosa. Okay?
Yeah.
In this case, I'll keep a piece of gel film to prevent adhesions. Now you can see how the middle mucosa has been nicely trimmed. Is it clear?
Yeah.
Fine. Now I'll elevate the annulus anteriorly. The reason is at the end of my procedure, the graft should go and sit over the bone anteriorly. Okay? Round neck, the double end, So now what I'm going to do, I'm elevating the
anterior flap.
Annulus anteriorly to expose the anterior canal wall bone.
Right.
So that my graft will come and sit over the bone and these flaps will be reflected back over the to its original position. So underneath that, my graft will be secured over the bone. See how much I am elevating? Can you see that?
Yes.
Huh? So
Yes, sir.
bone is here. My
Centralize a bit, sir. Yeah.
yeah.
No, again gone up. Again gone up. Little down.
Okay.
Yeah. Yes. Yes, it's fine.
Now you see how I am elevating the annulus, antecanal wall skin. The reason is my graft will come and sit over the bone, and then I reflect back this into its original position.
Right.
So my graft will get nicely secured anteriorly over the bone, and it will get its vascularity. Is it clear?
Yeah.
So that is the insertion the orifice.
Yes.
Quite wide here. Okay. Fine. Now the flap business, mid-layer work is over.
Yeah.
Now next thing is I have to do anterior buttress removal and some more posterior buttress removal. Iris scissor. Cotton ball. See how nicely I retained the mid-layer mucosa there. Huh?
Yeah.
In spite of very bad polypid mucosa was there, I gently trimmed and I retained the mucosa of the mid-layer. That is very, very important.
Yes.
To prevent any post-operative additions. Huh? Now I'll show how to remove the anterior buttress. Anterior buttress is nothing but a bony projection where the anterior canal, the postbony wall will meet the tegment plate. When you remove the anterior buttress, the tegment antera and tegment tympani should be in a single line. That is the motto.
Right.
Small letter diamond. Diamond. Okay. Now I will create a platform of bone over there. So my graft will come and sit over that bone. So the two purpose it is. One is I am going to remove the anterior buttress. Look at this, how I am going to remove the anterior buttress. So once you remove the anterior buttress, the tegment antera and tegment tympani should be in a single line.
Right.
This is another principle of canal wall down procedure is you have to remove the anterior buttress. Posterior buttress we have shown, ridge we have shown, bridge we have shown. Now lastly I am going to show the anterior buttress. See, once if we remove the anterior buttress, this tegment antera and tegment tympani should be in a single line. There should not be any projection in between these two. Now I create a platform of bone here to place my graft over that bone. If I place my graft over that bone, so it will sit over this and the mid-layer space will be increased.
Yes.
How I am creating this? That is at the floor of the anterior buttress. I create a platform of bone and also I can create a small sulcus over there so that I can place the graft and tuck the graft into the sulcus. Now I am drilling the anterior attic space.
Yeah.
And also remove this bone and make the anterior space very widely open. That is the incision tip orifice. And this is the canal for tensor tympani. Can you see that bone, white bone?
Yeah.
Hello? This is the canal for tensor tympani.
Yes.
And now there is some granulation tissue in the anterior space that I will drill it. Sometimes you miss cholesterol in the anterior space. Always when you do
the video is gone. Yeah.
Always when you do canal wall down procedure, you have to remove the cog and see to that the anterior space is completely clear of the disease. See now how I drilled it now. Now you can see beautifully the just inferior to the anterior space is the canal for tensor tympani. Double and nine.
Yes.
See, that is the canal for tensor tympani. This is the processus cochlear forms. Here you will get the geniculate ganglion. And see now how I am removing this polypid mucus from the floor of the anterior space.
Yes.
So this is how anti-atic space should be always cleared. Sometimes you leave a cholestoma here if you don't address this. Huh? See now very nicely I cleared it.
Yeah.
Now this is very clear. This is a process called clariformis that is clear. Now almost this is clear in a small vertically.
Right.
Now even I can create a small sulcus to touch the graft. Like a groove I am making here. Can you see that?
Yeah.
At the end, I can tuck my graft over this groove and my graft will sit over this bone. So why I created this platform of bone is to give a good mid-layer space. The graft will be placed over this and it will not collapse into the mid-layer. That is the idea of creating this anterior platform of bone. Is it clear?
Yes. Yes, sir.
So whenever there is a fistula is there, only you should address that at the end of the procedure. Okay. Now we have cleared the disease around the stapes. We have created good flaps. Everything is over. Now I don't like this irregular ridge here. Okay.
Yes.
I'll remove that. See, like this, if you drill, you can completely expose the sinus tympani without any problem. Huh?
Yeah.
Because most of the people, they say that disease in the cholestoma or anything cannot be removed in the sinus tympani, which is the cause for the recurrence. That is not true.
Yeah.
But you should know how to remove it.
Actually, more so is by the endoscopic guys. They always say you use an endoscope, without that you cannot remove. But since we are dissecting it nicely, it is not very difficult.
Not at all difficult. Even I can drill the floor of the sinus tympani.
Right.
Just for the demonstration purpose, I'm going to expose the whole sinus tympani. Okay.
Yeah.
Even of course, there is some polypid mucosa there. See there? And only thing you should know where the fascia nerve is there. Huh? People are scared to do this because they think the fascia nerve will come here. No, it will not come there. Huh? Pattern ball. Bada, 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 bada. So now I'll show whole sinus tympani, how one can expose. Huh? Till the head of the patient. Give me cotton ball. Small cotton ball. See, this is the sinus tympani. That is the pyramidalis process, okay? Below this is the sinus tympani. Can you see that? The whole sinus tympani is exposed here. What is that problem now? Absolutely, there's no problem to clear the disease in the sinus tympani. Is this point clear? Hello?
Yes, sir.
See, so nicely you can see the whole sinus
Right.
tympani. Huh?
Correct,
Where is the
sir.
question of leaving the disease here? Huh? Nothing. Huh?
Right.
So this is how one can easily clear the disease from the sinus tympani without any problem. I didn't practice. Now almost my disease clearance is over. The only thing I didn't practice. Ready? Now I had to remove this matrix over the suspected fistula. Is it clear? Any doubts now? Hello?
Yes, sir.
Yes, sir.
You have been removing all the fistula.
Everything we are see. Can you see the facial blood vessel there? That is the horizontal segment of the face now. You can see nicely the facial blood vessel. And you have seen how I cleared the disease over the stapes all around. Stapes is freely mobile. I cleared the disease in the sinus tympani. I polished the cavity. I removed the antibuttress, postbuttress, sinus lung. Everything is clear. Now, lastly, I have to clear the disease around the. Look at my cavity. How nice it is looking. So it should be smooth and uniform like this, except that part of the cholestoma matrix over the dome of the lateral hemisphere. There is a bony projection is there. I have to see. Wash. Vinay, some bony projection is there of this lateral hemisphere. CT scan nodu. So almost now we are ready to clear the disease around the cholestoma matrix around the. This has to be tackled at the end of the procedure, my dear friends. Okay. Why means, see, the moment I remove that fistula, okay, the matrix over the fistula, immediately it should be sealed with the temporis fascia and the periosteum. Okay. No, well, that is the reason thoroughly I am washing it. That you should do it at the end of the procedure, just before placing the graft. Is it clear? That's what I am doing.
And sir, suppose if it is opened at the beginning of the procedure while clearing the cholesteatoma, then can we seal it with a gel form or something like surgery seal?
No, what happens, suppose if you encounter that, the membranous labyrinth will get ruptured.
Exposed. Yeah,
The
that's
beginning,
why the
that
consent
is what
for
happens blindly if you elevate the matrix without knowing that there is a fistula.
Yes.
Okay, that can happen. See, now why I retain that matrix is I know that something is there.
Right.
Blue line or something. That is the reason I retained it. Huh?
True,
Suppose
sir.
if you encounter such problem, if you elevate it, what you have to do is plug that with a small periosteum.
Yeah.
If the membranous labyrinth is also open, suppose the membranous labyrinth is not open, what you have to do is you keep a periosteum, the temporis fascia and periosteum, and throughout the procedure you have to retain that and do the procedure with very difficulty, because whenever you irrigate that keeps floating, you have to protect the membranous labyrinth and do it. Okay.
Exactly, sir.
And also one more important thing is, whenever the cholestoma matrix is plastered over the semicircular canal, always you should suspect there may be a fistula underneath that and remove it. Okay.
And so that should be tackled at the end of the
End of the procedure. Now I am going to tackle that end of the procedure.
Right.
We have kept the crushed periosteum in hand. Idella.
Yes, sir.
Yeah, that also you can do it. So now I'll show you how to remove the matrix. First, what you have to do is you have to elevate the matrix 360 degrees. That island of matrix, what I have retained, one minute. Can you see that how I have elevated it all around 360 degrees? Huh?
Awesome.
Now go to higher magnification. Under slow constant irrigation, some bony projection is there. Yeah. Just millimeter by millimeter, you keep elevating it. See that? Multiple. Okay. See, can you see the blue line is coming into the view? Hello? Hello?
Blue line is visible, sir. Right, sir.
Yeah, yes, sir. Yes, sir. We are seeing the blue line.
See how I am removing the matrix. See, beautifully it came out. See, so beautifully it came out. Hello?
Yes, sir. Yeah, we are seeing, sir.
See, beautifully I removed that, huh?
Yes, sir. Yes,
Intact.
sir.
This is the beauty of the surgery, huh? See, now I'll touch the stapes. You see the mobility of this membranous labyrinth. Can you see that?
Yes, yes, sir. Yes, sir.
See, nicely it is moving, huh?
Yes, sir.
Focus illale. Okay. You know, shake. Why it is shaking? Why shaking is there? Now once again you see that?
Yes, we are seeing nicely, sir. Yeah.
Beautifully you can see that it is totally intact. That's all.
Yes.
Okay. So
Yes,
now
sir.
you know why I removed that end of the procedure. So immediately what I do, this is
Cover it
again
with
Vijayendra's technique. Huh? People
Yes.
say you put bone dust and all. See, this membranous labyrinth is such a delicate thing. If you touch it, bursts. If you put a bone dust and press it, it will burst open. Okay. The best
Okay.
way is this I've been doing from 30 years, no problem. Patient will not have any, this patient post-operatively will never have any giddiness. And hearing also will be better. This acts as the third window and hearing will also be better. So this is how I cover. See, now I covered, through that also I can see the membranous labyrinth there inside. Now again,
Yeah.
when I touch, I can show you how it moves. Give me a smooth cut pick. Look at here. You can see the mobility there, okay? Not that very clear because I sealed it.
Yes,
Now,
sir. Yes.
again, with this, I'm not happy. I'm going to seal it with another layer of periosteum. This is a crushed periosteum. All these things, we keep things ready. Sangeeta has already kept it ready. Okay? This is how fistula should be tackled
Close.
without damaging the membranous labyrinth and to give a good hearing. Okay? So everything I demonstrated very clearly, when to tackle, how to create the island of bone around the this thing fistula, and when you have to do it at the end of the procedure, you have to tackle it. So again, one more layer of periosteum, we keep it like this. They will not have any problem. Even post-operatively also, these patients will not have any problem. And again, soft tissue will come here. We are going to obliterate this area with the soft tissue. Show me the soft tissue, Kodi. So this much of protection will be there for the fistula. Okay?
Yes, sir. Yes, sir.
So this is a very nice case of fistula. We got it. So many times I have demonstrated this. Now this is the postocular soft tissue. Always I keep it to obliterate the supralabyrinthine area. Otherwise, what happens? The supralabyrinthine area, if you don't obliterate like this post-operatively, there will be a retraction pocket will occur here. So always I do that. Okay. Now, primary ossicular reconstruction, I take a subtex per cartilage preserved in 70% alcohol, and this is our my own way of doing ossiculoplasty. This we have been doing for past 30 years without any problem. This everyone knows about it. Only thing is how to sculpture is the beautiful technique here.
This is per cartilage.
Yeah, this is a very nice material and it's very thick. It will be like a silastic block. You can nicely sculpture into whatever shape and size you want. Okay.
Yes, sir.
Now look at this. How I'm going to sculpture this cartilage. Always you take 11 number blade for this. Huh?
Sir, yes.
See how I am making it round and uniform. Huh?
Yes, yes, sir.
This is the 11 number blade. I can make it. So for everything there is answer in ear surgery. Okay.
Yes,
Only
sir.
thing you should plan your surgery properly, and the technique what I am doing, this is all long time tested technique. I stick on to only this technique. Okay. Some
Yes, sir.
new techniques and all, that is all not time tested. Okay. They do it. But these things we have a follow up of more than 30 years without any problem, without any regrets. So
Yes, sir.
this is how all cases we tackle. So whatever cholesterol is there, without any problem, we can remove it. And only thing you should know how to remove, when to remove, and all. So here I very clearly demonstrated. First, I clear the disease around the stapes, huh?
Yes,
and
sir.
then I retain the matrix around the fistula.
Fistula.
I completely clear the disease. and thoroughly wash the cavity. Why I thoroughly wash the cavity is, once if you open the fistula, you cannot do washing. To do washing, that itself will rupture the membranous labyrinth. Okay. So that is the reason how I planned. That is, everything is very, very important. Now I am making this a 0.5 mm cutting burr tip. This is a dental burr tip. Now I am going to make a facet for the head of the stay piece.
Yes, sir. Yes.
ಬೇರೆ ಕಡೆ ಕಟ್ ಮಾಡ್ತಾ ಇದ್ದೇನೆ ಇಲ್ವಾ? ಜೆಂಟ್ಲಿ ತಗೊಳಮ್ಮ ಬೇರೆ. ಸ್ವಲ್ಪ ನೈಫ್ ಕೊಡಿ. See, with this technique, with my experience, almost we give 100% result for the cholesteatoma cases. People say recurs and all. Imagine if you do like this, where is there not given any room for any recurrence? Only thing, you have to completely clear the disease, follow the principle of canal wall down procedure, and also will not have cavity problem. So now
Yes, sir.
I show the next step is, we'll show how we obliterate the cavity and how we do meatoplasty. That is also very, very important.
Important. Yes, sir. Yes.
See how nicely I made a facet for the head of the stay piece. Is it clear?
Dr. Vijendra sir, this assembly I have started using since last 4 years after seeing you, and it is most satisfying, so stable assembly without any cost. I mean, many a times I have not used the preserved one. I took from a septum and immediately I put it.
Yeah,
But,
that also I can do it. No problem.
I have done that way, sir, because and the results were very good. Only thing about the cavity, I again go with Dr. Mahadevayya's study. Keep it wide open, let it drain properly, do a proper meatoplasty. He used to say, you are to guarantee a dry ear first, because he is sick of discharge. So whatever you do, he should not come back to you for the discharging ear. And rest, everything is bonus. That is what he used to do.
Now I made a groove for the stapedial tendon.
Yeah.
So my stapedial tendon will get locked.
Yes. Additional stability.
Yeah, it nicely. I'll show you how we lock this cartilage. Huh?
Yeah. Sir, I have moderated your this surgery couple of times, so I learned it much better than what I have learned earlier. So,
oh, good. Thank you. I'm very happy.
Yeah.
So now everything is over. Now we'll put the graft. Huh?
Yes.
And also, because the midlia mucosa we have manipulated so much, we will put a gel film. Huh?
Yes.
Give me gel film dry. Soft tissue alligator force kudi. This soft tissue will keep it later. Billy, paragilla. Gel film kudi. Smooth cut pick kudi. Some blood clots are there around the tape is. Remove that, okay? That's it. Clear. Huh? Now I hand over to Sangeeta. She will demonstrate how to place the graft and how to do meatoplasty and how to obliterate the cavity. Okay. So this was a very nice, interesting case.
Yeah,
I think
sir,
I
just one
demonstrated.
question. Just
Pardon?
one question. One question. If one
Yeah.
don't get the gel film, what can
Ah.
be the substitute for that?
Substitute for that, you have to keep a silastic sheet. If you keep a
Yeah.
silastic sheet, you have to remove it. Because if you don't remove the silastic sheet, I used to keep in the beginning, all the
Yeah.
silastic sheet, it migrates out. Silastic
Okay.
sheet comes in a different thickness. That
Yeah.
is 0.5 mm, 0.005, 0005. Thin silastic sheet you can keep. That remains. But still, I have seen the silastic sheet, two things. One is
Yeah.
it acts as a foreign body reaction, and after
Yeah.
some time, it forms lot of granulation tissue. And then, even if the tympanic membrane has taken well, because of this foreign body reaction, it will give way and it creates a perforation. Second thing
Yeah.
is, it sometimes, even without infection, I have seen this, it somehow pierces through the tympanic membrane and migrates out. Because of
Yeah.
this mid-layer pressure and air pressure, the silastic sheet will be pushed away from this and it will make a perforation and it will come out. All these things I have seen in the past. So
Yeah.
this gel film is an excellent material. It has got a this thing. What will happen? It will help for fast epithelialization. That is the main function. And second
Yes.
function is it prevents additions and it
Yes.
stays for nearly 6 to 8 weeks. So by that time, up to 3 months it stays. And by that time, the mid-layer mucosa will become normal. All these cases which we do with the gel film, they do
Mhm.
extremely well. We don't see any additions at all in these cases. That is the
Okay.
advantage. And only availability is the main problem. I
Yeah.
get this from America. One of my friend is there, is anesthetist. He will somehow manage to get this for me from last 20 years. He is getting it from me from America.
Yeah. So, and so there is no suitable substitute for that, if I say that way.
As far as my knowledge goes.
Yeah. Okay, sir. Thank you very much.
Now we see always when we want to do see this is a gel film.
Yeah. I have
This
seen,
is a
sir. You
gel.
have shown it before also.
Yeah. See the gel film, we have made a slit for it will go into the incision tube orifice.
Right.
So like that you have to make it.
Sir, did you try that gel foam, which is we make it compress and very thin, and then we can put it? Is it going to help, or that again induces granulation?
Gel foam will not form. That will also get absorbed, but
yeah,
it doesn't prevent additions. Gel foam. This prevents addition.
Yeah, that is definitely there. It has an advantage.
The main purpose of keeping this is now the mid-layer mucosa is a raw mid-layer mucosa. It is not a healthy. If the mid-layer mucosa is healthy, I would have not kept this. Because it is a raw mid-layer mucosa, when you keep this, when it come in contact with the temporalis fascia, then the all the possibilities that it can cause additions. And also then the mobility will be restricted and so many things, and the hearing results will not be good. So many things can happen. And see, look at the graft. See, such a wide graft Sangeeta has harvested. She is a specialist in taking graft. Even I cannot take like this. So, and now see that anteriorly elevated the annulus. Okay. Now we are placing the graft over the bone. Because I elevated the anterior annulus and the skin, anterior canal wall skin, almost about 8 to 10 millimeters lateral to the annulus. The reason is now the graft is nicely sitting over the bone. This is the secret. You have to place the graft directly over the bone and reflect back the tympanomeatal flap, so that will get anchored there. So then there will be no perforation. Sometimes what happens, we see in the revision cases, there will be a residual perforation around the incision tube orifice or anteriorly. Because why means the graft would have been not placed over the bone, the graft will fall down and that will give a perforation. That is a very common thing which we see in most of the post-operative cases, anterior perforation. is mainly because of the improper placement of the graft. See, now our graft is sitting nicely over the bone anteriorly, almost 360 degrees it is sitting. That is the reason I elevated the annulus, and then now I'm pushing back the skin back its annulus to its original position. Okay?
Right. Yes.
This is a very, very important point to be noted. And also we take a very wide graft. The reason is, look at the graft, which is completely covering the bone all over. See, look at that inferior posterior buttress area. The whole posterior buttress area is completely draped with the temporis fascia. So whenever you do grafting, no, you should never ever expose any bone. Bone should not be exposed and left. If you expose the bone and leave, what will happen? That bone will not heal. That forms granulation. Post-operatively, patient will be coming for repeatedly. They'll be coming because of the granulation. And so many times, my own cases, I have done skin grafting because it will not heal. Okay.
Yeah.
So that is the reason you should not.
Sir, some of the revision cases where this granulation tissue was totally denuded the middle ear mucosa and they left the bone as such exposed. And in revision, we again find lot of granulation. Is it because the bone was left open without a mucosa?
Yes, that is the reason. That is the reason. Even also, most of the cases we give vinegar drops. This vinegar will help further to regress the granulation tissue. Vinegar is nothing but acetic acid.
Right.
So regularly in all my cases of canal wall down procedure, after 1.5 months, we give vinegar drop for 1 month. So the main reason
drops are available now. Many companies are manufacturing that. So that's the good thing. Yeah.
Yeah, acetic acid, many companies are manufacturing.
Yes.
So you can use that liberally. That prevents granulation. See now.
Yeah. Okay. Thank you, sir. So nice of you. You have demonstrated such a nice case as usual. And it's a feast whenever I'm with you in any of your surgery, and love to be there.
So you are in a hurry to go home?
No.
Because you're telling bye. Okay. Others will watch.
Yeah.
See now you see the antecanal skin again. See how we are elevating this skin. And the main idea is she is tucking the graft over the bone.
Yeah.
See so much of skin we are elevated. Now look at that skin will go back to its original position. And the graft is sitting directly over the bone. That graft is nicely sandwiched between this tympanomeatal flaps and annulus and the bone. So then there is no way it can fall down. And also see the midlear space is nicely created because the graft is sitting over that platform of bone which are created anteriorly.
Yes.
No only you can see a good midlear space.
Yeah.
Now you have to keep a gel foam and then see to that, press it, bring the annulus to its original position. That is the most important thing. You are tucking the thing so that the annulus will go back to its original position.
Yes.
ನೀವು ಮಾತಾಡ್ರಿ ತಗೊಳ್ರಿ ಈಗ ಮೈಕ್ ಕೊಡಪ್ಪ use this mic, madam. Okay.
So the flap is nicely secured and the graft is sandwiched between the flaps and the bone.
Yeah.
After securing anteriorly, now you can elevate the flap. And now fill the middle ear with gel foam. and push it anteriorly up to the eustachian tube orifice. This gel foam, you usually place it after placing the graft, because initially before placing the graft, if you place it, it will be very difficult for you to place the graft. So always it is better to place the graft and then fill the middle ear with the gel foam. This acts like a bed.
But the cavity is so crystal clear, everything is clear, okay?
Suck. Cartilage.
Yeah, all of you watch how it is going to be locked. See that slit which I made will go along the separated tendon, and all of you watch slowly, Madi.
Yeah.
Hello, can you watch that? Keep watching how Sangeeta is going to lock that over the head of the stapes.
Yeah.
It will get stretched.
Sir, it's narrow. It's not going. Actually, this. No, sir. So the socket is a little.
You have to make a wide socket because the head of the stapes is
head of the stapes is little wider. Can you see that? That's why that it is not going and sitting. So you have to widen this. Sometimes it happens. Okay.
Yeah.
Inside, sir.
We are changing the battery. 1 minute. The battery of the camera we are going to change. It takes another 1 minute. Please bear with us.
Yeah. Yeah.
Did you see?
Yeah, it's
Hello?
yeah, it's
See, nice,
perfectly fitting now. Yeah.
see, nicely it is locked. See how it is dancing there?
Yeah.
Can you see that?
Yeah, yeah.
See the rounded reflex here?
Yeah.
Can you see the rounded reflex?
Yeah, yeah.
Hello? See here.
Yeah. Here, yeah.
Whole thing is moving. That whole polypid mucosa is moving. Okay?
Yeah.
So
Yes.
nicely it is locked here. That's it. Huh? So this is some minor adjustment I had to do it because the head of the stapes was little wider. So what I did, I widened that facet vortex. That's all. Huh?
Yeah.
So it is like a carpentry work.
That facet should snugly fit into that.
Yeah, it is nicely fitting down. And also see that groove I made for the stapedial tendon. So it gets locked there. Huh?
Right. So it
And
cannot
this-
move around. Yeah.
Yeah, this patient will have a very good hearing because already there is a fistula is also there that acts as a third window.
Yeah.
I have seen these patients will have a very good hearing.
Yeah.
So this is what we call as a myringo-stapedopexy procedure.
Yeah.
And also height is a little perfectly. The height should be almost up to the dome of the lateral semicircular.
Yeah.
So height is also perfect here. Now once if we reflect back the tip, that temple is fascia, we can see the height very clearly.
Yeah.
Will tell some.
Yeah. Excellent, sir.
So now it is almost, you can see the cartilage.
Yeah.
Delphum.
Now you can see the shadow of the cartilage there. Can you see that?
Yes, yes.
Upper end of the cartilage, touch that Sangeeta.
Yes.
See, that is the cartilage. Nicely it is sitting, okay?
Yes, sir.
And also it should be little away from the dome of the lateral semicircular. Sometimes if it is closer to this, post-operatively, we have seen that it will come and lean over the posterior rim and thereby restricts the mobility. That's why always we keep that away from the annulus or the posterior rim. Huh?
Right.
All these small things are very, very useful. That's
Yes.
Actually, she kept it. She didn't show that. That doesn't matter.
Yeah.
Now, the next most important thing is it like another 10 minutes. So all of you watch how we obliterate the cavity and how we do meatoplasty. Both are very important steps. In a
Yes.
canal wall down procedure, that is also equally important to achieve a cavity-free problem. So we will not get any cavity. And also we don't do a very wide meatoplasty. In this case, not necessary because my cavity will be very, very small.
Yes.
So even nowadays, we don't do wide meatoplasty. As Shambo used to say, rule of thumb, where your thumb should go inside.
Yeah.
So gone are the days. So those days are gone. Okay. Now we give a very small meatoplasty, almost like a normal, particularly if a patient needs a hearing aid post-operatively, if they got a severe sensory loss, where post-operatively they need a hearing aid, for them I give a very normal meatal opening
so they can comfortably use the hearing aid without any problem. Okay.
Right. Yes.
The main thing is, if you obliterate the cavity, if you don't have cavity, why they used to do meatoplasty? Because there used to be a very big cavity. So to clearance of the cavity, wide meatoplasty was done. When you don't have a cavity, where is the question of meatoplasty? There's no question of meatoplasty. You follow?
Yes. Yes, sir.
So that's why we don't do a wide meatoplasty. Now,
Yeah.
Sangeeta will show how to do meatoplasty now.
So this is the 12 o'clock and the 6 o'clock incision. Take an incision exactly at the midpoint of both the 6 o'clock and the 12 o'clock, that is at the 9 o'clock position, and make a stab incision so that you come posteriorly. Now this part, you need to lengthen the posterior meatal skin flap all along the length of your posterior meatal skin flap, thus creating a superior and a inferior flap.
Yes.
Now you palpate the level of the cartilage here, palpate the level of the cartilage and make a T-shaped incision so that you don't cut, taking care that you don't cut the cartilage through and through. I'm feeling the cartilage now. Just a few millimeters of the cartilage here, you can see the cartilage here. Now you remove this cartilage. Cartilage is called. And now take another parallel incision 2 millimeters inferior to the level of the cartilage which is here. Take an incision 2 millimeters below that so that this skin can be used to reflect and suture onto the soft tissue. In the process, you are completely covering the cartilage, thus preventing perichondritis. Hold. Here, as you can see, the soft tissue is a little more.
Connect to the.
Through. This is your superior flap. This is your inferior flap. Cut to the base, and the most important part of a meatoplasty is removal of the floor cartilage. If you don't remove the floor cartilage, the cartilage on the floor, that will prevent the auto cleaning mechanism of the cavity. So here, as you can see, if you don't remove this floor cartilage, this hump will cause accumulation in the cavity. Now you need to incise and separate the inferior flap from the cartilage all along the length of the skin here. Let's go. You can see this cartilage also at times can be used to culture a ossiculoplasty, because at times this cartilage itself is so thick, as you can see here. On, 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 Again, as you can see, there's another piece of cartilage which is here. Yes, sir. Yes, sir. Yes, sir. Again, in spite of removing that cartilage, there's another big piece which is still there. So I'm removing this cartilage, and then later you can break the spring action.
This is a very important step in metaplasty is if you don't remove this floor cartilage, your metaplasty will not be success. What happens, this floor cartilage, if you don't remove, it will form a hump, and post-operatively, this itself will cause a cavity problem. So always we have to remove this cartilage, and this cartilage will be so thick, at times even you can use it for the ossiculoplasty. So look at this, once this cartilage has been removed, how this inferior metal skin flap is flaring out like this. If you are not removed that there will be a hump. That hump will again form a cavity problem. That will not allow this the posterior part to be visualized. So this is very, very important is in metaplasty, you have to remove this floor cartilage and see to that the skin will flare up posteriorly and superiorly and inferiorly. Yeah, continue.
Now, as I earlier mentioned, this part of the skin, I'm taking a bite and another bite above so that the cartilage is completely covered with the skin here and thus preventing perichondritis.
You should never leave the cartilage exposed. That is the most important point. This is also very, very important. So we are left about 5 to 5 millimeters of skin, and that you will evertate and bury the cartilage. So the cartilage should not be exposed. So usually we put 3 switches. Everything is very, very important.
Now the gauze which I have kept here, that is in case there is bleeding, it will protect the underlying graft. On. So now slowly remove this gauze that you've kept there. And now this soft tissue which you have initially released, now this will go fall into the cavity, thus obliterating the cavity. As you can see, it's nicely obliterated the whole cavity. And this skin will come here. Now the superior flap, you take a bite and suture it to the temporalis muscle.
Yeah, it is
And the inferior flap, suture it to the soft tissue here.
Pull that and Centering. See, now you see the cavity once again. Look at that
This
soft
is the
tissue.
superior flap, which will come here.
A muzzle torsion.
And
So,
this is the-
slow, go to lower magnification.
So this is the lowest.
See, now look at the cavity. See, this is a highly vascular flap. So
Yes.
almost whole cavity is completely occluded with this. So our cavity post-optically, if you see only that much, where you are seeing the gel form, and also see the skin, how it is lining it. So this almost more than 50% of this soft tissue is lined by the skin. And this will be a size of the cavity post-optically. Friends, you believe it or not, I never get cavity problems. Very rarely we get cavity problem. Why we get cavity problem? At times, this post-ocular soft tissue, if it get necrose, we get cavity problem. Otherwise, all my cavities, if you see like this, you cannot make out that we have done a canal wall door procedure. That is a perfection we are achieved at the end of 30 years. And we are very happy the canal wall door procedure. People simply all over the world keep talking about the cavity problem, cavity problem, cavity problem. So according to my experience, we don't have any cavity problem at all if you do like this. Again, I'll tell you, if you follow the principles, that is a wide saucerization, and then you remove the anterior buttress, remove the posterior buttress, and remove the most important thing is you have to reduce the ridge and see to this the mastoid bowel and the external canal should be at the same level. And if you put soft tissue like this, there will be no question of any cavity problem. So with this, we conclude the day's program. We sincerely thank the Microlab Heroes branch, particularly the Vice President. Yesterday, he had come all over from Mumbai. Thank you very much, sir, for this great arrangement. And also, I thank Ram Kumar and also all other Microlab people who have done a wonderful job. And they were so keen. From 1 month, they're working on this program. And it was a successful program. Hope all the delegates have enjoyed the surgeries from morning. All the surgeries went on very well. And I once again thank everyone. And also I thank our anesthetists, Dr. Narsimurthy and Dr. Vinay. They have been here from afternoon. And also Dr. Nilesh is working very hard for this audiovisual things. And for Vinay, who demonstrated nicely the sapidectomy procedure. And all of our staff members over here. Thank you, one and all. Thank you very much.
Sir, thank you for giving me an opportunity to moderate your session, which is always a pleasure.
Yeah, thank you very much, sir. Dr.
you, sir.
Manjula
Thank you.
here from Micro.
Manjula, sorry, I forget to
Sir, I want to tell
Manjula.
you,
She
it
is
is
the
really
main person behind this.
No, sir,
Sorry,
no,
Manjula, I forgot
Yes, sir.
to mention your
I
name.
want to tell you, sir, there were 760 people continuously viewing, and also plus we had live streaming happened at 25 Medical College. Nearly more than 500, 600 PGs were watching, and it has been really a great experience for them, sir. They've been sending us a lot of appreciation through the mail and chat box. Thank you so much, sir. It was really
All the
wonderful,
credit
sir.
goes to Microlab people for wonderful arrangements on this teaching program. So many people are benefited with this. I wish and I love all the people, youngsters who have seen this. They should follow my technique and you will not have any problem. So one more important thing is learn one technique in ear surgery, master the technique, keep on doing the same thing. Don't keep on jumping. And if you see 100 surgeons will do 100 things. Everything looks nice. So we have got a 30 years follow-up and my results are excellent results. So you stick on to one procedure and do it and you'll get good results. I'll be very happy when I see my students doing a good job. We feel so happy. One of my students is here watching, Suresh. He is doing a wonderful job. He has been watching my surgery from 15 years. He is doing only my procedures and he is doing extremely well. Suresh is here. Come, Suresh. So he is from Chennai. He has come all the way to watch, and he is one of my students. I feel so proud when they send all their videos post-operative. So that is the most happiest thing for me when our students do a good job. Thank you. This is a good platform micro people are giving to impart my knowledge to all the budding ENT surgeons. Thank you very much.
Thank you so much, sir.
Thank you so much, sir.
Thank you.
And thank you all today. It was an excellent
Dr.
session.
Yeah,
In fact,
Dr. Prakash sir and Dr. Ilambarti, excellent
Ilambarti
moderator.
sir.
Thank you, sir. Both of
Thank
you.
you very much.
Sir, excellent
Actually,
demonstration, Vijayendra sir. Thank you,
I
sir.
thanks to the micro people, and more than that, Dr. Vijayendra always somehow gets me involved, and that's it. I mean, it's a privilege to me. And watching and moderating his surgery, he is a guru. His guru was also my guru. So,
Bye.
Thank you.
Bye, sir. Thank you. Namaste
Bye.
once
Thank
again.
you.
Bye,
Thank you,
sir.
one and all.
Thank you, sir. Thank you, sir. So, good evening, everyone, and really thankful to all of you for logging in and staying with us. I just quickly close the day with what is in store for us on day two. Day two, we have really exciting scientific session. We have 3 panel discussion, which is of very, very practical importance. One is strips and pearls of otology. Then we have headache and facial pain. And number 3 is sleep and the snoring effect disorder. So we have Dr. Jaiprakash Reddy for tips and pearls of otology, Dr. Mukherjee for head and facial pain, and sleep and snoring disorder by Dr. Seema Sheikh. And tomorrow we are starting at 10 o'clock. Apart from that, I would also like to tell all of you on the platform you have 3 certification course which is ongoing instructional courses. One is on anaphylaxis by Dr. Gayatri Pandit, position maneuver in vertigo by Dr. Srinivas DR, and swallowing assistant by Dr. Manju Isaac. So please go on. It will be available anytime. You can log in and then complete this course, instructional session, and get yourself certified under all this. Thank you, sir, so very much for all of you. Have a good night and see you all tomorrow morning at 10 o'clock. Over to you, Mr. Durga Prasad.
thank you, madam. Thank you all. So we'll sign off today and we'll join by tomorrow morning 9:45.
Yeah.
Thank you so much, Dr. Krishna and Manjula madam, and thank you all behind the team.
Thanks, Dr. Krishna. Thanks,
And thank you,
everyone.
Neshpal
Bye,
team
bye.
and all our marketing team. Thank you so much.
Yeah. Bye. Thank you.
Arvind, I think you can